So you can see up here on top. You guys can. Yeah, like.
Yeah, so they can cut out lunch and they can cut out-
Yeah, so it's recording and you're golden.
Okay, great.
So just
Thank
know
you
that
so much,
you
Kate.
have to be on your best behavior, tell your friends, right? You've done.
She got
this.
lost finding in the room,
It's
but only for a minute.
because when
There's
she
a-
walked in, it's a.
There's sign-in
vortex.
sheets up here in
Misty.
case, so. So none of you were on the other one, huh?
Oh, I didn't know it was.
Yeah, this is just in case somebody isn't on the thing.
Good morning.
All right, so. So Maria. Victoria. Blackton, no.
Yeah, okay,
Um,
I didn't realize.
Yeah, no, the other sheet is just for the overflow. So there's a sign-in sheet up here. And use the one with the names on it. If your name isn't on it, then you use the overflow sheet. Morning, Bay, come on in. Oh, and while we're in the classroom, we don't have to wear our masks. We certainly can if we want. But when we go out into the hallways, out and about, we do have to wear them. Just sign a sheet in front. You go around this corner and then take a break.
Thank you.
Yeah. The three of you that just came in, once you get settled, there's a sign sheet up here. If your name isn't on the sheet, then you use the other floor sheet. We'll give people a little bit more time to get here.
Morning CIT class.
Yep, you're in the right place.
Thank you. Morning, everyone.
In fact, there's a sign-in sheet right there for you. If your name isn't on that sheet, you can sign this other one. Just make sure you print so I can. And actually, so while she's doing that. So you don't have to swipe in, just so you know, that having your name on the sign-in sheet so that I can read it. After the day is done, I go back over to Knott Street and I send an email to all of your managers that you were here. And also the reason I have you do that is, I mean, there is a place to swipe in here, but I know that the information says it goes from 8 to 4:30. I haven't gone to 4:30 in 12 years. And if the class is, stays about this size, I mean, sometimes I have a lot of people show up who weren't signed up, and I can have this enormous class that kind of makes it a challenge. But yeah, if it stays right about this size, this will be perfect. Most of the day, look at that here. Morning.
CIT training?
Yep. There's a sign-in sheet there on the table. If your name is not, I didn't use the other one. All right, well, why don't we get going? So welcome, everybody. Nice to meet you. I'm Steve Wood. Hello.
Hello, sorry.
Welcome to the CIT class, the Crisis Intervention Training. How many of you are new hires, like you just went through your new hire orientation last month? That's pretty much everybody, okay. So at this point, we're going to have to, all binders are occupied, so you'll have to find a seat in the middle and then share a binder with somebody.
Excuse me, you parked out back?
Yeah.
You have to move your car to the far, in the front to the parking lot.
Oh,
Okay, anybody else that parked in front of the building, you have to move it across the parking lot to the big parking lot. Because physical therapy gets us there. Here, I'll take it. On that.
all right. Yeah, between the dialysis and physical therapy, that they keep that for patients. So by virtue of you being here, this is the full responder course. So this is the highest level of training that LS Medicine offers for people to deal with, patients or people who are escalating, become disorderly or difficult or aggressive. We will embedded in all of this is so, and what we'll be going over is,
Sorry.
oh boy. Okay, so you weren't on this one?
No, it was, sorry, no, I'm right there.
You are in this one? So cross your name off of here.
I resigned.
You signed on this one, so.
Yep, right there.
Okay. So, okay, so as you're coming in, pick one of the seats in the middle and share a binder with someone. Good.
You can sit here.
Also, while we're in the classroom, you do not have to wear your mask. You certainly can, because it is kind of close quarters. When we are out and about in the hallways, the School of Nursing does want us to have our masks on out there, but in here we don't. So yeah, so we're talking about different considerations as far as what to be looking for, de-escalation, a lot of things that are involved in aggressive situations, a code gray, how a code gray is supposed to be run, the different roles, who does what, that sort of thing. We also will be going over a bunch of self-defense maneuvers and how to protect yourself, how to do a hold, an escort, a takedown, putting someone in 4 points, taking them out. So there's a lot of stuff to cover. I also want to say, because I know that, again, you just went through your new higher orientation. This is not a day of me doing PowerPoint and you just staring at the screen. It is not like that at all. Thank the Lord. All right. It's kind of old school. The binder is mine. We keep using that. The packet that you have here with the giant chill pill on it, that is yours. You can write in that, take it home with you.
I know.
What's that? Oh, the people in the middle will have it. That's right. The anatomy of the day, we're in here most of the day. At 10 o'clock, we take a break. We got to move around. Actually, for any of you, if you need to move around by all means. Who still needs to sign in? Did I give you one? After the break, then we'll go until about lunchtime. We take around, 45, 50 minutes for lunch, because it used to be we could do it quicker, but the cafeteria over at McClellan is closed. Because used to be just run over there, grab some, come back, but that's what anymore. After lunch, we will watch a video with regard to active shooter. And then we'll wrap up in the binder, and then that's when we go to into the nursing lab, and that's go over how to put somebody in 4 point restraints, take them out. Back in here, do the self-defense, and we're done. There is a quiz at the end of the day. It's a 25-question quiz. Because I have to. I have you take that all together, like you get in groups of 2 or 3. And what I found is more learning occurs if you actually, you sit and discuss the questions. I mean, no one has not gotten 100 in forever, because we're all talking, I mean, in small groups, we're all talking about the information, so you go over it and we end up, everyone gets the right answer. Plus, sometimes people, you know, as employees, English is like a second or third language, and they might have a decent command of the spoken word, but the written word, maybe not so much. So that way, when you're all just reading and discussing the questions together, it just helps everybody out. So. Bathrooms, if you go out this door and around the corner, they're just right down there. So if you need to use the restroom, by all means. Has everybody signed in so far? Also, the format, like I said, it's not a PowerPoint. It's actually pretty active. Also, again, it's not me just talking at you for the day. In a little bit, we're going to do introductions, and I'm sure that we're going to see that there's a lot of experience in this room. So as we're moving through the material, like I'm going to give you what you need to know about how Ellis operates in these kinds of situations. But if you have something that you've learned, you know, that pertains to whatever we're talking about, you know, just share it, because we can learn from each other too. So by all means, and I can speed up and slow down, like some of you did this, you know, having just come in. This doesn't, I know it says 8 to 4:30. I do not go all the way to 4:30. This is, you know, it's a good sized class, but I can speed up and slow down. So I don't want you to not participate or not share something that, you know, you have that could be helpful to everybody, because you don't want the day to get longer. So by all means, I can trim as we go. Any other questions so far? All right. So like I said, I do want to do introductions. So we're going to go around the room. We'll have to be kind of efficient. This is a lot of people. So let us know your name, what you do, if you're a tech, nurse, whatever, social worker, where you're working, like what unit you're on, what service line, and also what else have you done? Not just in healthcare. And the reason I have you say that is, this isn't like a cookie cutter thing. Like if somebody raises their hand to you, you do this, or somebody's loud, you do that. Every situation is different. So you're going to have your own style, and you're going to have your own experience. So if you were like a bartender or a server, you've dealt with drunk, unreasonable, obnoxious people, hopefully without slacking, right? Or say you worked in like Target at customer service. So you've got somebody in your face yelling at you, and you know they're lying to you, but you still have to be professional. All of that is useful information, because you're gonna need that, because you will, even if you're on a medical floor. And actually, we recently added the medical floors to get the full responder course, because violence happens there too. A lot of people think it's just, you know, at the emergency room, psychiatry and security, they need it. No. I mean, the medical floors used to get a half a day, and it just wasn't enough. You know, we want you to be safe. We want you to be able to run a code. We want you to be able to be, you know, part of the team, not just there's a code, somebody's tearing up, you know, A602, you know, call a code and let's run away. No, we need to have everybody be part of that team, so that we can, because you're going to know the patient best. So the other full responders who are coming to you, they're not going to know the patient. You're going to know the patient best. So let's have us all work as a team. So who you are, what you do, where you do it, your work history, real quick. And then a couple things about you that we would never know otherwise. You know, fun facts. You like to hike, you've traveled to 3 continents, you know, stuff like that. Model Pampers when you were 2, just something fun, because that stuff comes up during the course of the day. All right. you can use that. So, so why don't we get started? Why don't you start?
Hi, my name is Victoria. I'm working as a nurse on C6. Prior to working as a nurse, I worked in retail.
Okay.
I don't know.
Sure you do. What do you like to do when you're in your spare time?
I like going to the beach up in Long Island. I just moved to the area.
Oh, all right. Well, welcome. Did you go to school here? Okay. All right.
Hi, I'm Sarah. I'm an RN in the ICU. I worked in customer service at Home Depot prior to this, and I was a tutor. And a fun fact about me is I like to run half marathons with my best friend.
All right. Good for you. Go ahead.
My name is Angelica, but I prefer Angie. Prior to this, I worked for an ARC, and then during the pandemic, I went and I got my CDL, so I was in trucking. I went to school for nursing, and I really miss healthcare, so I came back to Alice on my free time. My husband and I like to do a lot of traveling. He's also a trucker, so.
All right. All right. What are you gonna be doing here?
Oh, I work for the Safe Street Mental Health, one of the coordinators.
Oh, okay.
I am Elsie. I'm working in the ICU, P1E2. I actually, interesting because I just came from the VA emergency room. So we do this PMBD class,
Yeah.
which is CIT every 4 months over there.
Mhm.
And I've dealt for 8 years, a lot of, you don't even know. A lot of PTSDs.
Yeah, yeah. So then,
So I've been there.
so jump in as we're doing this stuff.
Yeah.
What about fun facts for you?
Fun. I like to hike.
All right.
Love going to the lake. Yep, swimming,
All right.
camping.
Outdoor girl, huh? All right. Go ahead.
Hi, my name is Nazima and I just moved from Queens. I'm a PCT tech at Ellis and I work at A6. I love to watch TV and traveling and stuff.
I'm Maria. I'm an RN in the emergency room. Prior to being a nurse, I was a high school teacher in inner city Brooklyn.
Wow.
Fun facts about me. I hate introductions. But I like to exercise.
All right. Go ahead.
My name's Liz. I'm going to be a nurse on A4. Prior to working as a nurse, I worked as a dietitian and I also worked in a preschool. So it's my talk about temper tantrums. Fun fact about me is I like to knit.
Okay, cool.
I'm Jessica. I'm an RN in the emergency department. I previously was on A4 for a year. Before that, I was an LPN in long-term care and short-term rehab, and then before that, retail and data entry. Oh, and I was a CNA instructor at Job Corps.
Oh. All right. Yeah.
And
Fun
fun fact-
in Glenmont?
Yeah.
Yeah.
Fun fact, I played roller derby.
Roller derby. So we won't mess with you. Go ahead.
Hi, I'm Danielle. Sorry I'm late. I came from my other job, which is kind of a fun fact. I work in the jail. So we do this day in, day out.
Yeah.
Mental health part of it. So it's mental health and murders combined. I work my second full-time job is in the emergency department. So working in the pods there, takedowns, 4-point restraints. My background is critical care EMS. I did 12 years paramedics in New York City, where I'm from.
Wow.
You don't even need the street.
Yeah.
That's right. I'll just come up sit up here.
Yeah, so I've been doing it a long time, and I think just like the key to it is, I'm like standing up wise, I'm 5'1", and I think it's not about size, it's about reading people.
Exactly.
And I think that's key. People think you need to be big, but now not to brag, but I mean, I do 185 inmates on a daily basis, sometimes by myself with 2 officers. And that's where I just came from. We had 4 takedowns overnight.
So you've been up all night too?
Yeah. Yeah. I came to your class twice, but you had rescheduled, so they're like, you need to go, so I'm like, all right.
All right.
I'm Maura, I'm in the ER as an RN. I've been in her 16 years, just started at Ellis. And a fact about me is I'm in school full-time for pre-law.
Huh.
Working full-time.
So you don't sleep either.
What?
Doing forensic nursing?
No, I'm just
done.
taking pre-law, because I don't know what I want to do. I've been a nurse 16 years, but I don't know if I want to mix the two careers or, but it's
Yeah.
always been my dream career, so I'm just back at it.
All right,
It's just a fun fact.
cool.
So, my name's Maggie. I am a medical assistant at the mental health outpatient clinic on State Street. Before that, I worked as a medical assistant at a addiction medicine clinic in Waterford. Pretty basic. I like to go to the gym, I guess.
Okay.
My name's Mackenzie. I'm a business operations analyst for the mental health services line over on that street. Before I was at St. Mary's in Amsterdam, I was a financial counselor. I like to play in a lot of beer league softball leagues over the summer. Takes up a lot of my time.
I'm Johnny. I'm a security guard. Before being a security guard, I was a trainer. Fun fact about myself.
Very good.
My name is Greg. I'm a nurse on C3. I'm traveling, so my contract's 13 weeks. Prior to this, I worked in New York City, in Monmouth Hospital. My hobbies include home improvement and parking where not supposed to.
Is that your superpower?
Yes. I always find the reserved spaces.
Go ahead.
Hey, I'm James, ICU nurse. I've been a nurse for 6 years, just moved here from California. Prior to nursing, I've had so many jobs. I can't even remember all of them. I worked in schools, been a teacher assistant, after school instructor, took care of horses, decorated Christmas trees, you name it.
Oh my gosh, that's cool.
So I guess that's my fun fact.
Okay.
Yeah.
All right.
I'm Mike. I'm an MSW student. I'm an intern over at Pros at State Street.
Gotcha.
Prior to this, I was working in foster care. And fun fact, I've spent time working on a ranch and I've raised pigs. The farm that I ran, and I've learned it's always better to allow animals to make the choices you want them to make rather than to try to force them into making the choices for food. And I think some of that maybe applies to people.
Yeah,
Certainly does.
Children.
Especially children.
Certainly does.
Morning. I'm Sarah Zoom. I'm newly employed. Before that, I worked in South Africa, South Arabia. I like watching soccer.
All right. Very good.
Hi, I'm Lexi. I'm an MSW student also. I'm an intern at the psychiatric unit inpatient on Knott Street. Previously, I was a full-time substitute in a middle school. And I guess I like cooking.
All right.
I'm Rachel. I'm also an MSW student in 2008 and finished training at the Pros program on State Street. Outpatient. Prior to my student life, I was on legal secretary for over a decade in family law and a little bit of time in retail as well.
Cool.
Hi, I'm Melinda. I'm a coordinator at the mental health clinic. And prior, I I work in the nurse's office at high school. So dealt with a lot of like snot and diarrhea. And a fun fact about me is I'm about to start a Pilates instructor certification.
Oh, cool. All right, and I'll tuck myself in here at the end. So like I said, I'm Steve Wood. I've been in the crisis intervention and safety specialist position since 2016. We created it at that time because we could see that workplace violence and dealing with these kind of situations, we wanted to stay ahead of it because it was workplace violence in healthcare was clearly on the increase. So we created this position. Prior to that, I actually came to Ellis, we were actually recruited to come to Ellis back in 2008 when they had pulled together a group to try to one, revamp the crisis intervention program, but also the inpatient psych department because it was in pretty tough shape. So, you know, a group of us had worked really hard to try to, you know, turn the ship around. Prior to that, I had worked at Four Winds Saratoga. Remember that psych hospital in Saratoga?
Worked there over like 2 summers ago.
Oh.
In the children's,
And Caitlin with the little ones.
the little ones.
Yeah. So I worked there for 20 years. Like a number of you, I started as a tech and, you know, got my did my graduate work while I was a tech, and then I held just about every, you know, clinical position that they have up there. I'm also a psychodramatist. I don't know if that means maybe some of you masters folks, you know, when you're doing your group work, we're gonna hear about psychodrama, but it's a therapeutic modality, but you do things in action. So a lot of people think of therapy like, you know, 2 people, you know, sitting in an office talking with each other. Yes, that's true. That's CBT and some other kind of stuff, but it's an active modality so that you actually do things rather than just talk about them. So some of that's in here today. I also have a private practice. I've had that since 1996. And I actually did that briefly full-time between Four Winds and here. And like everyone else, did all kinds of things, bartending, roofing, whatever you need to do to pay the bills. Other professional things that are actually pertain to this. I'm also trained by the FBI for critical incident stress management. So in civilian life, that's for like EMS, firefighters, that kind of thing. Not so much for police. They have their own system now. But like if there's I live up Saratoga way. So if there's a local firehouse, volunteer fire department, they have a particularly brutal call, I'll go to the firehouse afterward and we'll debrief so that they don't end up with PTSD serving the community, you know, because they see a lot of rough stuff too. So some of that's in here today. Fun facts. I, like you, very much an outdoor person. I was on the K9 team for LASAR, which is Lower Adirondack Search and Rescue. You know, trained in Airedale for wilderness search and rescue. That was fun. My father and I had a fishing guide service for a lot of years. So whether it was stream or on the boat, you know, like to be on the water. So yeah, that's good enough. All right, so the binder. I am not going to be going page by page. Some of you will have to share, so play nice. And so, like I said, I'm going to be hitting the high points.
Yeah.
And everyone has a take-home packet, correct?
Yeah.
All right. So yes, I'm going to hit the pages that are the most important. You'll see once you get going, you know, I really enjoy this part of my job. So, you know, if you have a question or you want to make a statement, just jump in. Otherwise, I'll just keep, you know, put on my mouth. Also, when we hit the quiz question, I'll try to, you know, point that out to you. So I want you to jump to page 9, please. So why do we even have crisis intervention to begin with? And actually, the first part is a quiz question. We want to prevent, reduce, or eliminate restraint and seclusion as much as possible. here in our system, we want to do everything like Danielle, like Danielle was saying, we want to do everything you can to try to de-escalate a situation. The last thing we want to do is go hands-on and get physical with somebody. So we're gonna do everything we can to try to give you tools to use and to have a good response. The other thing that's important on this page is that acronym 2/3 the way down, team. Together, everyone achieves more. It's been around forever. It's older than dirt, and it's really, really important. We don't go hands-on. We always work as a team. We don't do solo takedowns, all right? Unless it's like absolutely necessary. If somebody is wildly assaulting somebody else, yes, we jump in and we grab that person. Otherwise, we wait till we have enough people and make a plan and work together. And that comes up a number of times during the course of the day. Page 10. Oh, the other thing is, you'll see that the material in the binders is somewhat dated. I am this close to having, actually, in the take-home packet, when I say that this page in the binder is in your take-home, you'll see that the page in the take-home is different than the one in the binder, because the take-home is the new material. All right, so anyway, page 10 is in your take-home, and so I know it's written there, but the first topic is, what are some, and nurses, this is in your wheelhouse, what are some physical or medical conditions that can lead to someone becoming aggressive or out of control or disruptive? Medical conditions. Yeah.
You get the elderly with UTI and they are sundowning and
A lot of, this is
something simple.
right off the top. A lot of people don't know about that unless you're in the medical field. But yes, with the elderly, with the aging brain and between the infection and the lack of oxygen, they get a UTI, but it can cause altered mental status, delusions, aggression. So, and you get that 86-year-old woman with a UTI, man, those nails come out, and you just gotta watch yourself because that's dangerous.
She actually had a patient yesterday that came in for, she thought she had a UTI, but it was, so we worked her up. And literally it was not, and then at the end of it, it ended up being a crisis intervention. We were like, because it was a complete opposite of what we thought. We thought we were gonna treat her medically, but it ended up going psychological.
Huh, all right. Other things, what are some other medical or physical conditions that can lead someone to become aggressive?
I see concussion leads to some really aggressive behavior.
Concussions or TBI. Yeah. Hunger. Or hangry. Pain, like acute pain or chronic pain.
We see the long wait times set people off just because they're frustrated.
Right. That's what that would be like an environmental factor.
Yeah.
All right, so those are some of the medical ones. And then there's the whole psych arena. So we're gonna spend a little bit of time on this because some of you have, and interns out there, you can help me with this because you're studying it right now. But no matter where you're working, whether it's medical floor, emergency room, ICU, you will be dealing with people with mental health issues. In fact, the chronically mentally ill are notorious for not taking care of themselves physically. They won't take they won't manage their diabetes very well, or they'll get a cold and they'll go to pneumonia and they don't really take care of themselves. So we're gonna spend a little bit of time on this. So, what would you say are some of the most common psych disorders that we're gonna have to deal with? Bipolar. Oh, by the way, my handwriting is horrible. The squiggle will look kind of like what the word is supposed to be, but we'll get there. So bipolar, what else?
PTSD.
Borderline, oh, yeah. So I'm pretty sure everybody here, when you went through nursing school or whatever, you were trained in the DSM-5, correct? In the DSM-5, they changed, the DSM is the Diagnostic Statistical Manual, and it's like a a big catalog of all the psych disorders and what they look like, the symptoms and all that, okay? In the DSM-5 or the 5th edition, they changed how we organize psych disorders. It's primary diagnosis and then secondary diagnosis. Prior to that, and I wish they had kept the old format because it gave you a really standardized snapshot of what that's going on with that person. So there was axis 1. Axis 1 were the clinical disorders, all right? So everything you're saying here. Axis 2 were the personality disorders. So somebody just said borderline, right? So borderline personality is a personality disorder, not based in chemistry. All right, and we'll get to the fact. Don't let me forget to talk about borderline because sometimes I get going and I forget that. So let's do the so axis 3 would be medical. So that's where if somebody comes in, they present with some psychotic features, but it's a UTI. That would be here, the medical. Axis 4 were psychosocial factors. So wait times, more like somebody got cheated on, they lost a job, they're being evicted. Major life events could lead to someone becoming aggressive. They don't have any medical problems, already psych issues, but major life disruption, now they're going into crisis. And axis 5 was the global assessment of functioning. It was a scale from 1 to 100. 1, you're dead, and 100, you're Jesus. So it's somewhere in between. All right. So back to the disorders. So you're on a roll. Bipolars, PTSD, schizophrenia. What are some other ones?
Substance use disorder.
Big time. Substance abuse. That's a big umbrella. Under there is OCD, panic disorders, generalized anxiety disorder, all that arena. There's some other biggies out there.
Suicidal ideation.
That's a symptom, and that could occur in a lot of these. Yep. Intellectual disabilities is the term that replaced mental retardation. So that's like a spectrum, like mild, moderate, severe. Same with autistic spectrum disorder. That in a DSM-5, again, they restructured that and they made all of autism the autistic spectrum disorder. In fact, a lot of people still use the term Asperger's, which is like mild autism. That's really not a disorder anymore. That's not part of it. We just use this, and actually that one, not like the American Psychiatric Association cares what I think. I'm glad they did that because, well, before that, it wasn't considered a mental health disorder or mental health issue. So all the families who struggled with, who had a family member with autism, they couldn't bill insurance.
Yeah.
So they were out there struggling, trying to get, the Office of OPWDD and the developmental disorder state services. That system is completely overwhelmed. So they were really struggling to have get services for their autistic family member. Now they can. We've hit a lot of the biggies. Also, when it comes to kids, in DSM, they added disruptive mood dysregulation disorder. And actually, that's an interesting one because oppositional defiant disorder is pretty much like it says. The kid is oppositional defiant. And if you say, go outside and play, no. Well, then you better stay in here and watch TV. No, I'm going to go outside. Because that's what it is. That's literally, there's so much, pent up in them because of what's going on in their life. That literally, they're just going to rage against the machine because it's almost like communication. Just like, I know. So that's that. Now, this looks like that, but it also has a mood component. So that means they're going to have mood fluctuation. Also, they technically did away with schizoaffective disorder, which is kind of like this, but it also has a a mood component. I don't know why they did away with that one, because people still use it a lot, because I do think it is a disorder, but anyway. Then there's conduct disorder and that kind of stuff. Now, for our purposes, I mean, this isn't the venue to be talking about what all these look like and all the symptoms, but you will see these. And for our purposes, we're talking about crisis intervention and people get becoming aggressive. So that's the part that we're going to focus on. Which of these do you think someone become aggressive? That one? Yeah. And everyone's familiar with bipolar, right? Because you're going to have like an even mood, and they can go up and get manic, or then they can go down and have, like you said, depression, suicidal ideation, that kind of thing. So when somebody's up here, there's bipolar 1, when they get full-blown mania, or bipolar 2, where they go up, they get irritable, agitated, pressured, they can't sleep, and then they crash, or they can go into full-blown mania and they have completely altered mental status, grandiosity, and delusions and all that stuff. So yes, this person can become aggressive. How about this? Yeah.
Yes.
How about this?
Yes.
Yes. Yes. Yeah, probably not so much. Somebody who's depressed, they might be dangerous to themselves, right? But that can not necessarily dangerous to somebody else. How about that one?
Yes.
How so?
If it's not treated and they're in like a panic, it puts them over into like a crisis.
Or OCD.
Yeah. If you have somebody who's OCD really bad, and they have the obsession and the compulsion that they need to complete because of the doom that they believe, and they believe it is real to them, that if I don't tap the table 3 times in order to leave the room, I just come unglued. So yes, not as likely, but yes, it's possible. Here, right? Autism, yes. So a lot of these can have a situation where that could cause someone to become aggressive. So that's why it's really important for us to be paying attention. So when we talk about an altered mental status due to whatever, what are some features of an altered mental status? What can that look like? Yep. Confusion, disoriented, tangential thinking. What's that?
Paranoia.
Paranoia, absolutely. So now we're starting to talk about psychosis. What are some basic elements of psychosis? Yes. Hallucinations, whatever. That's a long word, and I'm tired. What? There's 4 components of hallucinations.
Like audio, visual.
Yeah.
Yep.
Auditory,
Auditory.
visual, tactile, and olfactory. Now, so that you sound like the professionals that you are, this little pet peeve, Steve P, whatever I call it. It's auditory, not audio. We have a nurse in psychiatry who's been a nurse since God made nurses. And she'll give report.
Yeah, exactly.
She'll give report and she'll say the patient denies audio hallucinations. And my head wants to explode. Audio is the blow pump you put in your truck. All right. Auditory is hearing things. Visual is obviously when you're seeing things. Tactile is when they've got the bugs crawling on them. Vast majority of the time, tactile is withdrawal. In fact, in the emergency room, they've got a phrase that is bugs, it's drugs.
Yeah.
So now it can be. I mean, we had a woman. She's no longer alive. Who we treated, was a chronic mental health patient that we treated at the clinic, who has schizophrenia, and she believed part of her delusion, part of her psychosis was that she had bugs in her, things that were planted in her. And she could feel the things they had planted chips in her, and she would never self-present to the hospital. Her ICM would go check on her, and she'd be in her apartment having like carved her arm to get the chips out, and just take a washcloth and tie it up. I mean, it was gruesome. When she got sick, And then olfactory, which is smelling something. That's not very common. Although years ago, did someone say A6 earlier? Doesn't really matter. On A6, years ago, there was this elderly woman who was having olfactory hallucinations of smelling smoke. You want to turn a medical floor upside down in a heartbeat. You get an old lady screaming, fire! Fire! I smell fire! You could not convince her otherwise because she's having this hallucination, which is real to her. You could not calm her down. She's smelling smoke. She's screaming there's a fire. Get the Zyprexa. Anyway, so it's real to them. Now, so that's hallucinations. What's the other name?
Delusion.
There we go. Again, so delusions are when you believe something is true that is pretty basic. Delusions can be fixed, so you can have the same delusion all the time. So let's see, say we have a delusion with some religious preoccupation and paranoia. We'll mix those all together. So you can have a fixed delusion that the Catholic Church is out to get you. So I always believe that every morning I wake up. So if I wanted to go from here to State Street and there's a Catholic church on my way, I'm going to go all the way around the block to not be by that Catholic church. Or I think I have the paranoid delusion that all the cameras at the intersections, the FBI put them up to watch me. So now you could be sitting at an intersection in your car and I'm coming across the crosswalk like this because I don't want the cameras. Paranoid delusion. Or it can be transient. So I can believe one day that anybody in scrubs is going to poison me. And then the next day, I might believe that anybody wearing glasses can read my mind. So
I have an interesting case. My uncle, 30 years ago, got into a motorcycle accident. And if you've ever seen the movie 50 First Dates, where like she comes
yeah.
that's literally him. He's stuck 30 years ago. And so like and he's fully functioning to a degree. But he's also has been struggling with like alcoholism. So he had to move from Florida to up here. So my mom's taking care of him. So my mom's dealing with like the whole spectrum of depression, anxiety, the repetition, the paranoia, and it's just like, but it's really interesting. It's interesting, but it's also frustrating at the same time because every day is slightly different. So he has like this really big thing about like Big Brother's always watching him and everybody's like implanted in cell phones and trying to get him to use a phone was like a whole procedure. And then he lost his license due to so many DWIs. So like now it's, he has like this really big thing against my aunt, his ex-wife. So he's like constantly holding her like as the reason like, oh, he has a lot of these issues. And so it's just like, you know, he doesn't fall into any single category. He just pulls a little bit from each of them, but like dealing with that and then dealing with the repetition like every day.
So he has a
something.
TBI, which has a lot of
Oh yeah,
a lot
and
of these features.
he's like, I give my mom so much props because I can only deal with it for small, you know, increments of time. And then my husband was like, oh, it's all in everybody's head. And then he spent a day with my uncle and he's like, no,
where's the beer?
Yeah, and my husband, he's from the army, so he has PTSD, so I had to go with him with night terrors. And it's like, and then you put those two together and it's like, forget it. Yeah, it's a whole can of worms.
Wow. All right, so this is where, like, so when we did that thing like with the glasses, so and if I think you guys read my mind, so, and this is where we're talking about communication and what you said about reading a situation. That's a lot of what this whole day is about. Because I didn't tell you that I think you can read my mind with my words, but I told you. I told you something's up. Those are the subtleties that you have to be able to read. Because if I, you know, and you keep walking at me, and I keep getting, you know, more juiced, something's going to happen because we're not paying attention to what's in front of us. And we as adults, just by default and going through time, we just kind of fall into the thing that our brain is only paying attention to the things that we want. Like if we're going to the store, we're paying attention to the list and what we need at the store, and we're not paying attention to anything else. Children aren't like that. They haven't narrowed their perspective yet. Children see everything. From a theoretical point of view, I hold to like the constructivist thought, and Kelly, who kind of generated that developmental theory, talks about children as scientists. Yeah, so they're interacting with their world, and it's very interesting, and they're just soaking everything up like a sponge. And the example I have there is, so my wife and I, we have a toy pool, 10-pound little dog, cutest out. My wife and the dog are inseparable, and she's a self-proclaimed crazy dog lady. Everywhere she goes, she's got the pouch, the little dog, with the arm sticking out, and it looks like a stuffed animal because the dog is really well behaved. Doesn't bark, doesn't move. It will scare people in the checkout because, oh geez, I thought it was stuffed animal. No, it's not. She could be in Hannaford or Marshall's or whatever. Dog is there. The kid can be 80 feet away. Oh, look at the puppy. And the mother's like, what the? There's no, because grown-ups don't see it. We just block out what we don't need. Again, I want you to open that back up again to be able to see all those subtleties, because there's reading the person, but there's also environmental awareness, situational awareness that's going to keep you safe and keep you even more effective at doing what you do, because you're paying attention. Your awareness is heightened. How the hell did I get there? All right. Oh yeah, reading delusion. Okay, I had to back up in my head. So if somebody has an altered mental status and they're psychotic, I think that you're going to poison me, and I'm having command auditory hallucinations. I have voices in my head now telling me to do something, and the voices are telling me that if this person comes over and touches me, I need to stab them in the neck with my fork. So now there's a situation, bro, right? So that's where it's important to be reading. If I'm giving off any clues that I'm uncomfortable with you, we need to be reading. Okay. So anyway, so reading those cues is what's going to help us stay safe with these different disorders. Personality disorders. These, because they're largely chemically based, we can give medications for them, right? With bipolar, we give some mood stabilizers, so it could be lithium or Depakote. PTSD, well, it is physical. Propranolol actually does help, but more closer to the event, not so much after. But schizophrenia, so the atypicals like Zyprexa or Risperidone, the typicals like granddaddies of Haldol and Thorazine, they're still effective. Substance abuse, yeah, depression and antidepressant, anxiety, you can do the benzos. Benzos just mask. Chemically, they just mask the anxiety. It's still there, but they don't feel it. With somewhat mild anxiety, the SSRIs like Prozac and Zoloft, they are effective with mild anxiety, and they actually stop the anxiety from happening. They're just covered up. And I could keep going, but anyway, with the personality disorders, it's a disorder of self. So I can't take a pill for me having a disorder of, or a makeup that is different. So what would you say are some of the most common personality disorders? We have a borderline personality disorder. What else? Narcissistic personality disorder. Antisocial personality disorder. There's dependent personality disorder. There's histrionic. The main two we need to be concerned about here are antisocial and borderline. The antisocial personality is largely there is no conscience. I'm going to do whatever I want to do because I want to do it. I don't give a crap how it affects anybody else. A lot of people think of that as like, gang members and, drug dealers and all that kind of stuff. That's true. But some of the best, most successful CEOs in, multinational companies are also, will have a antisocial personality because their business is thriving because they're just destroy anybody who gets in their way. Like you might have a company that makes widgets and you're a small upstart and really no competition to me whatsoever. But the mere fact that you're making widgets and I make widgets, I'm going to destroy you just because I can. That's antisocial. Now, with the borderline personality, it's a really hard way to live. And also, through the years, it has developed somewhat of a negative connotation because of the set of symptoms. I didn't say this earlier, but so I have workshops that I do at the hospital and out in the community. And I have a whole workshop on just this. Because you might have a comorbid situation where you have somebody who has a borderline personality and then depression. So you can treat the depression with antidepressants, but that's not necessarily going to address this. This has to be treated in therapy. There's 9 criteria. I have 5 to have the full disorder. In the DSM-5, they did start to allow diagnosing somebody under the age of 18 with a personality disorder. I personally, in my, inpatient and my practice, I won't do that. I might say somebody has traits, but you have to be careful when you start putting those kind of labels on people because it will follow them. So with the borderline, so that you can recognize it when you see it. There is prone to impulsive behavior, tend to self-medicate with drugs and alcohol, crave intimacy and connection, fear rejection and abandonment with every cell of their body, and typically struggle with not having healthy boundaries and kind of define themselves through somebody else or people that they're around. And they can tend to idealize or get focused on one person. And because the boundaries, they usually grow up, actually, a lot of time where it comes from is childhood trauma can lead to that personality structure, or growing up in an environment which is very dismissing and demeaning of the kid. So they never really learn to have an identity or sense of self. So they start to define themselves through other people, and they get attached to somebody, and then they just get really close, and they just want to, let's say Angie is my tech, and she comes in and she's just very, always smiling and supportive and wants to help. And so I'm just feeling like Angie is the best tech since God started making techs. So I'm going to be asking her more and more about her and her life, and where she lives, and what she does, and does she have any kids, and does she have a boyfriend? And so I'm just going to keep getting closer and closer. So I'm going to try to insert myself in her life. Now, the reason I'm going over all this is I've seen it happen many times. Someone with borderline personality structure will idealize you, right, and start to try to insert themselves into your life. And so if I did that to Angie and I just start pursuing her, what's she going to do as a healthy individual? She's going to withdraw and
Create a boundary.
Boundaries. She's going to set boundaries with me. So now I can continue to pursue her and idealize her, or when she sets those boundaries, now I feel rejected. I can't function that way. So if I feel rejected, I can again continue to idealize, or I can devalue her. So now if she sets boundaries with me, Steve, this is a professional relationship and you just not be asking me personal questions. I want to help you, but you can't be asking me all those personal things. So if I want to devalue her, so now I feel rejected, I'm going through a boss. That Angie chick, she's inappropriate. She comes in, she says sexual things to me. She was rubbing the inside of my thigh. I'm gonna file a grievance with the Justice Center. I'm gonna call OMH. So now she's on administrative leave, paid or unpaid, while this whole investigation is going on. So her career is in jeopardy because of how I reacted and because of my mental health disorder.
So ironically, that happens to me at my old job, which is why I left.
Oh, sorry.
No.
You're gonna stand up and like punch me in the face.
No, yeah.
So that's what I'm saying. Trust your gut. Trust your gut. Because and it can be weird, you know, that to go to your boss and say, oh, that guy Steve, he's been coming on to me. I think he likes me, or he's doing something, and it's feeling really awkward. You gotta say something. You gotta say something because you need to document that this was going on. Because if I end up turning on you as a professional, you need to have that documented or stated so that you're protected. Because if you don't, so you changed your job.
No, I went through it. I actually had to deal with the Justice Center. I even changed the location that I was working in. The issue that I had was staffing while they were trained. Once they got done with training, it didn't stick. So my issue actually came down to not having supportive staff to back me up when I was presenting to them, hey, we have this issue, this person's fixated on me. I removed myself twice into this from the situation, try to get farther and farther from it. Because I wanted to stay at my job. I really loved it. I was there for 10 years. Staff did not help, and they actually turned it into it was my fault, even though I had the paperwork presenting that, hey, I'm trying to address this issue, I'm trying to get it cleared up. And then it just got to the point where I just got so, and I was part of management, I just got so fed up. I was like, this is not a healthy mental, like when you start dreading going to work because of the situation that's occurring. It was unfortunate. I had to leave. That's when I took the opportunity during the pandemic to change. I was like, I'm totally done with healthcare. Like I was so burnt from that situation and dealing with the Justice Center and getting put on leave for a situation that was not my fault. That was, not handled appropriately. And it's traumatic to like good staff, and so, but it happens,
So that was due to like the environmental and how they were running things. This has to do with this disorder. So just make sure that you take care of that, because and a lot of you who are new to the field and you're just starting out, it can be really awkward. And it can be same sex, opposite sex, doesn't really matter. A lot of people think that borderline personality is mainly women. It's not. It's both. It might be like 51% women, 49 men, but it's pretty close. And in men, this and this can look like this. So.
You see that a lot in corrections, because the men who tend to have it in general, and it's a general umbrella statement, their rejection usually turns violent. And that's when like their rebuff turns into usually violence. And I mean, over the past month, I've seen 3. We have 3 convicted murderers from that diagnosis.
All right. Any statements or situations that you've been through that pertain to this, or anything that you would add? Because I know some of you, like have really good info. Anything else that you would? Because I mean, we'll come back to this, but I go through this because you'll need this framework when you're doing your thing. All right. Neurological impairments. We're talking about that. So TBI, dementia, that kind of thing. With dementia and somebody who has an altered mental status due to something like this or this, dementia and psych are different. They can look the same because they believe, like dementia, it sounds like they're delusional. They're not. Their brain has changed permanently, and there's no medication that's going to bring their brain back to reality. So if you're dealing with someone who looks like they might have dementia, we use what's called therapeutic fitting. All right. So say it's a veteran in a nursing home or something, and he's screaming at the wall, I need my orders, I need my orders now, where's the lieutenant, I need my orders. Walking up to me and saying, hey, Mr. Wood, you're not in the service, you're not in the army anymore, that was 30 years ago. You know, so you need to stop yelling about your lieutenant. I'm going to fight. Verbally, physically, because my brain doesn't know other than the fact I need my orders. So with therapeutic fibbing, you'd be like, oh, Mr. Wood, I know you need your orders. The lieutenant is not here right now, but you know what? It's lunchtime. Let's head to the, what do they call it? What's that? The mess hall. Let's head to the mess hall, get you some lunch, and then we'll get you to the lieutenant. Damn it. Okay. So now you've connected with me because you're not going to change what I believe. So, okay, yeah, we'll get to, and the same thing, like, you know, in the later stages, you know, they'll regress and, you know, you'll have this, you know, 85-year-old guy, you know, is my mother going to come to visit? My mother's going to come to visit today, right? Mom's been dead for, you know, 50 years. So yes, later on, she'll come visit later on. Now it's like with somebody who's psychotic, you know, there's bugs on the walls. This place is filthy. Look at all those bugs on the wall. Huh, okay, well, you know, that's concerning, but you know what, right now, the bugs, we'll take care of the bugs, but you know, let's go on to something else, or so you're not gonna collude with it and say, yeah, look at all those bugs, Ellis sucks. No, it's like, no, I actually, you know what, I don't see the bugs, so I'm not gonna fight them on it. I'm not gonna fight them on it, but I'm not gonna collude with it either. All right.
I had a patient who had COPD. When I first started nursing, like one up in my career, and he became hypoxic, and he got left alone, or at some point he became aggressive because of the decrease of oxygen in his brain. So he became delirious, and he ended up punching my tech, it was a male, in the face and broke her nose.
Wow.
It was and it was like my second year of nursing, and I mean, it was like a wake up call, like never, like, you know, you can't be alone because of that situation, like in my career.
No.
Yeah.
No. The effects of substance abuse, we're seeing it a lot. I mean, cocaine, heroin, K2 and ice. I mean, it's getting bad out there. Psychosocial factors, we kind of talked about that. If you have something serious that's going on in your life, it can cause you to, you know, decompensate or become aggressive. And then environmental factors, conflicts with staff or overcrowding, or like Daniel was saying, like the ER, like just yesterday, we had a code in the ER. The guy was brought in by the ambulance, and he'd been there for maybe an hour, maybe hour and 15 minutes, and he was going off, demanding to be seen, and that, you know, people were, you know, going in ahead of him that he felt shouldn't. What's that?
You gotta try to get to the door, right?
Yeah. And he was saying, and if I'm not seen by noontime, I'm gonna pop off. I'm gonna, and you know, and there's a woman sitting in the wheelchair who had been there all night, you know, but he didn't care because it was all about him. So we get that off. All right, so we're gonna move on. That's some of the background there. Let's go to page 12. And let's do something different. Can I have somebody read that page for us? Read the assumption and the reality.
Unit staff know how to recognize a potentially violent situation. Reality. Research was conducted on nurses' decisions about clinical cues of patient agitation, self-harm, inclination to assault others, and destruction of property. Nurses agreed only 22% of the time. Those with the least clinical experience made the most restrictive recommendations.
So those last two sentences are really important. One, if I gave all of you a scenario and said, what would you know, write down how you'd handle it, we get them all back together, you'd agree between 22 and 25% of the time. So that means 75% of the time, every one of you can have a really good idea, but because if we're not working as a team, we could end up working against each other. So that's why communication, teamwork is really important. The other is, for those of you who are newer to the field, it's just a human nature thing that if somebody starts becoming aggressive, like you have somebody with alcohol withdrawal, they keep getting off their bed, they want to go home, they won't listen to you, and they're getting aggressive. Try to say, no, you need to sit down on the bed. That's just trying to clamp that down and get more restrictive is will escalate the situation. Can someone read page 13 for us, please?
Assumption, staff know how to de-escalate potentially violent situations. Reality, behavioral analysis indicated the most frequent. Wow,
Antecedent.
thank you. Antecedent to the use of mechanical restraint was a staff initiated encounter with the patient. Analysis of violence over a 6-month period in 3 acute psych units found that de-escalation was used as an intervention 25% of the time.
Yeah, that's horrifically low. And this is OMH stuff. This program is actually, it's a modified version of PMCS, which is what the New York State Office of Mental Health uses in the state hospitals. And I went out there, became a trainer, and because we're not a state hospital, we can use that model, but then modify it to our setting. So that's what this is for us today. So yeah, we definitely have to de-escalate as much as possible. We're gonna skip 14. Can someone read 15 for us, please?
Assumption, seclusion and restraint are used without bias and only in response to objective feeling. Reality, research indicates that cultural and social bias may exist. Those more likely to be restrained are younger and are more male and of African American or Hispanic ethnicity. Another study concluded that factors that had a greater influence on the use of seclusion than demographic and clinical factors were clinical biases, staff role perceptions, and administrator attitudes.
Yeah. I would love to say that Ellis hasn't had this problem. I'd be lying. This is one of my, I like this part of my job. I like to do these because the next time we're working together, it's probably because things are really going south. So it's nice to have that connection and have a day together and work together. And it's also really important because I'm with all of you being new and being able to work together. This often matches the population that we have here in Schenectady is being very diverse. And that's really important and something that is crucial for us to lean on. Have any of you met, if you're in the emergency room, have you met Kareem yet? So Kareem is this tall, this wide, all the way down. He's huge. He actually played semi-pro football until he grew out his huge guy. Real sweet, huge smile. He used to work in psych, so the emergency room poached him. So he was up on psych, and we had a young man of color who we knew well. We had him on the adolescent unit, and now he was around 20 at this point. Bipolar, so he was manic, pressured. He was in his involuntary status because out in the community he was aggressive, hypersexual. We had him in a single because he was just like all over the place. So, and he also fancied himself quite the rapper. And I would try to do it for you, but I just can't. So, but he was good, and he would freestyle, and he would cover to cover, and so at this point he's irritable, he's agitated, he's in his room, he's wrapping up a storm. The lyrics would offend some people, but he's just going to town, and he's doing this, because he has so much energy. He's doing this like mixed martial arts dance thing while he's rapping, and he's like on his bed, off his bed, running around the room, kicking and punching and doing all kinds of stuff. And his nurse from rural upstate New York sees this, and she's like, "Oh my God, call a code. He's throwing punches. He's aggressive. He's violent. Call a code now." Thank God for Kareem. Kareem saw it for what it was. Now, is he out in the dining room, trying to kicking people in the face and all that? No, he's in his room by himself. He's burning off energy. He's singing and dancing, right? He's not bothering anybody. She sees it as violent. Kareem's like, "Wait, whoa, you know what? Let me give it a try." And he goes over to the door jamb, leans the door, leans against the door jab. He goes, dude, turn the volume down. You're scaring the patients. And the guy went, okay. He saw it for what it was. And that's why I like doing this, I like meeting you. You're our fresh blood. I mean, I want you to be a wave of Kareems going out to where you go to be part of that team, that's or situation, and speak up. When this seasoned nurse from her background totally misread what was going on. He's been at the hospital since. He's hurt multiple staff when he's manic. In fact, this last time that he was in, he was again, his presentation was the same. They heard hit the code gray called overhead. A nurse and a tech went to try to keep him in his room. He had planned it. He took his socks off so he had stronger grip on the floor. And as soon as they came in, he went at him, tore the heck out of the rotator cuff of this, the nurse was much larger, bigger than me. So, yeah, just work as a team and please speak up if you see something that's not going right. Or somebody's like, I'm done with this one. That's it. Call the code. We're going in restraints. They're slamming their door and they're pissed off at you, but they're not doing anything else. So, all right, that was good. Skip that page. All right, so next section in here. Jump to page 19. They have it in here, as far as like this section about cultural awareness and customer service. I would also take this service recovery model of listen, apologize, resolve. I would also tuck that in later when we do de-escalation. I use this all the time, not with somebody who's complaining about their cold coffee. Okay, sorry, your coffee's cold. Listen, so let somebody vent. Sometimes just letting them get it off their chest. They might not be doing it in the most articulate or healthy manner, but sometimes just letting them vent, feeling heard can take care of it. Then apologize. You're not apologizing that you did anything wrong or that the nurse or Alice Medicine, you're not apologizing for that particular thing. You're apologizing. I'm so sorry you're going through that. I'm so sorry that it's been that difficult for you. I'm so sorry that you've had to wait. It is. It's really frustrating and hard. Validate. Don't collude. Those effing cops, they brought me in. Now I have to wait here. Yeah, I know. SPD, they suck. We hear it all the time. No, that's colluding. So now you're connected with that person, but in a negative way. You want to validate. I'm so sorry that you had that experience coming to the hospital. I can't see how anybody would find that. Okay, I'm just so sorry you went through that. And they could be telling the truth. They could be telling a lie. You just want to validate where they're at. Apologize that they're in that situation. And then recovery. Is there anything we can do to manage the situation? I can get another cup of coffee. Or like on the medical floors, say the doctor on Tuesday tells your patient, if your labs come back tomorrow looking pretty good, you can go home. So that patient on Wednesday morning, their street clothes are on, their sneakers are tied, and they are ready to go. And then, but the doctor doesn't show up till 2 o'clock. So now they're getting more and more agitated. So in that kind of situation, sometimes it's knowledge. You might be afraid to tell the patient, well, the doctor's not going to go up till probably, mid-afternoon. Why do I effing have to wait? It's just a piece of effing paper. The result required is it's really important to be seen by the doctor to finalize things. I know it is really hard to wait. It seems like it's not important, but your surgeons downstairs, they do the surgeries first. So when she comes upstairs to the floor, we'll make sure she does the discharges first, and that's right up there at the top of the list. So they don't want to wait, but now they know why they're waiting, and they're able to say, well, she operated on me, so I guess I have to be realistic. She's operating on somebody else, and I'll be discharged when she goes out there. So that's what I'm saying about the resolve piece. What is something that, because we can't make the doctor get there any sooner, but we can at least tell them why they're waiting and to expedite things. Next page, page 20. All right, so culture and diversity. Hot topics right now. What would you say are, I know they're listed right there, but what would you say are some of the main components that make up someone's culture?
Beliefs.
Their beliefs, yeah, yeah. So there's, well, there can be beliefs about a lot of things, but there's also
Other
spirituality.
races as well, or they could think, for example, like if you're speaking to a different culture, like women have a place in that culture and they don't want to hear it from you, it's like, you know, so it's not you they're angry at, maybe just perhaps getting like a opposite gender to go in and speak with them. Could be the situation.
We have that, we see that fair amount, like with Muslim and Hindu patients. Yeah. Like, so, right, having a female tell a male what to do, sometimes doesn't go over well. Or, like, there's a large OBGYN practice in Niskayuna, it's all women, and they deliver at Bellevue, but they don't tell the patients that if you deliver on off hours, you might have a male doctor covering. And that happened at Bellevue. This woman showed up and she dilated like 5 centimeters. She was close. And there was a male doctor on, and the husband and the wife refused, because you ain't going down there, pal. No way. So they literally, we had to like frantically call all around. And they ended up, she crossed her legs, got in the car and drove to Troy to find a female doctor to deliver the job. So it carried, so yeah. So beliefs, there's the faith, you know, and religion is the practice of that faith. Food preferences. What else?
Body gestures.
Yeah, body gestures.
Like if
Eye
you're making
contact.
Contact and you shouldn't be.
There are some cultures that, you know, maintaining eye contact is disrespectful. In our culture, you know, looking someone in the eye is actually, you know, preferred. So, and diversity is when you have a lot of different ethnic and cultural dynamics going on. Schenectady is not a big city, but it is diverse. What would you say are some of the main ethnic or religious groups that we have around
We feel like Viennese.
here? And actually, that was actually on purpose. I forget what mayor it was a while back. When the locomotive business left Schenectady, a lot of businesses went under, and a lot of people moved away out of Schenectady. And the mayor at the time put a big push on down in the city, and then ultimately from Guyana, for them to come here. And because their culture is hardworking, positive, entrepreneurial, and so he made up, like if people would come and buy a house or buy a business, he would give them tax breaks. So a lot of people from a lot of Guyanese people came, started, you know, houses started being occupied, businesses started, and really revitalized. I said, wow, I went into that way. Anyway, yes, Guyanese, black, white, Hispanic. We have a lot of Indian and Pakistani, and it's because it's really interesting because we can have, you know, inner city over the hill. Plus we have, you know, Knowles Atomic.
We have some Amish too.
Amish.
Yeah, they
Yeah.
spend a lot of time, that's one of the things that the ER manager Laura said, that a lot of times they bring their pediatrics there. And when they bring their pediatrics there, because they're not like, because they don't ever seek healthcare, usually the child is like really sick.
You
So
are
they have-
exactly right.
Yeah, because of that.
Because if they have something minor, they'll go to Nathan Latour. Otherwise, they'll end up coming here, or Nathan Latour will send them. And it is funny. So, and the whole family comes, like,
Yeah.
yeah, one person sick and there'll be 23 people. I think it was A5 or A6. It was A6, because you know how, like, if you've been up on A6, their lounge area is like this big overlook. So it's really kind of attractive up there. The patient was on A6 and there were a whole bunch of family members. And when they're indoors, they don't wear their shoes. So patient went for a test somewhere and we didn't see it, but the family went with them. But so they weren't in the lounge area, but all their shoes were lined up on the floor. So it was like, what happened? They're all gone. Invasion of the body snatchers, just like, they're gone. Because their shoes were all there, but there's no people. Yeah, yeah. All right, so the next page is in your take home cultural sensitivity. As far as, modify your teaching to their culture and their language. The thing about eye contact, food purposes, how they handle that is important. The two things I would point out is one, don't assume. Just because I might know one Guyanese family doesn't mean I know all Guyanese families. So make sure that you're paying attention to that. And the other one is to just ask. I know right now in our current societal times, even acknowledging that somebody is different than you, oh my God, where's he going with that? We're in a professional setting. If you see on the face sheet that someone is Muslim, to go up and ask that person, I see here that you're Muslim, even if they're like, what's happening? Just, is there anything that you need or you would prefer while you're here with regard to your faith so that we can make your stay the most positive? And, that guy might say, well, at 3 o'clock, I need to pray. So if I got some privacy at 3 o'clock, that'd be great. Oh, I can make that happen. We'll close the door. And in fact, would you like an extra blanket? For kneeling? Oh, that would be great. I don't have to use it on the floor. I'll bring you a heated blanket just before 3. You just scored because you were genuine and you're treating the whole person. So don't be afraid to ask. Now, the next couple sections, like I said, they're dated, but there's 2 charts. There's cultural considerations and then the culture tool. They're also in your take home. We're not going to go through these. There's just too much information there. I put them in your take home so that if you have you're treating someone from Yemen, you can learn a little bit about the culture, and it's not exhaustive, it's really basic, but it might be something that's useful to you. So you have those. The next section, if we're talking about those previously, that the cultural considerations, jump to page 30. It looks like this. And the binders that have the black rim, 29 and 30 are backwards. So I want you to find this chart where it says adolescent, adult, and older adult. Okay, so what we're dealing with an adolescent, which technically is to the mid-20s, but usually you think about a teenager. If you're dealing with a teenager, what is unique about them developmentally? Like, what are teenagers like? What's important?
They know it all.
They think they know it all. Yep. They want to be independent. It's because they know it all. They can make their own decisions. They don't want to be told what to do. What else?
Quite impulsive.
Yes,
Yeah.
big time.
They have different pacing in their development, so you wouldn't be the same age but at different stages.
Yes, that's very true.
Very true. Girls tend to be more advanced than boys. Lots of mood swings, right? Who's people wise, who's the most important to a teenager?
Their peers.
Their peers, absolutely. They can have friends at school say that square wheels are the new thing, and they will believe it. And then kid comes home and you're like, inside your head, your friend's an idiot. I can't believe you believe him, but okay.
It's like the rise of Champion before, like back in the day, Champion was like, when I went to school, it was like not thing to wear. And then all of a sudden, like the new spec is like Champion, like went up from like $20. Now it's like $70 to buy a sweatshirt.
Yeah.
Because it's like the new
thing.
because they're all wearing it.
If you need to redirect the teenager, separate them from the herd, because they're not going to want to change. They're not going to want to bend to your will and have it witnessed. So
Yeah.
This has changed everything. Yep. So where kids, previous generations thought they knew everything, now I can Google it. I know better than you. In fact, over at Bellevue, I hear this all the time. So the nurse will be going in to do breastfeeding teaching, latching on or whatever. The kid said, no, that's not right. Because they know that they've already Googled it, that's not what Google said. And they're taking pictures of everything over at Bellevue, so they'll be in there and boyfriend will be sitting in the room next to her, she'll have they'll be doing an internal and they want to turn their phone on and like, no! You can't take a picture of that, right? Not here anyway. Unbelievable. But this has changed everything because the younger generation doesn't know life without this.
Yeah.
Their entire world is through this. So previous generation, we might be a group of friends and we would hang out, and we all eat lunch together, we plan to go to the movies, and if she wasn't at the table, make sure you tell her so that she comes, because we all want to go see whatever. So nothing came right there. So we would take care of that. And yes, you could use the phone with the cord in the wall.
Right. They just speak to their parents.
Yeah.
Hey, is there a home
Right.
line?
Now, it's all through this, even if we're sitting at the same table, I'm gonna text you, not talk to you. So if you take this away, they don't know how to live life without a phone. And I tell you, without exaggeration, whether it's in the crisis unit and we will reopen B3 soon. Within a week's time, we will have a teenage girl come to the hospital, having taken a pretty serious overdose on Tylenol or whatever, because mom took her phone away because she was up again at 2:30 in the morning on her phone, and she can't get up for school. And now, so she's suicidal and she took an overdose because the phone was gone. Or John, well, obviously, I was gonna use Johnny, but there's a Johnny there. So Jack got a 38 on his midterm math report, and dad found it on the kitchen table and goes ballistic. I can't believe you got a F38 on math. That's it. All your screens are getting locked up out in the garage. And now Johnny's chasing dad around the house with a steak knife because he took his Xbox and stuff. So it's just not being able to modulate this is interesting. Having been in the field for quite some time, and actually my background is child, adolescent, and family. And this is broad strokes, it's everybody this age, but what I've noticed is there's just overall less frustration tolerance. Everything on this is immediate, so if things don't happen quickly, that's a problem. Social skills are getting less because all the interaction is through this. And I had a kid in the practice who was kind of a loner and kind of depressed. Was having some suicidal ideation. So I was talking, so how about your friends? I mean, how do you rely on your friends? He said, well, I talk to them online. I said, okay, but don't you have any in school? No, not really. So, well, where are your friends? Well, I have one in California. I have two that are over in England. And I think the other one's in Missouri. But we FaceTime. That's his friend group, which is now a term, friend group. Yeah, they're all on the internet. No one touches him. Although his family cared very much for him, but he just didn't have the ability to connect like that. So, all right. So teenagers. How about adults? What's important in life for an adult? Money, right? Career, paying the bills, paying the mortgage, buying school supplies for the kids, taking care of the family, raising your kids, taking care of your parents.
I feel like for adults, especially like in my peer group, is like I don't know, the feeling of being in like the right place, but no one knows exactly, like the social, like I should be doing this by 30, or like, yeah, it's kind of like transcended, like I have a career at 32, but my friend who's about to turn 32 doesn't, and it's a big catastrophe because our whole lives we've been like spoon fed, like we should have our like shit together by our 30s. I think that is like right now is a huge like mental health topic for adults.
Huh, okay. Good.
I think kids too, because like I don't have any biological kids. And I, you know, I'm over 30, so like all my friends, not over the phone, like actual friends. You know, they all have kids and I'm like the cool aunt that gets kids and I can hand them back, but they all look at me and and it's really funny that they look at me and not my husband and they're like, why are you gonna have a kid? It's like, well, you know, last I knew, you know, I know it's been a minute since sex education in high school, but it takes two to have a kid. I'm like, but why are you always looking at me as the one who's holding back and having a kid? And it gets frustrating after a while, like repetitively, you know, because everyone's like, oh, well, you're over 30, you don't have a kid yet, you know, your eggs are gonna run out. And I'm like, well, geez, no peer
So
pressure
like,
on
they
that
actually
one.
say that to you?
Yeah, it's like no peer pressure, but it's like repetitively to the point where I actually had to address it to my husband. I'm like, the next time this comes up, I need you as my spouse to step in and be like, hey, you know, it takes two.
It's
like,
our life choice.
yeah, yeah, and everyone's
Step off.
yeah, and he has a son, you know, because, you know, one drunken night, whatever, but it's cool. And I don't judge him on it. I love my stepson, but you know, it's everyone's like, oh, well, you're married, so you need to have a kid too. It's like, does the world really need it? Like I have fur children. And I joke with my mom, and my mom's like, yeah, these are my grandchildren, you know, I have, you know.
Oh, I know
And-
that one.
Yeah, and she's cool with it, and I'm cool with it, but I hate the fact that everyone's like, oh, well, you're 31 and you have to have a kid by 35. and
Wow.
I'm just like, well, shit, man.
Yeah.
You know, nothing else matters. Like, you know, I'm independent, I have my own home, I have, you know,
Yeah,
two vehicles, but it doesn't matter because I don't have a child, so,
Wow.
yeah.
Okay, so that's adults. Now, how about the elderly or older adults? What's gonna be important to them?
Retirement.
Retirement, but even older. What's that?
Maybe grandchildren.
Grandchildren?
Okay.
Mhm.
A lot of them go into depression, I've seen, because like their friends and their close peers are passing away.
Loss.
Loss.
A lot for the elderly kind of focuses around loss. I'm losing my friends. I've lost my spouse. I'm losing my ability. I can't go back home. I'm losing my independence.
I got my license taken.
I got my license taken away. I'm losing, my memory isn't working. I'm losing the function of my body. I'm pissing myself, for God's sake. So, you know, so yes. So being respectful of that is important. Actually, I would say respect is important throughout the developmental life cycle, but how you show respect to a 16-year-old is going to be different than an 86-year-old, but still important nonetheless. Okay, just so you know, we are actually ahead of schedule. Now, we're going to talk about communications. Let's go to page 34. Now, this page is woefully out of date. It says that there's essentially that there's two facets of communication: verbal and nonverbal. That's actually inaccurate. Four chairs. There's actually three facets of communication. Okay. And actually, I'm just gonna cut to the chase. There's three. This is a pie chart of communication. There's three facets of communication. There's verbal, paraverbal, and nonverbal. Verbal are the words we choose, the actual words that we say, the content of our speech. Right? Paraverbal is how we say what we say. So if I have a benign statement like have a seat in the waiting room, I can say it like that, have a seat in the waiting room. Or you change the paraverbals and I can say, have a seat in the waiting room. Changes the message. How does it change the message? Have a seat in the waiting room. What do my paraverbals say? Get your ass in the waiting
Sit
room.
down.
Yeah. Have a seat in the waiting room. What's one of my paraverbals saying? Take your time. Have a seat. You know what? I don't care where your ass is, but don't sit in front of me. So it's something like that, right? It's disrespectful, it's demeaning. Or, and then there's nonverbal, where I could be like, have a seat in the waiting room, pointing to the waiting room. Have a seat in the waiting room. What am I nonverbal saying? Pissed off, angry, close off. So now you're gonna say it now.
You're wasting your time.
Right.
In the parking lot.
Don't move your car.
So, but they all they all fit together, they all come together. So all right, so what's the percentage? Which of these do you think is number one? Nonverbal? All right. We'll go with that. What do you think the second one is? Paraverbal. This is a good class, you're crushing it. Yes, you're right. So this is about 60%, this is about 30, that's about 10. That varies though. It varies in what you're doing in healthcare and it varies from career to career. A police officer, it's going to be 90-10. 90%, they're reading your body language, what you're doing, then a little bit about how you're saying it, and then the verbal, you're probably lying anyway. So, so they're reading their environment, they're reading you big time. For us in healthcare, this is pretty accurate, although sometimes this might go up, because if you're doing like wound care teaching or discharge instructions, the content of your speech is really important. Or you're doing an assessment, what that patient is telling you is really important. But also for the paraverbals. Like if you're doing an assessment with me and you're like, okay, so Mr. Wood, do you drink alcohol? Yeah. How much do you drink? A couple on the weekend. Now, my verbals are telling you I have a couple drinks on the weekend. What are my paraverbals telling you? I'm lying through my teeth. I'm a hardcore alcoholic, but I'm gonna let you know that. So we're gonna, rather than just talk about this, we're gonna do something with it. So I'm gonna need a couple volunteers. We're actually gonna do more than one of these, so if you don't volunteer for the first one, it doesn't automatically you're safe. I need 2 volunteers, please. Come up here, yep, thank you. Have a seat in one of these. It's your time.
I've been up all night.
I was gonna say.
It's gonna be steps.
Yeah,
You should get a pay.
Now, I was gonna say, now she is
I
totally
don't know what I
outdoing
just
all you guys.
volunteered for, but,
She's,
okay.
you come sit over here. So she's been up all night. God bless her. All right, so we have Danielle up. Danielle and James. You get to pick who's gonna build for us, Danielle or James? Okay, James, I want
Sorry, you're closer.
you to build something with your 6 blocks. All right, James, your job, you got the 2 of you have identical sets of blocks. Your job is to explain to her how to build that same exact thing over here.
It's gonna be a male, female.
Danielle.
Right here. I can feel this coming on.
That Mars is Venus, man.
It's left, it's to the right. There we go.
90 degrees angle for you.
Yeah.
Your job is to build the same thing over here. You can't turn around and look, and you can't ask any questions. You can't even make a sound. All you can do is listen and build.
Oh, so she can't say anything.
Correct. So all you just have to tell her how to build that.
And the other people say something.
No. Nope, the peanut gallery is gonna go away.
All right,
And now I want you to do your best, but I don't want this to go for 20 minutes.
all right.
All right, ready to go.
Okay, so I have 4 long rectangle things and then 2 short ones. There's 2 long ones are parallel to each other on the bottom. Then 2 more kind of to make a square looking thing on top of that. And then the 2 smallest ones go on top parallel to each other. That's too fast.
She can't say anything.
All right, so 2.
Well, she's got it.
Okay.
All right, go ahead, look. So she has, well, wait, she has 2 long parallel, she has 2 other 2 long parallel. And it's making a square thing,
Yeah,
and yet the 2 on top.
I accept it.
So what she built matches what you said, and what you said matches what the 2 of you built, but they are not the same. Mid-error, right? This is harder than it looks. We have a room full of professionals playing with 6 blocks, and it's still hard. This happens all the time because it does match what he said. Now, I set them up. What did I do to set them up? To fail.
I couldn't ask the question.
Right, so there's no two-way communication. And actually, those of us up here could see her nonverbals. The confusion on her face was like all over the place. So she couldn't ask anything she wanted to, but she couldn't. And the other was, I took away the nonverbal. So if I had the 2 of you facing each other with a partition in the middle, if you had seen the confusion on her face, you would have been, oh, wait. Because you would have read, she's confused, let me back up. But I took that away from you. So it didn't work. This is a microcosm of the stuff that we deal with every day. So you have our patient who you're giving, or your client, that you're talking with and giving instructions. What are some things in real life where your client or your patient is trying to cooperate, but something's in the way and it's not clicking? How can that happen in real life? Which one will work on?
You asked the question.
I know, but so other than her,
You know,
well,
like
she
the-
said language.
Yeah, like technical language that a patient might not understand.
Right. So you're ahead of me. Medical terminology, yes. And you said hearing. So you might have somebody who is hard of hearing, yep. Or somebody, a geriatric person, or they're anxious, they're being discharged and they're anxious, so they don't know what, they're not hearing the information. And the big one, she said right off the bat, language, she said, being a translator for a lot of the people, like we referred to earlier, a lot of the people in this town, English is like a 2nd or 3rd language. You will be dealing with this. So say English is her 3rd language. And James is doing, we'll do discharge instructions. So James is telling Danielle, you're being discharged, these are your medications. It's extremely important that you take these medications as prescribed. There's 3 pills a day, morning, noon, and night, and your pill bottle will say TID. So make sure you take these medications as prescribed. Now, if English is her 3rd language, what she could have heard is important, blah, 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 3 pills, blah, 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 night. There it is. She's taking 3 pills a day, but she's not taking them correctly. So depending on what the illness is, what the medications are, she's overdosing every day. Or under, right. So now, and this is where all of this stuff comes together. In her culture, dealing with a male healthcare professional, I'm supposed to esteem you. So as you speak, I'm going to esteem you. I have no fucking clue what you just told me, but I'm going to esteem you. So now the nonverbals that we're reading in this culture is yet got it, 3 pills, morning, noon, and night. Move on. But that's not what's going on. So, who was someone here in nursing school? No. Okay, so from your nursing education, how do we mitigate this? There it is. So make sure that person tells back to you what they said, even if you think that they get it, confirm it. Because that's, when I was working on the adolescent unit, the doctor and I would have a conversation with the kid. And they'd say, okay, so let's go over there again. You tell us what we just talked about. And they're talking about something way over here, like, oh my God. This kid has no clue. So we have to really back up because we realize how awful it was.
There's another big one, I don't know if you're gonna touch on it, but it's a huge deal and it almost killed a patient. When I was up at Saratoga, health literacy was huge. You can't assume someone knows how to read. So you're handing them things and they're shaking their head and and you find out they don't know how to read. And they're embarrassed. So we would do like little techniques, like when you hand them papers, if the wording's upside down, if they're not recognizing it or even looking through it, they probably can't read it. So, and I mean, I think what is it, 85% now, things are written at a third grade level for that reason. Cursive. Yeah.
Yeah. We can get lost in that. There's a lot
Yeah,
of young people.
It's a
not-
rabbit hole.
Yeah,
but that's
like a
just
lot
the way
of
it
young people
started.
cannot read that clock.
Yeah.
It has to be a digital clock.
Yeah.
That makes no sense to me. Okay, good job. If you two would help me on the next one. So we're gonna go out in the hallway. And I need 2 more volunteers in here. So let's go out here. Oh, don't worry about it. We're just gonna.
I know that was like in
All right, so we have Lexi and Rachel. All right, so you get to pick who's gonna build, Lexi or Rachel. You pick. Lexi, okay, so Lexi, I want you to build something with your blocks, please. And Rachel, so your job is the same. I want you to build the same thing over here. And colors do matter. Right? So same thing over here. And you can ask questions. You can't look, but you can ask questions if you want.
Give me a second. I think I just screwed myself. Okay, ready?
Great. So did you hear her? She can ask questions, but she can look. And the same goes for you. I want you to explain how to build the same exact thing, but don't take forever.
Okay.
Okay, ready, go.
Okay, you have the, oh my God, the red long block. Back towards the back of the chair, laying down horizontal.
Horizontal parallel to the chair legs or the back of the chair.
The back of the chair.
Okay.
Then on one side, my left, you have the green long block going parallel against the blue on the, all the way to the right
Okay, so these are for the red?
Yeah.
Okay. Did they touch the red?
Yes.
I'm really loving this jacket.
And then on top of the blue and the green, you have the yellow long block all the way at the end, not touching the red.
The edge opposite the red?
Correct.
Okay,
With the red should be on the chair and the yellow should be on top of the blue and the green block.
Okay, are the edges of the blue and green flush with the red and the yellow, or are they?
Correct.
yellow?
Oh, well, yeah, correct.
Okay, what am I doing with the smaller blocks?
Then you have the green smaller block on the left, the same side as the other green, touching the yellow small one across, like laying like a bridge.
Okay, so they join together, green on the left and yellow on the right?
Yeah,
Okay, good. I think I have these.
and then yellow, the yellow long block should be touching the two small ones.
Okay, so they're directly flush against yellow.
Correct,
Okay,
so there
so
should-
furthest from me, red,
Yes,
closest to me, yellow, but raised up on top of the other two.
correct,
Green on the left,
Correct.
blue on the right.
correct.
All right, go ahead and take a look.
Yellow.
Is it
Yeah.
correct?
Go ahead, we'll take a look.
Yeah, nailed it.
All right, nice
It's
job.
crazy in the middle of it, you literally said too, like, I think I got these blocks mixed up and you switched it. That's crazy.
Yeah.
I would like to say, we're also friends in class, so I don't know if that
We
helps.
do talking to one another over things,
We're on
like-
separate
so we're like
language.
coworkers in that way.
All right,
I don't know if
okay,
that's cheating.
thank you, you two, the standing people can sit down. All
Also,
right.
were you really gonna name your daughter Lexi?
All right, so what was the very, actually, that's a great job, you got, and actually, you're right, having that previous connection.
Yeah.
Will definitely help. So really good job, you got it. What was the variable in that one?
Loudness, I'm talking about.
Which, yeah, them
Like
talking,
outside noise.
which is a distraction, yes. So what was that like for the two of you with the,
It takes a lot of auditory energy to focus on a particular voice.
yeah,
I think since I was the one talking, it was easier for me, because I knew what I had to say, I didn't really have to like listen to what they were saying, but it was probably more difficult for Rachel to.
Yeah, yeah, because she's trying to distinguish.
Yeah.
What voice is what.
I also realized I use my hands to describe it and she can't.
She
see
can't.
it. To show you where the blocks
She
are.
was.
So I was thinking in my head, why are you doing this? She can't see it. But yeah.
That's the Italian part.
Yeah.
All right. So, and you didn't make the mistakes that you did to make. Oh, no, stay there. So, I know I'm asking an obvious question, but are there gonna be distractions in performing your healthcare duties?
Yes.
Absolutely. Like what? What are the distractions that you're gonna have to be dealing with?
Call lights.
Was that
Call lights.
call lights, call bells?
Psychiatric unit, you have a
alarms?
bunch of other patients talking and stuff while you're in the meetings.
Yeah, so family members, other patients, visitors, other staff, the doctor, the tech is coming up to you with all the vitals that you asked for. And so here's the vitals that you need. And by the way, the woman in 302 thinks you suck. You know, that's just, there's all kinds of things coming at you.
And then you have the internal distractions too, of the next few patients you're gonna see after the one that you're shopping.
Or you gotta pee, or you haven't eaten.
Yep.
Or.
Yep. So, some distractions we can mitigate, some we can't. Also, don't be the distraction. You know, like, if you're, what was your name again? Liz. So if Liz is on the phone with a pharmacy trying to do a med rack, and you're standing in the nurse's station talking about, hey, this weekend, there's a Huff and Putt up in Saratoga. On Tuesday nights, you can play miniature golf and just get stoned, man. And it's all totally cool. Now, everybody in that nurse's station is like, what? Including Liz, wait, Huff and Putt? So don't be a distraction. That's a true example, by the way. It's real. Yeah. My private practice office is here. There's a landscaper, and then there's this miniature golf. So on Tuesday nights when I'm leaving the practice, the lights are on and there's more laughing over there while they're playing miniature golf. And if the breeze is right, you can, what. So anyway, so yes, distractions, and we have to be able to try to mitigate those as best we can. The last thing I'll say on this one is, for the two of you directly, and the rest of us vicariously, that's what it's like to be schizophrenic. So if you can imagine living your life with constant,
Noise.
somebody
Yeah.
talking to you, trying to get your attention, telling you to do something, telling you yourself, telling you, you should kill yourself, or they can be fun voices, but, yeah, so that's, if you get the neuroleptics up high enough, if you get rid of the voices, but that's when all the side effects start kicking in, so they start getting, impacted, or weight gain, or, EPS, or, tardive dyskinesia, and then you gotta bring it back down to now go to the voices again. So it's tough. Okay, thank you, two. You're gonna have and for, well, I usually, when I have time, I will do one more, where I'll have the person doing the talking will deliver the instructions to this person, but they do it like with a drill sergeant voice. So it's like, now, put the red block, do it now, red block, blue block. And so that's how they're talking, and I only give them 30 seconds to do it. Put the red block down now. So this person over here is getting yelled at, and come on, Maggot, do it. But then, so they get frustrated, and then as they're doing that, I'll say 10 seconds gone, halfway mark, 10 seconds left. So then this person talks louder and faster, and then starts cutting corners. And this person over here is just like, and just because, they're just so frustrated. So, and that one is about pressure,
That's
feeling
like
the
an
pressure.
ER code right there. That's literally, we got 50 people in the room. This one's like, what do you want me to do? And that's exactly it.
Yeah. So, but that, you can understand it, the pressure, and yes, there's gonna be pressure in doing what you do. You gotta do that discharge, get that, get EBS up here, clean that room, because the ED is full, and just pressure. So. All right, so it's 10 o'clock. I have a little bit left to do on this part, but we'll do that after the break. So if you want to, you can go stretch your legs. If we go, there are vending machines, if you look at some, beverages and stuff, if you want to go check those out. And so why don't you come back in 10 minutes or so. We'll pick up.
So start yelling at you. I don't know that. Yeah. You're like, I will die. No, not at all.
Oh, yes, remember you gotta wear your mask out there.
As big as I am. No, the army. Turning too hard for people. So it was okay. Yeah, no, I just started. And those. No, guys.
We don't know, wait.
How?
Waiting for recommendation, so overnight.
In Army for 4 years, and it was a national, so I did like the weekend. So was that like?
No,
Oh,
and that was my, yeah, I've only had.
Okay, so that's
Nothing
literally
on
why.
this stuff.
And why would you-
Yeah.
Same,
Alright,
we
yeah.
started together.
These eyes, okay, so that's why they face it here.
No, but now.
Yeah.
Oh, so she would do that, yeah. And then we had tomorrow. Oh, yeah, she was.
But I ended up spending
Yeah.
Yeah, first part time. I just never really went very much. So I'm just out there, I'm just getting.
Yeah.
Oh, I mean, she didn't say no, I said certain numbers of the asked her where they were.
But I've never met
That is
that.
right. So.
No, I just started,
So I just.
cause I was like, I actually,
But honestly, like, I mean, I like those, so it's really on the weekends, which I'm not.
Yeah.
Yeah, so.
I really think it's
Because everyone there is so like willing to everybody. Yes, all the other boards, like.
I got it.
I've like, I don't know, years ago.
Yeah.
Yeah.
Yeah, cause I was like, you went to school here.
Yeah, there's so by the vending machines, like there's mailboxes, there's like water for.
Okay, perfect. I was literally like,
Yeah.
she'll know, cause she went to school here.
Yeah.
Thank you.
1987 to 2007.
Like every day she looks for jobs.
I thought, I heard that.
Oh, yeah.
Yeah.
Before I get my meeting, I was before.
Walk around like I'm at home.
Yeah.
I took a phone with my house.
You said Saratoga and four.
Yeah.
Oh, okay. Well, maybe, I mean, although I haven't been,
I don't know, but I would, yeah, I would live there. Oh, because then you're gonna sit at the when you're whatever. Yeah, I think this is.
That's hands-on.
Yeah.
I was like, you wanna like work out.
Yeah. And it's like I said, it's better when you do something with it.
Yeah.
Actually, I've done this.
Based on what I-
Right.
I don't remember being like, yeah, I remember like a big deal, like,
Yeah, because I know
just like
someone else.
that and I'm like, oh, how did you we don't remember when
And she was like, not as this is.
And I teach it, so you, and, they ask you, we just teach it. Yeah, I teach it.
Yeah, I was starting.
Yeah.
So I worked in. Yeah.
I'm gonna say
That's what I was like,
yeah, I graduate level thing.
Yeah, that's really weird.
I know, my special, my
It's very.
like ordered or something.
It's a lot of things like don't.
I know.
No, it's just started. It's a while.
Yeah, that is fine, like I can thank you.
Right.
Yeah.
Just,
Just
I'm not.
Yeah.
Not at all.
Get out of
I was
my-
directing everyone.
Yeah.
I don't know what to finish or something, like,
Yeah.
hiring, you're just like setting up everything. Make sure people are aware. Yeah. Hire you. No, no.
I was like, the tuition. I guess the nursing, I'm not sure,
Yeah.
Yeah.
I think that. We don't like what they're doing, you're not as a nurse, but like. I'm like, we know. I wouldn't never. You know, it's for my time watching. I do all this stuff, so thank you. I probably could see it.
Since I finished in May, we're not eligible to apply until we're a year.
Oh, I do.
No, literally. She's gonna do A3.
Right.
That's what I said.
Right, but not-
Yeah.
Like, he was really
Yeah.
Yeah, and she thinks still kind of.
Two, and then
No.
three.
Yeah, I tried to get you something.
Yes.
Yeah.
It is, you can just, yeah, so I was like.
And then they
Okay,
would-
you find out.
Yeah. Like, here, this is-
Yeah.
Yeah.
Right.
That was in my
Yeah.
I'm not even like on any schedule.
Yeah.
Like an hour and a half. I know. I was very big on some issues, just like not sure who's been like, yes, yeah. The issue. Like, yeah.
Look at 6 patients with every time you're up on the screen.
Yeah.
So when you get to that place, you know, 93%. Okay, so this Friday night. They don't tell you, you can't go back and edit anything, they don't, it's only here. So basically, I would do one with this.
Yeah, I see, like, I was like,
Did you watch the video?
All right, we still have a couple people,
Okay.
but we're gonna, all right, so with the chairs, with the chair exercise, we talked about essentially our verbal, you know, as far as our directions and giving enough information, enough detail, but not too much, and all the other things that can be going on around us, and how we say things and distractions and all that. Now, this last thing, some of you, I just gave some cards to. On the card is an emotion or a state of existence. When it's your turn, you need to turn to the rest of the room and you need to portray whatever is on that card. So it's kind of like charades. However, in charades, when someone is close to the thing, you can go like this to let them know, not verbally, yeah, you're close. You can't do that. You have to keep going until we get that exact word. And there's a reason for it.
Non-verbal.
Totally nonverbal. You can't make any sounds whatsoever. And I actually have loving in here, which I didn't hand out. If you had loving, you can't do something like. None of that. You have to. That's so glad it's Friday. So you have to just portray it, okay? No sign language or cutesy stuff. So. Actually, you went first. You went first last time. Let's start in the back.
I went last, so.
Oh, you have. No. Okay.
Trying to get out of here.
Jamie gets a sticker. Okay.
You're gonna have to already get to. Oh, yeah.
That's right. Who else? Who else? You have one? All right.
Yes.
Embarrassed.
Are you doing it?
Embarrassed.
Yeah, I thought you got that again. I was like, you read all the cards. Embarrassed. Oh, wow.
Wow.
I
All
don't know
right.
if that was.
That was good.
It's the embarrassed.
Okay, wait. Go ahead.
Angry?
Wow. You guys are 3 for 3. That never happens. That was a real struggle for you, wasn't it? All right, Johnny, yeah, you're up.
Layla. Layla.
Indifferent.
Comfortable.
Actually, if I always give this to a guy if I can, and they like 99.9% of the time do the very same
What was the word?
thing.
Put their hands behind their head.
If you give this to a guy who was raised in the States, now.
Crazy.
Another data point.
You're a statistic.
No.
Are you a Winnie the Pooh?
And it's a social construct. And you guys proved it. Because the first thing he did, first thing we heard was lazy. Doesn't care, and something else. Somebody said something like chill. And actually, the fact that you said comfortable that quick is actually pretty good because the vast majority of the time, they go for a long time and they'll say disinterested, doesn't care, lazy, defiant. They go through that because the nonverbals, it's a social contract. Even if you give it to a woman, if they don't, if what they do doesn't work the first try, women will do the same thing. Because in our culture, if you ask, especially a guy, okay, get comfortable. In other words, let your guard down. They do, because when you said, lazy or guarded or whatever it was, they always do this. And they always do this. But what are the nonverbals about this?
There's so much I don't care in that. Like, I don't care about you.
Yeah, this is my space. And even this happens in the animal world, in the, what's the bird world? Bird world. Aviary, thank you. Like I grew up on a small farm and we had chickens and we had bantams, which are little tiny chickens. A bantam rooster, as soon as he comes out of the hen house, puffs himself up, strutting around. He's a little tiny bird, but he's got like the Napoleon complex and he's gonna puff himself up because I'm big. That's what this is. This is my space. I'm making myself big. And then this is stay away. Most cultures on this planet, if you expose the sole of your foot to them, it is offensive. And depending on the culture, it's highly offensive. Because the message is, you are beneath the dirtiest part of my body. You are beneath the feces that's on my foot. That's the message. So, good old Americans. But it's a social construct because women will do it too. Like if a woman sits like this and they don't get it, they'll do this because that's what we read as comfortable.
Well, it's also like, maybe a little different for humans if you walk like upright, but when you're comfortable, you're also vulnerable. Like dogs will roll on their back and expose their belly, which is all their like internal organs.
Right. So it's just funny. It happens every time. Now, unless the guy's from the Philippines, then he'll just do this. Because he wasn't taught this. All right, who else has cards? Okay, go ahead.
It's just
Snotty. Judging.
What's it?
Paranoid.
All right. There's more cards up. Okay.
I got one out.
All right.
sad.
Lonely. Oh, well, that was what I thought.
All right, good. Wow.
All right.
I don't even wanna do this one. Oh, wait a minute. I don't even know if I can do it. I'm sorry,
This is actually probably the hardest one.
I was just gonna say,
You can do it.
here,
Shy, guarded,
Anxious?
What is it?
guilty. I don't know.
Actually,
That'd be one.
you actually hit most of the markers. You know, as a student of all this.
Like getting paid, like I took it, I don't know, it's like.
No, right. See, but your eyes were darting, but you didn't look at anything. See, with guilt there's a tremendous amount of internal preoccupation. It's everything that's going on is behind their eyes. So there's this, and somebody said like nervous. So yeah, there's like this nervous energy, but it's not focused on anything. And it's also a primary process emotion. So, I mean, frustrated is one thing, you know, my cries are frustrated. This is like
Yeah, I
soul
was like,
stuff.
oh, when I got that, I was like.
And the
"Wait,
example I
this
use in this
one."
one is from Bellevue. So this woman delivered a little early. And so she had promised the father that she wouldn't do any drugs or alcohol the entire time she was carrying the child. She slipped and she relapsed late in the third trimester on cocaine. And because she delivered early, then now she's delivered, so they're doing the blood test, they're testing the amniotic fluid, and she's like 95% sure that it's gonna come back positive. So CPS is gonna get involved, probably take the baby, and the husband is gonna have a nuclear meltdown. And she's got all of that going on behind her eyes, and that's all you're gonna see. She could be suicidal because she feels so overwhelmed by what's happening and powerless. And she made such a bad mistake. That's the only cue you're gonna get, because it's not gonna be very demonstrative. It's gonna be, you know, that internal thing. So remember, just keep hammering away at paying attention and reading what's going on. You know, because it's not always, you know, the aggression thing. Could be other stuff going on. It's just as, you know, important or less threatening. Do we do them all, or you have one? Okay.
Yeah.
I hope you didn't forget, damn it.
You still want me to go? So I can't do it. I don't know. This is hard. It's easy, but it's hard. I know I can't not laugh into it, which like hurt a little bit.
What is it?
Confused.
Confused. Okay.
That is my-
So this is a really good move. You're crushing this stuff, because I mean, you went 3 for 3 first guess, and that never happens. So you're good at reading stuff. But did we get all of them on the first try?
No.
So, and again, that's a big portion of the communication. So putting all of this stuff together and to understand what's happening is crucial. And the last thing I'll say on this part, and then we'll move on, is I was doing this training a few years ago now. It was a large group like this. And the guy was sitting right here, kind of like where Johnny is. And he goes, oh, yeah, we use this kind of stuff for the place where I used to work. He said, where I used to work, they told us to use love. And he said it like that. And I was like, what? You got to use love. And I said, does HR really know? And he goes, no. And he schooled me right in front of everybody. He said, love is listen, observe. So LO, listen, observe, verify. So listen to what they're saying and how they're saying it. Observe their nonverbals, verify what you think you're doing, and then execute. And I was like, damn, that's good. So you got to use love.
But Steve Wood said.
He said it was okay. Johnny, yeah. Come on, buddy. All right. I can't even see. Page 36. Page 36. So for our purposes, SOS is self, others, and surroundings. So when you're going into a setting or situation, you have to be paying attention to yourself. What's going on with you? Is it a good day? Is it your third 12-hour? You're tired, you're hangry. You had a fight before you came to work, or you did your pay, wrote out your bills, and there's $14 to get you till next Tuesday. All that stuff is there. So what's going on with you? Others, who else is involved? The patient, family, you're having a conflict with a social worker or a co-worker. And then surroundings, is there, this guy's getting escalated, there's an IV pole, is there, what's in the environment that, could affect things. The next page talks about roadblocks to communication. Obviously some of these, like shaming someone, criticizing them, threatening them is not cool. The too much self-disclosure, I think that's in the quiz. You don't want to have too much self-disclosure in the medical setting, certainly in psych and in the ED. You don't want to be sharing too much of your own information because that can really come around to bite you. So the main one on here for me is taking things personal. That leads to power struggles, that leads to hurt feelings, that leads to bruised egos, and we end up with problems. Like actually in the jail setting, if you don't apply, let it fly. Just. And the best way to handle this is actually using rational detachment. So that means you're in a professional setting, and I'm going to consciously make sure I remember that I'm in a professional setting. So this person who's sitting across from me, who is being difficult on purpose, I don't have to take it personally. The other thing I'll toss in here, I learned from one of my clients in my private practice. She worked for Verizon. She was management, so she had to deal with the craft or the folks who climb the poles, the desktop, which is governed by the CWA, the Communication Workers of America. If you know much about that, it's a particularly contentious union. So she had to deal with that kind of stuff all the time. And so we were just talking about staffing and dealing with stuff. And she said, Steve, when I'm in that situation and somebody's giving me a hard time, either on purpose or it's just who they are, I just remind myself the only people that I have to listen to and pay attention to are the people I eat with, the people I sleep with, and the people I pray with. If they're in those categories, then I need to listen to what they're saying and take it to heart. But if they're not, I'll deal with the situation. I don't have to wear their negativity. I could just be me and do the task in front of me. And that particular one was really useful. So when I'm in the emergency room and I'm getting called every, name in the book, it's like, I'm not going to say that. I'm going home anyway. I'm not going to say that.
Yeah.
But I'm telling myself, I don't have to take this. I'll deal with you, but it doesn't affect me in my life. So, and you'll see, we have plenty of staff who've been, working really hard for a long time, and they're burned out, and they're tired of being disrespected, and it's really hard. So, helping each other is a good idea. Page 39. This is another quiz question. So, when it comes to breaking the cycle of aggression or contentiousness, it's one of those all the above type questions. To work with the client, give the client choices so they have a sense of control, take conflict out of the disagreement, negotiate, be non-judgmental. Page 41. And a little bit of time on this one. Now, a lot of the people that we serve, you will be working with people who have PTSD. And so I'll talk a little bit about it so you can recognize it, because they might tell you, they might not. Another professional tip is that in our current societal nomenclature, people really overuse the term traumatized. If you are working with somebody who's truly has PTSD and has been traumatized, that if you're just loosely using the term traumatized, they won't respect you. And the example I have here was actually my extended family. Was at a gathering. I have a cousin who was wanted for nothing. He had a great childhood. He has a good job, wife, kids, has a home in Rotterdam. And this was back during the 2016 election. Or just after. And this example has nothing to do with politics. We're at a gathering in his house, and he's like, I'm just so traumatized by the outcome of the election. And I just wanted to grab him by the throat and put him up against a cabinet. And say, you're an asshole. Because he doesn't know trauma. In PTSD, there's the event. That event changes that person forever. Not necessarily for the worse. They might be a stronger person. But it changes them forever on a neurobiological cellular level. So it's not like, somebody hit my car, or I don't like the election outcome. It's heavy duty life altering events. It can be a single event, like getting jumped, beaten, car crash, severe car crash, or a long-term event like active duty in the military, domestic violence, childhood abuse. But they've been through that event that has affected them. Now, in order to recognize it, hypervigilance. So that person is scanning their environment, constantly being aware of what's going on. So you'll see that in veterans and often with the police officers. They're in a room, they will sit with their back against the wall. So I can see everything around me and no one can come up on my six. So I'm constantly scanning. Like if there are two officer and their spouse going out to dinner, they will pick a seat. Even if they say, oh, here, I have this seat in the middle. No, I want to sit over here. Because I want to sit with the back against the wall and see the people in the room and where the exit is. If you're rooming a patient, say you're working in a clinic or something, and you would tell the person, here, have a seat on the exam table. I need to run out and get something else, and I'll be right back. And you come back in the room and they're sitting on a chair because they're back against the wall. They don't feel comfortable, if exposed, sitting in the middle of the room. Even though there's nobody in the room, I'm exposed, I'm sitting in the chair with my back against the wall.
By the window. My husband is, I'm conditioned to, I'm conditioned to that point. If he's in a room and there's a window and a door, he's gonna put himself right in that corner because he can see the windows.
Exactly.
Yeah.
Exactly.
Yeah.
And it's not even a conscious,
No,
just do it.
it's to the point, because we've been together for 10 years, it's the point where I'm trained to take the seat, to give him, to make sure he's comfortable. So,
Exactly. It's just tolerable.
Yeah.
Hyperarousal. Arousal. Exaggerated response to a stimuli. Often with vets, it's sound, but it could be anything. It could be lights, smell. Smell is our most primitive sense. Well, a little short on the frontal lobe, but suffice. Smell is right there at the top of the brainstem, right by the temporal lobe. So the temporal lobe takes history and experience and is involved in decision making and kind of like well-being and what to do. Smell is right smack dab in the middle. So smell is very closely associated with that. We don't often think about smell as being a trigger, but it really can be. Actually, right here, right now, what is a smell that you know of that just literally takes you to another time and place in your life? A good one.
Usually food. A lot of people say it's food. And is it vanilla? One of I remember.
Well, vanilla is also is a calming.
It's calming, and I remember them saying, even Yankee Candle, I said it was their #1 seller because it's one of the most recognized and relaxing scents.
What that?
A pear. A pear. Like
Oh, going to, okay, it's like.
a pear. That's a pear, and you can smell like everything.
Yes, okay.
Sometimes food, like people smell something from their childhood, like maybe something their grandma cooked or a perfume that.
Right, that's what I'm talking about, like perfume.
X-War that might set you off.
Exactly. Other folks, what's a smell that just takes you to another time and place?
Popcorn.
Popcorn takes you where?
It's just
So neat that it's
yeah.
in the
just-
equal, yes.
I don't even like popcorn, but it makes me hungry. I'm just yeah.
All right, other than food, we got a bunch of food examples, where,
Balsam pine, Christmas trees as a kid.
Yeah.
Cleaning supplies. Like when I walked in here, it smelled like my high school and I was like, whoa. Or like sometimes I'll like walk somewhere, like walk into a place and I'll smell like a cleaning supply, like Pine Sol that I used at my old job. And I'm like, whoa. That's
Yeah.
I don't know why, that's.
It's just that powerful because, you know, that olfactory sensation is really.
You thinking gasoline? I don't know, a lot of people love the smell of gasoline, I don't.
I asked this question years ago and the woman said, oh, I got one. Musty, nasty, stinky parking garage. And I'm like, oh no, because I'm thinking, we don't want to hear it. And so I made a face like that and she went, oh no, it's good. So now we're like, oh, the whole room was like, whoa. And she said, no, when I was a kid, my grandmother lived in the city and we lived upstate and we would drive for what seemed like forever. We would get to the city and we would pull into this nasty, stinky, urine-soaked, moldy garage. And I knew I was one elevator ride away from my grandmother. So I was like, yeah, well, hope you didn't tell her that. Urine makes me think of you.
Those mothballs.
Yeah.
Oh, yeah.
All are closed.
So anyway, smell is very important and actually, well, I have other examples, but I gotta keep us going. All right, so. Intrusive, I know that's not how you spell thoughts, but thoughts. All right, intrusive thoughts. You can be talking with somebody and they don't even need a trigger and intrusive thoughts of what happened to them can just push into their consciousness, distract them, be unpleasant. So just be aware that that can happen. Dissociation, that's losing blocks of time. It can be momentary, it can be long blocks of time. Sometimes there's a trigger, sometimes there's not. If you are working with a trauma survivor and they tell you, you know, they've lost blocks of time or they don't remember a conversation, that could very well be true. Sometimes people will use it as a dodge to get out of something. If they're a little savvy, well, actually kids will use, oh, I have ADHD, you can't get me in trouble with it, you know. But no, it's a lot of the time it's true. And it could be like, you know, just sitting in the room and staring and you walk in and I'm just staring and you keep calling my name and I'm not acknowledging you. It's like, this guy Steve's a real jerk. No, it's just, I'm actually not there. Or the person can be like physically functional. I remember it was the adult partial hospitalization program at Four Winds. It was a check-in on a Monday. And this woman, it was an interesting case. She had been abused as a little girl. She eventually told, it was addressed, you know, going to jail and all that stuff. And it's just kind of put it behind her. And, you know, she went to high school, college, had a career, got married, children, had a good life. Was doing fine. Until her daughter got to be the same age as she was when the abuse started. And all of a sudden her PTSD just went boom. Huge. And this was her most troubling. And she said it was bad this Monday. She said it was a bad weekend. She said, I left the house around, I still remember the story. Left the house around 11 o'clock. Don't know what happened. The next thing I know, I come to and it's 2:30 in the afternoon. I'm sitting in the McDonald's parking lot. No idea. No idea what I did, other than the fact that I know I went to stores because I had a receipt. So here she is driving a 2,000-pound machine, stopping at stoplights, negotiating turns, turn signals, in and out of stores, making change. No memory whatsoever. Total dissociative state. So, and the last thing is flashbacks. So that person is totally back in the event. So if you have a service that he is back there, they can feel the sand in his mouth, hear the gunfire, he can smell the gunfire, the wind on his face, back in. So obviously, if that's the case, we really need to be careful about how we deal with that situation. So, and respect it. Now, when it comes to working with or treating a client or a patient with PTSD, how might we adjust our care? Go ahead.
Could you say a little bit about more what dissociation looks like to us on the outside? Like if somebody's in a dissociative event, can you tell?
Not necessarily, because like I said, it could be. Like I'm looking in your direction, but I'm not looking at you, and you can be talking to me because I'm not here. I'm not even gonna respond. And or like you can have come in. I'm your client. You come in and have a conversation about getting services in the community. And we have a whole conversation. And then on a Wednesday, and on a Thursday, you say, let's finish that conversation we had about community services. And I can look at you and say, we didn't talk about services. Trying to get over.
Pretty normally.
Yeah, so it can present that way. So if he says, we didn't have that conversation. And why are you trying to, get over on me? Tell me we spoke about something, you covering your ass? Because I literally, in my world, I didn't even see you yesterday. So that's where you might pull, oh, really? So I'm wondering, with your PTSD, I'm wondering if you might have been in one of your dissociative. Could be, because I don't remember talking. So you might have to pull apart. But yeah.
Like for example, right now I'm doing forensic nursing. I'm back from my master's in forensics and we're doing SANE right now. So
Right. Oh, yeah.
it's part
We're
of
starting
our,
that day by saying,
so it's a sexual assault nurse examining. For trauma victims, elders, children, women, men, all ages. And part of the interviewing technique, because its focus is like on this. So when you're asking the questions, it's common that it's recognized as like, oh, they're forgetful or they're just avoiding. They're not, because their account of the trauma comes in varying stages. So like they might say, I woke up in bed, my clothes were ripped, and then you're like, okay, well, what was before that? And they're like, I was at a store in the morning. So they're having like this dissociative thing, they're acting normally, they're answering appropriately, but the events are not, they're just not adding up. It's like, okay, well, something happened between you were at a store and now your clothes are ripped. Where were you? And then it's like, you just kind of have to allow them to kind of guide where they're going, because if you start asking different questions and they feel pressured, then it's just going to worsen this whole.
that was very, very well said. Because everything she just said is right. So as far as, as interns working with, you will see that.
But it also can come off as alcohol or drug abuse. It's often people are like, oh, they're just drunk. They were drunk or they blacked out. No, they did not. Their tox screen was negative. There was no drugs or alcohol. It's the trauma.
How about touch? How should we handle touch?
You should respect somebody's personal space, and I wouldn't touch them unless they ask first or something, or.
Yeah, I'll actually ask or alert them. Because they talked about AID when they rolled out AID, years ago. I was like, oh my God, another thing we got to do. And it'll last for like 6 months and then no one will do it. I use it all the time. With a trauma survivor, to acknowledge the person, introduce myself, the data or the D is what we're going to do, get a set of vitals, explain that, and then thank them. That's it. But if this is a trauma survivor, for me to do that, acknowledge her, say my name, tell her that I'm a tech, second shift, I need to come get a set of vitals. Are you okay with that? So if she's a trauma survivor, and she was abused by a guy, She's like, it gives her like 17 seconds. Oh, okay, I'm in the hospital. He's a tech. He's just gonna get a set of vitals. Just walking in, you know, is she's. So
I find the guys on night shift a lot with that, like when they want to do the vitals, they wake somebody up and they're startled, you get a lot of,
this is a great class.
you get a lot of like.
The
like
next
that.
thing I was gonna say
Yeah.
is, if you have a vet, if you have a, usually a vet, right?
And
Tom
they wake up
Side,
and they're startled. They
they will often tell you, if you need to wake me up, do not touch me. And there's a reason for it. Waking up is not an on-off binary switch. You wake up, right? If you're asleep, personally without PTSD, you will go through the process of waking up. If you have a trauma survivor and they're asleep, they don't have the conscious coping skills to manage a flashback or, you know, a flashback. So what happens is you touch them, they'll splinter off into a flashback. And if you startle them and they go into a flashback and they're in hand-to-hand combat, you're going to be on your ass on linoleum before you can blink, because it's hardwired into them to handle the situation. So do what they tell you. And you were talking about personal space. See, again, you guys are touching. There's different layers of personal space. There's the social layer, not social distancing, social layer. So if you and I are in Hannaford in a cereal aisle, you know, okay, no big deal. You can't see your face. Personal space. And if we're in Hannaford in a cereal aisle, I'm sitting here like this.
Making eye contact. Making eye contact.
So obviously I'll get the bubble, right?
Yeah, you like raising rent too?
That usually gets them right back.
So there's first, come on. All right, personal space, but then there's intimate. And in healthcare, I mean, you're in that intimate. Yeah. So reading this person's nonverbals and listening to them and talking with them and make sure that they're comfortable is really important, because they're in there all the time. Also, the closer you get to someone, often our patients are sitting down or laying down in bed, which are vulnerable positions. The closer I get and I stay standing, what is this besides being really close? Threatening, dominating, it's power differential. So if this is a trauma survivor, I'm dominating her. If she's not triggered, she pretty much will be. Also, the closer you get to somebody, as far as like effective care, the closer you get, the more you want to be down on eye level. Because I could be down, come in the eye level. I can sit here for 60 seconds, explaining to her, oh, lab results came back, they're looking good. There's one that's a little off, but the doctor's not that concerned. It's looking really good. But they just came in and I wanted you to know. Less than 60 seconds. I could also stand in the doorway. I could stand here for 4 minutes and have a similar conversation, even share more information and leave. You ask her in 2 hours, which conversation was the longest and where she got the most information? Which one's it going to be? The 60 seconds sitting, because I'm looking at her eye level, and the message is, I'm here, we're discussing this with you. Versus standing in the door, the message is, I'm going to give you this information, but I don't want to get hooked in talking to you, so I'm going to stay here standing so I can. That's what I'm saying. And you let, and you know, you're all professionals, but I do this with the nursing students too. You know, we have to learn how to guide those conversations so that, yes, we don't get hooked in it. And we end up having to stay there for half an hour because we sat down. But so yeah, just.
You ever notice that like height differentials factors in?
Height.
Because, yeah, well, because I'm taller and like my the doctor I had, she's like 5'0". And so like me sitting, me sitting is the same as her standing. So when she sat, I still felt like I was towering over. So I didn't mind that she stood because we were the same height then.
Right.
But like but sometimes like I find myself, because you know, like I'm 6 foot, and you know, like if I don't lower myself down to some people's level, like I feel like even though I'm not acting dominant, like they're like I don't want them to think like you know like I'm towering over them.
That's wise and sensitive.
Yeah.
Okay, so there's other stuff here that I think is quiz stuff. On 90, the middle of the page, talks about 90% of mental health clinic patients have been exposed to trauma. That's an OMH number, and it's really high. So when you think about like who we treat at the clinic, almost all, and that's for a reason, because they grew up in a lot of these illnesses are genetic, so they probably grew up in a household that had mental illness or chronic mental illness that might have affected parenting or the safety, and they probably are on disability, so they don't have a lot of money. They're living in a low rent, high crime area, so there's a lot of opportunity for our folks to have been traumatized. Yeah. The last thing I'll say here, because I have a number of studies I could share, but I'll trim it down to one, just to go over the fact of how much this affects us. Some of you might remember back in 1993, David Koresh had a cult in Waco, Texas. It was a religious cult. He was the godhead, and it involved the physical and sexual abuse of women and children. And when the authorities in Waco found out about it, they went down to shut down the compound. And he locked down the compound. They negotiated out 23 kids. Negotiations broke down, and then they went into take it by force. And the long and short of it was the entire compound was burned to the ground, blown out, burned to the ground. So now you have these kids who grew up with long-term longitudinal abuse, and now a single event, all the people they know and love on the planet are gone. So Bessel van der Kolk, not Bessel, Bruce Perry studied these kids and was working with them on the trauma and that kind of thing. And physiologically, what he found, even years out, over a decade, years out, their heart rate was in the range of that of an infant. Just never slowed down. Even through their teen years, into their 20s, their heart would just never slow down, and their breathing was fast and shallow, unless they did that. So it was helping with the psychological trauma, but also literally helping them with their body, so their body didn't burn out. That's how much they were affected by the whole thing. All right, and if there's somebody that if this area is of interest to you, Bessel van der Kolk is a really good read. Brilliant man, MD, psychiatrist. His latest, The Body Keeps Score, is really good. I've met the man, I presented with the man. He's really impressive. All right, page 42. So, good old Maslow and his hierarchy of needs. So if you look at that, if you look at Maslow's hierarchy of needs, before we get there, probably 3 or 4 decades now, we had a mayor who is Schenectady, who his philosophical approach to governing was to get anybody who wanted public assistance should get it. And so if you wanted disability or and public services, get an EBT card and all that, he made sure that either through DSS or they come into the hospital and establish as a resident and say that that they had a disability and they get it. And word got out, and Schenectady people with disabilities flocked to Schenectady. And I had a colleague from Vermont and another one from out near Buffalo tell me the same thing I experienced right here in Hills treating people, that they would say they were suicidal, come into the hospital, sit down, say, I'm suicidal, I have depression, I want to get my disability papers. Oh yeah, And we would say, no, we don't do that here. You have to, yes, you do. Well, it says here you're from Brooklyn. Yeah, I am. But, you know, I was in a taxi and the taxi driver said that if you want to do anything on disability, definitely go to SNCC. So everyone knows this. So people flock here. Short of it is, we have a very high per capita population of people who are on disability or people who want to live on public assistance. Hence, we have a very large population of people who are at or below the poverty. With that said, you know, with that very high level of homeless individuals and all that, where do they fall on Maslow's hierarchy of needs? Yeah. Right. The survival, yeah, you're right. Right there at the bottom. So. Here, Mackenzie, I want you to help me. Everybody on this side of the room needs to get 3 pieces of paper, including yourself. So we're going to hand out 3 pieces of paper to each of you. And what I want you to do is, I want you to write. I want you to think of the 3 most important things to you in your life. Not on the Maslow thing. What are the 3 most important things to you in your life? And I want you to write 1 each on these 3 pieces of paper. So you're gonna end up with 3 pieces of paper that have something written, 1 thing written on it. The 3 most important things to you in your life, one each. Everybody have a pen?
Yes, it's like that.
All done? Okay. Here, Mackenzie, I'll help me. All right, so you have the 3 most important things to you in your life. I'm going to take one of them. So you're not sharing it with me, I'm going to take it. You can pick which one it is, but you know, I want you to essentially give it. So go ahead and get one from each person.
So random.
All right, so I now have family, my friends, support system, home, my family, relationship, independence, career, my family, my faith, family, dad, love, peace, career, my dad, my Father's Day today. Stability, food, and self-esteem. I want another one. now have money, respect, health, my daughter. High satisfaction with work, family, boyfriend, health, happiness, my house, education, money, safe water, career, family, financial security, health, my dogs, and confidently in my career. Yep.
Greedy. We should just went with the
Right?
flow.
Because one thing about the news-
No, I lost.
All right. I now have my husband.
Not him.
Not a guy, not a guy. My husband, family. Want to love and care for. Job, family, faith, family, kids, safety. Clean air to breathe. My pets. My mental health. Happy connections, mom, family. Willow, my kid. Health. My kids, family, support. All right, what's that feel like?
Hopelessness.
Hopelessness? Depressing and sad.
I'd literally be dead. You took away my food, water, and air.
So, and literally. Other folks, what else? What's that like?
Hopeless.
Got nothing. So when somebody comes into the hospital, say we have that homeless person, and they've got a doubled up plastic Hannaford bag. And in that bag, he's got a picture of his family, DBT card, social security card, extra pair of socks, another shirt, and a steak knife for protection on the streets. And he comes into the hospital, gets picked up by SPD. And what do we do with that when that homeless person comes to the hospital? So, yeah. Give me your bag. That's everything he owns. The bag. We'll lock it up for you. Give me the bag. Take off all your clothes. That's the only clothes that they have on. Couple shirts, jacket. Let's take all your clothes, take them off. Put on these paper scrubs. Oh, by the way, if you have an underwire bra, you gotta take that too. So we strip them of everything they own on this planet. Ridiculous. So now we have to. It's a safety thing. How we do what we do is so important. Because if we're not doing that with dignity. You get the point. Everybody stand up. Spin 360 to the right. Yep. Spin 360 to the left. And say hello to two people. Bump shoulders or elbows or whatever you want. All right. Okay, sit back down. I brought you to an unpleasant place. I need to get you back out of here. So. Enough said. All right, this next section, it's a big thing for OMH. I think it's a moderate for us, but I'll cruise through it quick. So jump to page 46. Now, they're big on the notion of a stress versus a crisis. So this is a list of things that are stressful. Losing your job, divorce, winning the lottery, which I would take my chances on, but death of a parent. The bottom line is actually the next page, page 47 is a quiz question. What keeps someone from going into crisis is if they, in OMH terms, if they have equilibrium. So if they have balance in their life, they're much more likely to handle a stressor and handle it because you handle the stressor versus having the event kick you into crisis. So that's the quiz question. I think it's if someone goes into crisis instead of stress, it's because they have disequilibrium or something like that. Okay. A more useful way to look at it is page 48. And this is useful not just in the professional domain, but also in our real life. So we don't really call them balancing factors anymore. We call them protective factors versus risk factors. So in column A, there's 3 areas of life. There's the perception of the event, social support, and coping skills. So if we look at those 3 domains, if a person has a realistic perception of the event, they're more likely to handle it. If they have adequate situational support, they're more likely to handle it. If they have decent coping skills, they're more likely to handle it. So if you have a woman patient and she's got an illness or a situation and she understands the situation, and you ask her about support, she'll be, oh yeah, my sister lives in town, my husband is supportive, and I'm in a cell group at church, so I have support. And coping skills, oh yeah, I like to walk the dogs, I like to knit, I like to cook. So there's things that I can do. Versus your second patient who is a guy and he hears the word squamous cells, and it could be cancer. He's freaking out about this. He's not really paying attention to the fact that it's actually pre-cancer. It's not that bad. What supports do you have? Well, I work nights and I live alone. I have a pet iguana named Charlie. And coping, well, I either watch TV or if I get stressed, it depends on how stressful it is. It's either going to be Sam Adams IPA or 1792 bourbon. So he self-medicates. This he's much more likely to go into crisis than our other person, right? So just looking at those domains and helping them with the situation is good. Now, this chart, page 50. This chart is also in your take home. I want you to find this chart. It looks different, but find this chart in your take home packet, please. So what I want you to do is I want you to go down the columns and I want you to circle or put a dot by, however you want to do it. I want you to indicate what are your personal symptoms of stress. What happens, and you might not get them all at once, but what are your own symptoms of stress? Okay. Keep going for that time. What did you notice about you and stress? Are they in a particular column? They're all over the page. You were surprised by what you found. What did you know? Hey, we'll do this in a general sense. Because I don't want to get too specific. Like if you have if you get forgetful, you have angry outbursts, poor concentration, you get diarrhea, we don't need to know. Keep it general. What did you notice about you and stress?
In general, like overall, I would say I'm more physiological.
Yeah, so it affects your, yeah.
Like anyway, I'm able to like focus to my job that I'm internalizing, obviously.
Okay. Okay. Yeah.
I think it depends if it's like chronic stress or an acute stressor, the reaction
Yeah.
is different.
Yeah, that makes sense.
I noticed the more obvious ones that I could think of were physiological, like I had to kind of think about the cognitive column and behavioral, like it was more obvious.
Yeah, okay, okay. Anybody else have an observation?
I can't shut my brain off, so I don't sleep at night. Like if I'm looking at this.
Yeah.
I lost my appetite and I don't eat.
Kind of go hand in hand. Yeah. Yes, so the reason I have us do this is one of the few exercises that I kept from the previous trainers who were absolutely. It was, oh, never mind, maybe I'll tell you later. It was painful. But this was a good exercise. Because we are in a high stress, high risk pool when it comes to like jobs. We're not like firefighters, EMS, police, they're but the risk pool that we're in, we are much more likely than the average individual to experience depression, anxiety, self-medicate with drugs and alcohol, experience domestic violence, and suicide. So it's really important that we're paying attention to what's going on with us, because you're dealing with pain, you're dealing with stress, you're dealing with heartache, you're dealing with people who are struggling, and that's cumulative. So if we're not taking care of ourselves, it will catch up to us. So I don't want you to be a statistic or get burned out. Like that was a sad story from your previous job that you just couldn't do anymore because they were just the way they were treating you.
I'm healthier now.
Yeah. I worked with, he was the chief of a volunteer fire department up my way. Very wise man, very highly respected. And it came time for him to retire. If any of you like police officers, firefighters, EMS, come, firefighter. And the role is important to them. And it's like, had that fire, move on. Had that call, move on. And that's how he lived his life for decades. And when he retired, he didn't have the role anymore. And shortly after he retired, his wife was telling him, you need help. And he was a little stubborn at first, but being a wise man, he was like, yeah. And he wouldn't meet with me in my office. I ain't gonna go talk about Shrek's office. So we would meet in Dunkin' Donuts. And so here we are, the two of us sitting in Dunkin' Donuts. Now, here's this big hard man getting misty-eyed. Why are we doing this in Dunkin' Donuts? I don't know. Glad you know that. Anyway. So he's like, Steve, I'm remembering shit from 25 years ago. The last one was I still remember this. He's like, the fire, we put the fire out. We thought we got everybody out, but we didn't. This body of this woman just fused to the couch, like all one piece, and the smell. And it's just going through the whole thing. It was this. So he didn't have true PTSD because he didn't have all the other symptoms, but he was having this symptom because he never took care of it as he was going through it. So it was all just there. And as soon as he lost that role, it all was just coming back. So once you realize what it was and that it was normal to just, okay, you have the memory, you can just let it go. It's not, it doesn't mean that you're crazy. It doesn't mean there's anything wrong with you. It just means that you are now remembering this stuff and you never dealt with it back then. So it literally took care of it pretty quick once you understood. But I don't want you to end up in a situation where you're having all this stuff going on with you because you weren't taking care of yourself while you're doing your career, okay? Actually, the next page is page 52. It's strategies for managing stress. That's also in your take-home packet. A lot of this we already know because we're in healthcare, but we in healthcare are notorious for taking care of everybody else and taking care of ourselves last. So, you know, not taking too much overtime. Yes, a good diet is important. Good sleep is important. Smoking isn't a good idea. A bottle of Pinot Grigio every night. So, yeah, I just want that to. Okay, turn to page 54. Now, this page is also in your take-home packet. The one in the binder is incredibly sophomoric. This thing looks like a 4-year-old did it. Find that crisis cycle in your take-home. It looks much different. Yeah. I'm going to go through the next several pages all at once. All right, now we're gonna already start pulling our stuff together. If someone is triggered, and I don't necessarily mean with PTSD, but someone is getting upset by something. How can we tell? What can we be looking for? How are we gonna know? What's that?
Posturing, like how they're nonverbals.
Yeah.
Are they, hands on their hips, or they,
Keep going.
Pacing.
Yes, pacing, increased energy, pacing, mild agitation.
respiratory, like if they're huffing, if they're.
Yep. Verbally, they're getting louder, more agitation.
Every 5 seconds.
What's that?
Calling every 5
Okay,
seconds.
yeah,
Coloring.
yeah.
Their faces get
So-
red.
Yep. So a lot of that was like an increase in energy, pacing loud, or it could be a decrease in energy. It's a change in affect. It's a change in presentation. Because, there are plenty of people who, when they get upset, they shut down. And actually, they can be more dangerous than the ones that will act out, because people that are acting out, you can tell what's going on with them, right? Somebody who shuts down, you don't know when they're gonna pop off. So recognizing that change, when we need to make sure that if we recognize that something's going on or a change has occurred, to address it then. Gee, a little while ago, we were sitting in your room watching TV. Now you're just sitting and staring at the wall, with the TV off. It's something different. Is everything okay? No, I just got a call from my grandson's probation officer. He just got picked up for possession again. He's probably gonna go to jail. So now that grandmother and grandfather lay in that bed, they're gonna start getting agitated. But now the fact that we recognized it when we saw it, we can now oh my gosh, how can we help you get the social worker in versus dealing with an explosion? So use their strengths. What kind of sports, what kind of coping skills, start to research all that stuff so that we can take care of it while it's small. So a lot of times that doesn't happen, so they start to escalate. This, when it comes to the code gray and running things, that's our window. You want to catch it obviously more sooner than later, and there's a number of things you can do. You can give them choices, like say I just do psych because I can pull it from it. Jaheim wanted to go home, and he's not ready yet. He thought he could go home. He can't. The doctor, said no. You can't do it. he goes blasting out of the meeting, the conference room with the doctor. That mother effer. So, oh, Jaheim, you wanna talk? Leave me alone. I want the radio, shove your fucking radio. Do you wanna go to your room and chill out? So, because we control so much of their environment, to be able to give them choices, even picking from our choices, it gives them a sense of control. So if we can find something, great. Also, the more that this initially, as they're escalating, their awareness of their environment is very acute, and they're like we said, hypervigilant. The longer this goes on, that actually diminishes. Adrenaline, noradrenaline, cortisol, all kinds of those chemicals are dumping into their system. Blood is going from their organs to their muscles. Fight or flight is kicking in. So our opportunity to engage them without going hands-on is getting more and more and more narrow. So we really got to do our best to try to again, use their positives. Do they like music? Do they like the color? Do they like the, what can we do to help them to try to de-escalate? As far as the crisis is concerned, later on when we do a mock code, we'll talk more about that, how that goes. When somebody is in full-blown crisis, they are 20% stronger just due to chemistry. So don't underestimate that, that 14-year-old coming in, or that, skinny 18-year-old or whatever.
96-year-old grandma with the cane.
Right. Don't underestimate them, because their body is in fight or flight, and they're going to be juiced. So they go into crisis. So maybe we can de-escalate it. Now, in Ellis Medicine, who are the nurses here today? That's good. In the Ellis Medicine system, you are the one who runs the code. Okay. So you're the one who gets to decide when the code gray is going to be called, unless the person was on one-to-one, and the one-to-one is, he's going after the one-to-one. The one-to-one can scream, "Hey, call a code gray," because they're trying to get away from him. So in those kind of situations, anybody can call a code. But overall, it's the nurse who runs the code, and he or she can decide. If you know the patient well, and they're usually a lot of bark and no bite, you might wait and try to do the de-escalation because you know how they function. You don't know the patient, and if it feels unsafe, here, call a code. I track all this stuff, so I would much rather have. Actually, I should have brought some. Shoot. I'd rather have a lot of codes, and the vast majority of them be diffused. Then, because some people, I think it's more on medical floors, they, I won't call a code. If you feel unsafe, call a code. If we get there and you don't need us, great. We want you to be safe. We want you to make sure that you have enough people to do what you need to do. And nurses, it's your clinical judgment. Having a bunch of people show up, our security officers are dressed in black. They've got a flak jacket on. They're pretty imposing. And maybe having a bunch of security officers show up would make things worse. So then you can call your code, but tell the security officers to stay outside in the hallway, out of the line of sight until needed. You can do it wherever you want. Or maybe you get there, you get in there. He's already, throw a plate against the wall and strutting the tech. And by the way, he has a fork. Okay. So yeah, we'll pick that up later. The recovery is after the fact. There's two parts. One with the patient, the treatment team, or after the code may say, listen, you got triggered by not being able to be discharged. You escalated despite people trying to help you with how to handle it. You went into a full-blown crisis. So you tried to get off the unit. You pushed the tech. We had to call a code. You refused any meds. You ended up with an IM and at 4 points. That's the extreme example. So now we can talk with that patient. Listen, you got triggered. All that crap happened. It didn't have to happen. What can you do when you get triggered while you're here and in your real life? Well, chilling by myself and getting away from everybody is usually what works best for me. Okay. So while you're here, we will see if we can make that happen. And by the way, in psych interns, I use this a lot, because doing the visual talking about what their triggers are. Like with a borderline, feeling rejected, or I call somebody, they didn't call me back, or whatever it is. Identify the trigger, what the process was, kind of like chain analysis, like this piece, to this piece, to this piece, to this piece, and then you cut. So now let's pull this, what is something else that we can do? Like, what is something you can do here? It's usually in that first third. If they don't catch it in the first third, and they keep going, it's really hard to stop them. And if you want later, maybe during lunch, I have some other like action method stuff that I can share with you that you can use. That are really simple. It's not like full psychodrama where you're gonna get down into all kinds of stuff and they're gonna start flipping out. But it's like hands-on, kind of like this stuff that you can use if you want. So there's that, and then there's for staff, we do a debriefing. A lot happens in like 3 minutes, okay? Everybody gathers at usually the nurse's station or someplace after the code. Johnny's with the security officer. He will have a sheet like this. So say this is the group of people who responded to the code. Everybody who responded to the code needs to sign this piece of paper, whether you went hands-on or not. This is how we track how many we had come, what discipline, that kind of thing. So we all sign this. So here, this will come out. This will be getting passed around the nurse's station. Now, so Liz, it was Liz's code. So Liz, we're all gonna gather at nurse's station. In our system, it's security that enters the occurrence in the MIDAS, because there's an algorithm that needs to be followed. And if we try to teach everybody to do the same thing, it doesn't work. So they enter it. So what has to happen is Liz is gonna say, okay, Jamal, this is what happened. So, because he needs to hear the narrative, because he's gonna enter it. So what was the trigger, the escalation, throwing things, swearing, blah, blah, blah. I offered him PRN, he refused. We called the code and, it was de-escalated, or we called the code and he got even more angry, more threatening. The doctor ordered an IM, V52, so patient refused it, wouldn't take them voluntarily, we had to go hands-on, patient ended up in 4-point restraints. So now he has what he needs, and then he'll ask, were there any injuries? With regard to that, if you, like say Mackenzie was attacked, she was on the knee, and he went after her, and she dodged the punch, but she caught her hip on the chair, so she, tweaked her back. Liz would be like, you know what, you need to go down and get checked out at or in the after hours fashion. That's important. If you think that the injury is significant or could be, you gotta get it checked out. Because if she goes home, that happened on a Thursday, and then by Monday when she comes back, she can barely walk. She's had 3 days, 2 on the weekend, where said there was no injury, but now you're saying you can barely walk. And it's important just for the line of succession. That code happened. She went to employee health. She left. She said she didn't feel so bad, but over the weekend. So now when she comes back, it's verified. And if you have to go on disability or workers' comp, that's all neatly done. If you have to backtrack, it gets really wonky really quick. So now the flip side is if I bang my finger on the door jamb and I got a little nick on my skin right here, a little bit of blood. Wash your hands, get a Band-Aid, and stop whining. Right. So that's first aid, and it's not an injury. Now, if we did go hands-on, they will be printing out this sheet. This is the attendance sheet. This is the hands-on sheet. Say it was the 5 of you who went hands-on, the 5 of you would need to sign the sheet. Okay. So Liz will have orchestrated that. all of this is happening at the same time. And then it's like what did we learn? What went well? What could we do better? So we might figure out that this guy, if he doesn't calm down, like really quickly, once he crosses that line, it's off to the races every time. So just call the code. Because trying to negotiate with him when he gets it, his mindset like that doesn't work. So you'll learn those things as you go. Any questions about that stuff? Because like I said, the code part we'll do later. All right. Page 61. I don't think this is on the quiz, but it's another acronym, Q-tip, quit taking it personally. And again, that often leads to power struggles and that never goes well. Page 62 is in your take-home packet. Again, it looks different, but this is more like a tip sheet, really. As far as if things are escalating, one, knowing your patient and how they operate, what their goals for their misbehaviors are, the medications, that's good. Knowing yourself, what like we talked about this morning. If you're in a good space, great. If you're not, you need to know that. Being aware of your surroundings, and that behavior is a form of communication. So next page is this one. It says environmental safety. These were added due to our event and an RCA. This has to do with environmental safety with regard to weapons of opportunity. So the back of that picture, back of that page is a photograph or a picture. These are all items that have been used as a weapon one time or another. The exit sign came off the ceiling of C3, the site floor. The guy ripped it off the ceiling and was breaking it apart to get sharp pieces of plastic to stab the staff. Pens and pencils. That's what this one came from. We had one patient who was really paranoid and largely nonverbal. He stabbed another patient in the face with a pen. Fortunately, he had glasses, so it didn't get him in the eye, and it broke his orbital bone. Utensils, toothbrushes, the comb. The guy broke all the interior teeth out of the comb, so just the back of the sharp hook. The lotion and the toothpaste and the cup. Those are everyday items. Oh, I didn't talk about self-injurious behavior. Duh. Back up here, one of the common symptoms that somebody with a borderline personality structure will use that makes that, remember we talked about the stigma, but is that they will engage in self-harm to like reel you in. Sometimes they'll hurt themselves in places that can't be seen and that cause pain, and it's the pain in the blood that is the payoff. Unfortunately, a lot of the time it's, you know, I got scratched myself with a fork, it's suicidal. That's so I'm trying to reel you in using self-harm. Those are items in the hospital, the lotion, the toothpaste, that the crimped plastic or metal is sharp enough that people will cut with it. So if you're on a medical floor, you have to. So if you go in and there's a toiletry container and it looks like there's ketchup on the toothpaste, I doubt that they were smearing it on their hamburger. It was probably something like this. So yeah, so just pay attention to those kind of things. The next page is environmental safety with regard to ligature risk. The leading form of attempted and completed suicide in the hospital setting is strangulation. So if you're on a one-to-one medical floor, wherever, you want to make sure that any item that they can strangle themselves with is out of arm's reach. So that means hoses, tubes, the telephone, plastic bags, they all need to be, and actually, and who are the techs today? So for you, if you're on a one-to-one for somebody who's having suicidal ideation, you want them to keep their hands visible. I was at a conference once, and the psychiatrist, who was a real hoot, he said, "No one ever killed themselves with their feet." Yeah. And it is important The picture on the back of that page is one of the trauma rooms in ED that shows, and all, even on our medical floor, there's hoses and actually this came from an event where there was a guy on the medical floor who we did not know he was having suicidal ideation. And he was actually a tech, thank God, was just rounding on her patients. He had wrapped a pulse ox cord around his neck and he was blue. And the tech didn't have to be in the room, but she went in the room just to check and save his life. So, and also, and this is also for nurses, you will have people, and actually, these folks love to be in a hospital. 24-hour care, people are awake, taking care of me. That's heaven. So, we had a woman well known to us, personality structure like that, was on the medical floor for medical procedure. I don't know what it was. The night tech had a can of soda. And he wasn't paying attention. The patient got hold of the can of soda during shift change. Day tech came on and she would lay in the bed with the covers up. And when he would look away, she would be mumbling, fumbling under the covers. And when he would look back, she'd be still. That happened a couple times and he was like, this is odd. So he says, you know what? I just got to check things out. I just want to make sure that your IV is everything's okay. So I just want to just pull the cover down and just check your IV. So he pulls it down. There's this big pool of blood on the bed. He's like, oh my God, the IV was over here dry and intact. She had taken the can, worked it in half, and was cut the heck out of the thigh. So again, just read what's in front of you. This next section, the outpatient mental health, is woefully out of date. CDT, continuing day treatment, doesn't even exist anymore. We now have pros. And this actually, a lot of this was written because in our old building over at Lafayette Street, it was this broken down, decrepit. It just felt nasty. Just the whole environment versus the environment you have now with this nice new building, lots, bright and clean and all new furniture. And so we used to have a code team over there. We don't, because we just don't need it. It's a building full of social workers who are very empathetic to taking care of people. So we just don't, you have patients who get loud from time to time, but you don't really need a crisis team or a code gray team or anything like that. Just to be safe. So watching what clothing you're wearing. You don't want to wear scarves or be careful about wearing ties. But even then, if it's during the winter when it's dark at night, if you want to, go to your car and have somebody with you, go in pairs, because we don't have, social workers and ICMs they're not driving people in their cars anymore. You don't have to do home visits or anything. So it's changed a lot. So the safety factor is much better than it used to be for the outpatient department. Page 68. This is another quiz question. And it's kind of, I would say it's tricky, but I think the question is something like, what's the first verbal calming technique that you should use? And the answer is listening, because it makes it sound like one of the things you're supposed to say, but the first thing you're supposed to do is listen. Now, this whole thing about get yes, I'm going to show you something that is really useful in whether you're doing an assessment for a medical patient or an assessment for a psych patient or even substance abuse. In the psychodrama world, they talk about going from periphery to core. So you're going to start on the outside and you're going to just listen while they're telling you something. If they're not listening to you, they're not a cooperative patient. That's where things can get interesting. And the best thing, the best way I can describe this is, there was a Russian psychodramatist who did a really cool, but really simple study. And it was about getting yes. He devised two intake sheets that were distributed randomly. One was to get yes, and one was probably here to probably get the answer no. So if they're not talking, the next easiest thing is to ask yes or no questions. you can set yourself and the client up for success by getting a yes. And his questionnaires was, the yes one was questions like, was it a long drive? Duh. Were the conditions difficult? Duh. Is it cold outside? It's northern Russia. Duh. Yeah. So there's a yes, yes, yes. Versus questions like, are you glad? Now, this is a clinic for mandated clients for alcoholism and domestic violence. If you know anything about the Russian culture, it's extremely private. You know, what was it, the SS, or what was it? You know, if you defied the Communist Party, your family would just disappear. So you didn't tell anybody anything outside your family. So he had questions like, are you glad to be here?
Yes.
Do you agree with the judge's decision? Yes. No, no, no. So those interviews, I mean, came to a screeching halt. But the yes, asking, you know, was it a long drive? We know it's long. Yes, yes. So yes is a more connecting answer. Then, next layer in is to ask open-ended, non-threatening questions. Can you confirm your address for me? 1, 2, 3 trolls in the row. But it's non-threatening and it's giving some information. Then you can keep working your way in. Once from there, then you start to hone in on what the topic is. But this works. I've used it myself many, many times. Page 70. Now we start moving into like the de-escalation stuff. Yeah, we're still ahead of the schedule. So, page 70 is nonverbal calming techniques. So time away. So in other words, if you have two people that are not getting along, just like in parenting, divide and conquer. So it might be like in the ICU. Who's the ICU again? A lot of the time it's family in the ICU because you have really, really sick patients. They might be having those end of life conversations. And now the family, the patient isn't even conscious, but the family is having a fight. I mean, yeah. So that's, you know, so splitting them up. Maybe someone has to go home. Maybe someone needs to go get sober before they had another conversation, stuff like that. So splitting people up. Body language, I feel like I really talked about that pretty well, reading the situation. You certainly do want to present down the bottom right that you're, you know, alert, caring, in control, attentive, those kind of things. I think we covered that sufficiently. Selective focus, sometimes ignoring the behavior is the way to go because they'll be doing some sort of acting out or creating a ruckus. And if you address it and give it attention, you get more. So sometimes just ignoring something and when it doesn't get the desired effect, especially with kids, it's over. Eye contact, I think we kind of talked about that in our culture for the most part, it's necessary. You don't want to stare at somebody, but proximity, I think we talked about that sufficiently. Touch, I think we talked about that sufficiently. On medical floors, it's a little different, or on geriatric floors, I think, you know, putting your arm around somebody or giving a touch on the arm or something like that can be comforting. You just need to, you know, read the situation, read the client. Limiting the audience, I'm actually going to add that in a different spot. Jump on over to page 75A. Some other de-escalation tips. Some of them seem obvious, but they're important to go over. Now, 1, to be empathetic and non-judgmental. Like I said before, a lot of the people we serve, whether it's mental health or poverty or whatever, they anticipate being treated with like a second-class citizen, talked down to, not, you know, with disregard or disrespect, that kind of thing. So the more that you can show that you are non-judgmental and you're treating them like everybody else, you're winning from the start. Respecting personal space. for safety's sake is important. It's good to stay an arm and a half or at least a leg length away. I think that's equivalent to this question, leg length away. Because you want that buffer. So if somebody is gonna pop off or we didn't read it, or they just spontaneously, get aggressive. You want that buffer to, plus you don't want to get too close to them, like we said earlier. Non-threatening nonverbals. Number 3 is important. We had a tech. On why. You've already done. So. We had a tech. Well, first, when he would go to a code, his nonverbals to assert control of the environment was to walk in like this. Captain Cobra. Just piss it way up. And so one time he was doing a 1-to-1. And so right now you'll be the patient, you're just gonna walk around right here. This is how he would be a 1-to-1. Strutting. Now, reverse roles. So this is Ryan. So I'm getting more and more pissed off because he's just hounding me like this. So finally I turn around and I go like this. Reverse roles. So. Like that. Kind of enjoy it. Ryan grabs the guy. It was on video, but he just like grabs him, throws him over his shoulder, throws him on the ground, is kneeling on him, holding his face like this sideways to the, and thanks. That's all. First roll. No. If you want to teach the rest of that. No, you're saying, okay, go. Yeah, if I was gonna do a video of all the things you can't do in a code, he checked every box. It was like the most hellacious thing. So as soon as the whole thing was done, I just said, go home. Because it was just that bad. He was excited. And he wanted to be a code gray captain. He wanted to be somebody who's like, I'm gonna go take her. It's like there's not a chance in hell that you're gonna be overreacting. You see that a lot in people who are just burned out, tired, and they just, or a patient is particularly trying and we just lose it. So help those staff out. Focusing on the feeling is a little bit of an art, because patients and visitors, family members, often they're with us because something's not going well, and people then take their anger out on us because they feel out of control or whatever. So rather than focus on the anger, like say I'm the son of an elderly woman, my mother, and she's in the hospital and she's not doing well, and I'm out at the nurse's station. Somebody needs to get in there and take care of her. They haven't changed her sheets. I think she's soiled. This place isn't any good. So I'm taking my anger out on you. Anger in that situation is a secondary emotion. There's a more primary process emotion going on underneath it. Like, well, what is it? What's underneath my anger? Yeah, I'm afraid I'm gonna lose my mother. I have no control. So rather than deal with my anger, Mr. Wood, you coming out here yelling, it's not gonna help your mother. You can say that. It's not gonna be very helpful. Or, Mr. Wood, I'm so sorry. You're right. She has been here in the hospital 3 times in the last 4 months, and she's just not responding the way we hoped. I can't imagine what that's like right now. It's got to be really, really hard. In just that little intervention, you've gone from an adversarial situation to now connecting with me here. And actually probably going to have a better relationship to be able to actually, the response is going to be, I'm so sorry. I just don't know what to do. She's not getting better. I'm just afraid. Then you're all set. So focus on the feeling. Ignoring challenging questions. You think you know me? Stuff like that. Just don't even. That's like throwing a big old spinnerbait right out. Just go ahead, like. Just ignore it. Don't take the bait. setting limits, so yes. We have to set limits when patients or family are getting more difficult. Make sure you choose them wisely. If you're, because if somebody's being difficult and you say, well, we're just gonna call the police on you. Probably not. So you've eroded your credibility. We'll call a code, security will show up, but. Just like in parenting, I mean, you know, parenting, you're not gonna tell a kid, you can't watch TV for a year. You see, you know. So choose them wisely. And allow silence and time for them to make a decision. Another that yeah, because if you set limits, they need to think about it. Also, and ignoring challenging questions. You know, and you've all seen it before, when people don't get what they want, when they want it, or how they think it should be, they'll create a scene. It used to be more of an urban kind of thing. Now it's everywhere. People don't get what they want, when they want it. I'm going to disrupt your waiting room. I'm going to be screaming and yelling. It's a tactic. It's a manipulative behavior. I'm going to create a scene to try to make you feel uncomfortable and all the other people in the waiting room uncomfortable so that you'll give me what I want to shut me up. Rewarding that kind of behavior, sometimes we have to, but there's a couple things you can do. One, like I said, remove the audience. That behavior has much more power if there's a lot to witness it. So if they're in the waiting room, in the emergency room, take them aside, don't have that conversation, because now all the drama, there's no audience. Also, somebody who's timid might have a hard time with this, but to actually address it, label the behavior. So if you have somebody flipping out at the nurse's station or whatever, to say it to them.
What you did, I understand you're frustrated right now. I would be also, but we are here to take care of yourself and your family members, make sure everyone here is safe. And what you're doing right now is hindering that. I will get there as soon as I can. Can I get you something in the meantime? But you have to call it out, because if not, like I've done it when I was younger. No, I'm not at a point where I don't care at this point.
Yeah.
It's for the greater good. That one, you can't cater to the one because 20 are going down based on one.
Right.
So.
And if they keep it going,
Yeah.
to be able to say to that person, okay, because I clearly see that you're really upset. It's very important to you. However, by creating a scene here in the waiting room, that's not going to get you what you want any faster. So creating a scene isn't going to work. I definitely want to work with you. Really, it's important. So just take a moment, and I'll be right with you and disengage, because the message is, I know what you're doing. Now you know. I keep popping off, creating a scene. I already told you. So now, hopefully, they'll at least be like, well, okay, I tried that, didn't work. So maybe they'll cooperate. Maybe they won't. Maybe some people just do it because they like to create a scene. But it does work. Page 76 is the last page of your take-home packet. It's a do and don't list. A lot of the stuff we already talked about. So so I put it in there as kind of as a summary. Actually, we're already into the afternoon stuff. So actually, it's the perfect spot to take a break. So why don't we try to get back? Okay, I'm not quite as familiar with this area. I know if you go over to State Street, there's like go up to 12 and take the left. There's State Street. There's a bunch over there.
the Chinese Thai place. There's a bunch on that stretch.
So our concierge will take you.
We've been here a few times.
So yeah, so why don't you go ahead, get yourself something. Come on back and we'll pick up. If we get back like quarter of, 10 of. And actually, if you want to go get food and then bring it back and eat here, we can do that too. I'll get us going. Yeah. Yeah.
You're good. You're good.
I'm gonna go to Stewart's. Do you want anything? Angie? I'm gonna go to Stewart's. Do you want anything?
I
Okay.
brought food to someone bum, I didn't want to leave.
I brought food too, but I like need coffee.
Yeah. If I drink any more coffee, it's not gonna be a good thing.
I think that we're having this conversation, so my youngest son, sat in the first time in personal space, the first grade. Literally come in contact with the teacher. This is the message that I got yesterday. I've been checking it, he switched schools in first grade, he's got some adjustments socially,
yeah.
So she said to me yesterday, she's like, this is the message I got last night. Thank you for checking in today. This morning was okay. The afternoon was very tough. He was all over the carpet, choosing not to follow directions, putting hands on other friends and getting in those spaces. I had to have him take a walk with Mrs. Appleton to get some of his energy out, but that didn't seem to help either. We will continue to build stamina back up for school and continue to look for positive behavior to reinforce throughout the day. Literally, she just messaged me again. I was like so afraid to open it, like. So we shared a conversation last night. She just said, she's like, I just want to let you know, Gavin had a pretty good morning this morning. He earned a couple warm fuzzies in our big jar. Trying to, but I didn't go. I go, same. Even my first one, I'm going to the principal's office for. I just want to say too, you're awesome. You're awesome. Like you're just like really like I have never taken a class like this before, and like just all my nursing, and you're really your teaching style, your method, you're engaging, you're like. Not saying this, but even this morning coming here, I was like, I gotta take a training today, like 8 hours,
Yeah.
But
That's, I know that that's the vast majority of the time, that's.
Yeah, that's where you're like, I'm not
That's the
gonna do
mindset.
PowerPoint, like you're really.
That's the mindset that people are coming in, and I know that it's gonna take me, probably the first hour, even if I
To
tell
gain
them
it,
it's
yeah.
engaging, that the first hour to break that ice. And then people start to sit up
Yeah.
and then they start talking, just like this, it happens every.
Yeah, well, you have, like I said, your gift is also special, that's why I just wanted to say that to you,
Well,
it's
thank
like, you're awesome, the way that you teach.
I'll go grab a Cliff Bar or something.
Good plan. Geez, Aaron finished our lunch late. I didn't realize you were like, right on it.
I like this graceful display.
I thought that was me. I was like, what?
get alerts whenever there's code.
I get alerts every time my husband forgets something.
Angie, do you know Krista's last name? by chance?
I can ask. She's on maternity leave right now, so.
Oh, well, do you know who does your time then?
So here's the weird thing. Christina Moran?
Oh, Mr. Russo?
Yeah, Russo, thank you. Yeah, Russo. But it's Christina Moran, she does the time, but she left, but technically she's still hired on to do, because Krista's on maternity leave.
Yeah.
And Krista got Christina's position, so it's kind of like gray area right now, it's kind of like self-governing a little bit.
And let's see.
I know, I saw you got all the talk, like, Krista Russo.
Yeah.
Or something like that.
Honestly, it's kind of like shared responsibility right now, between Lauren, Dana, just like Krista, Christina, like Jen, I don't know, it's all, so.
I know, it's like tricky.
Yeah, it's a little dysfunctional, but like a working dysfunctional.
Word.
Yeah. Is that for like the time card? Okay, it'd be Christina Moore at the time.
Yeah, oh yeah.
Okay, cool.
I was aware of that. That Christine Moran was helping until she came back.
Yeah,
To make sure it's right.
it's all through email, but she's still really
Mackenzie, do you do your own time or who else is in this?
I think actually Millington's doing it. I don't think Erica, because when I asked about my time card, Ashley said she was approving them and stuff.
And Elizabeth, do you know who the nurse manager is applying for?
Mandy Richardson. It's probably an email as Amanda Richardson.
Yeah, it is. And Mackenzie with, I know Elizabeth, is she still doing time for the staff?
It's a good question, because I see her in her office sometimes.
Well, yeah, but that's because of she got injured, so I think she's still on.
They haven't hired anybody for the nurse manager.
Yeah, so who's doing all the time?
I'm gonna guess either Erica or Ashley then. But I don't have a confident answer on that.
Isn't Ashley off next week?
I think so. I think she gets married next week.
Yeah, yeah.
I think I guess she's still the board meetings next week. I guess she's still gonna call in for that. But
Okay.
do you want me to email Erica? Ask who's doing time
Yeah, if you could,
for the nurses, sure.
because yeah. I also have to figure out who does C4, C6, A6, A4. Oh, no, I have it for.
Does Christina Curcio, is she a public force, or is she? or is
You
she-
know what? She does so much. I have no idea.
That's why I'm thinking maybe, because she does a lot.
Yeah, I don't know. Oh.
Do you want to introduce something for your video? And then just let's see if we can get in about one. Yes, and there's nothing in the email. Okay, so we need to send it to default. Let's see if it'll work. It may not connect. I don't know why I sent him an invite to my meeting. Um, It's dumping him in an empty world. It's not letting him see this one. The only thing I could say too is. So your meeting is this number. Yeah, that's what I said. 'Cause that's my standard number. Oh, no, you have 410 at the end. And that's in the. So it's 842-1954-10. Is there a passcode? Because usually if there is a password, it say it right here too. So you know, it should just be that number. But that's here. Well, it would play a sound when someone joins. He's been trying to. So yeah, this can just stay. Well, you can make this be minimal, yeah, because I don't want this to be in the way of your video. And then once you are done, if you want to go back to just using the whiteboard, press VGA so that you can come over and just raise up the screen. And then you can go back to the whiteboard. Are you done after the video?
No.
But you would be done using the.
Yeah, then I'll
projector?
just rate that back up.
Okay, yeah, and then all you have to do to get that off your screen is that VGA.
Okay.
Alrighty, cool, thanks, Steve.
All right, thank
You
you.
need something to figure that out the door. And maybe say something.
Okay. Okay, I think we have everybody back. I think he just went to get his water. So if you're eating, go ahead, keep eating. I'll get started again. So to get your head back in the game, what was something from the morning that stuck out to you? You got something from it. It was something new. I don't know. What stuck out to you in the morning, first half of the day?
So on a personal level, my husband is a veteran and he has PTSD. And sometimes we'll have conversations and literally, I don't know, if it's I always thought it was selective listening. I'd be like, oh, we were talking about it. And I said, you said you would do this. And he'll be like, I don't remember. And it happens all the time. And now I realize that he probably was disassociating. It's not just me asking him to take out the trash. It's conversations about something we've done or something I do need him to do. And I was always thought wow, he's just not interested in what I'm saying. But now I think it might be partly that coping.
Yeah. Yeah, and it doesn't have to be anything stressful or anything. It can just occur. Other folks, what'd you see? What'd you get?
I think you did this training for everyone since with the pandemic.
Yeah.
Not just nurses.
I would take something similar, which said like my boyfriend's a deputy sheriff, so all of a sudden you're saying things in 30 minutes like this, it started resonate. I can put it with examples. And whatnot.
Okay. Any other observations? Yeah.
I've taken quite a few versions of this through different studies, and I honestly not just to be ass kissing for the way you're presenting the material, I think it's easy to grasp. And I've never in any of them in 32 years seen the building block models. Because that's a concrete way to see something, and some people don't learn, they're visual learner, and that was pretty.
That's, all of this, see, the content is, the modified version from OMH. All the rest of this stuff is all stuff I did or added. Because I think
it's very dry, you read it through here and then take a quiz, but the hands-on, I thought honestly, I'm not gonna lie, I'm this is
I did the same thing.
I'm not even gonna lie. And I was here we go again, how many times am I gonna do this?
I know that every month I'm sitting in front of a room full of people that are saying, this is gonna suck. I have to sit here for 8 effing hours.
Yeah.
And that's why right up front, and then you and I just had this conversation.
Everybody
I
left
said,
for
even
lunch,
though-
I walked up to him and said,
I said, even though I tell people it's not a PowerPoint, it's interactive, behind their eyes are yeah. And it takes a good hour for people to realize this ain't so bad.
Yeah.
It's okay. I can actually listen to this.
When you
And-
said we're taking a break at 10 a.m. and I looked and I was oh my God, that is 2 hours. That was I looked and I was oh God.
and she's been up all night, right?
Yeah, I was
So-
I don't think I'm
she's
making it.
engaged.
Like,
so she's been
honestly,
up all
I was
night.
I don't
She's
think I'm
engaged.
making it 2 hours. I was getting ready to start propping my head, and then I was 20 minutes in. I said,
Okay, well, good. I'm glad you're finding that the format is, and that's what I talked about, doing things active.
Yeah.
You're using a different part of your brain, you retain it differently.
Yeah.
It's much more user friendly. So anyway, thank you. Go ahead.
Just as a new grad, we've kind of just adapted what's right or wrong in the hospital, and going over the crisis model. I had a patient this week where we deny every treatment, everything, and then when I got there, my preceptor and we gave him options to make it his terms, and it's kind of your crisis scope. And because we did it and making it fit him, think it was his way, he accepted everything that we asked him to do. It's just kind of cool to see it in word form.
Yeah, cool. All right. Anything else? All right. So after much monkeying around, I think we've got this set. Now, this is an active shooter video. we've adopted this. This is the model that we use at Ellis Medicine. So we'll watch this. It's an 11-minute video, and then we'll talk a little bit about how it applies and all that. So,
the amount of policy your healthcare organization will be using and the training video you're about to watch are based on guidelines developed by the U.S. Department of Homeland Security. As you will see, we've applied these recommendations for healthcare settings in our community. I encourage you to watch this video, perhaps a few times. Fight to memory. I also encourage you to speak to your colleagues, administration, and management about what you learned and what policies and procedures are in place at your facility to help you survive an active shooter incident. This training will force you to imagine the unimaginable, but I hope you will imagine it and think of how you could respond if this happened on your floor, in your clinic, or on your shift. Your life may depend on it. Thank you.
As healthcare professionals, it's hard for us to imagine facing an active shooter taking lives in the very places where we work so hard to save them. Sadly, shootings can happen anywhere, including hospitals and healthcare facilities. While we all hope we will never have to face this kind of deadly situation, it's absolutely critical to understand what to do if an active shooter enters your facility. That is why the Mesh Coalition, representatives from Marion County hospitals, and advisors from law enforcement work together to research and propose a model policy for responding to an active shooter in a healthcare setting. This policy, approved by the boards of directors for both the Mesh Coalition and the Indianapolis Coalition for Patient Safety, serves as a template so that Central Indiana hospitals and healthcare organizations can create their own facility-specific policies for responding to active shooter incidents. An active shooter incident can occur in your facility on any day at any time. Excuse me. Yeah, where's 214 at? Thanks. You have just seconds to react and 3 actions you can take to help make yourself safe. Run, hide, or fight.
The perpetrators are varied. The venues that they select are varied. The victims that they select are varied. Their mindset is to create the most amount of havoc, death, and destruction in the shortest amount of time that they possibly can.
With this type of training, it ensures that all of our hospital and healthcare providers understand how our emergency and first responders will be reacting to these situations, so that we will have similar response, people will have similar training, it will make it much easier, and as a result, could potentially save lives.
In law enforcement, the common phrase is you will react as you have trained. So you're going to do something. The question is, are you going to do something that could potentially save your life?
Let's go. Let's go. This one. My front. Hurry.
If you can't evacuate the area, leave immediately. Don't bother to take anything with you. Encourage others to go with you, but if they don't follow, don't wait.
On a scale of 1 to 10, 10 being, stay here, stay quiet.
If you're with a patient who cannot escape with you, discontinue care and leave. If you can, secure the patient room upon exiting. Do not stop to help the wounded. Exit the area immediately.
So running preserves your ability to stay alive and preserves your ability to respond to the patients who may need your care after the incident. We may be abandoning that patient for a short time, but if we aren't there to respond to their medical needs after the shooting incident, we're going to help to them. So think of it as conserving your resources.
When exiting, keep your hands raised and visible. If you encounter anyone else, warn them not to go into the area. Avoid pointing, screaming, or yelling while evacuating. If law enforcement is present, follow their orders.
Law enforcement would direct the threat past casualties, past a lot of victims, be able to end the threat. And it makes a lot of sense because more death is going to fall unless that is done as a priority.
Move a safe distance away from the facility. If law enforcement has not arrived, follow your facility's procedures for reporting the incident. This can be to call 911, call facility security, or press a panic button if the area is equipped with one. Make the report, even if you think someone else already has. Do not attempt to re-enter the scene until law enforcement has given an all-clear announcement. Depending upon the situation and where you are, your best option may be to hide. The best hiding place is one that is out of the shooter's view, provides protection from gunfire, and doesn't trap you or restrict your movement. Block the door to prevent the shooter from entering, and hide behind large objects like cabinets or desks. Remain silent.
Look for places where you might be able to hide behind locked doors, maybe a medication room, maybe a supply room.
We labeled on our floor the safe places to hide. We've instructed our nurses to barricade the doors, move the beds in front of the door, barricade it, and put the patient, and maybe even yourself with the patient in the bathroom, and lock the door, turn off the lights, and just try to act like no one's there.
Follow your facility's procedures for reporting the incident, but only if making the call won't give away your position to the shooter. If anyone with you is injured, do what you can to attend to them while remaining hidden. But while you are hiding, you must also think through what you will do if the shooter finds you. Although it should be your last resort, prepare to fight the attacker.
Incapacitating any kind of suspect and stopping him from doing what he had been doing is your goal there.
If your life is in imminent danger, prepare to fight. Your goal is to disrupt or incapacitate the shooter. Even yelling or throwing objects can help by confusing the shooter and making it harder to aim. Act as aggressively as possible. Your commitment to your actions will mean the difference between life and death.
The more you have in numbers, the greater your chances are to be successful in defeating someone that's even armed.
Think of run, hide, fight as more than just what to do when faced with an active shooter. It can be a way of thinking about your surroundings every day. Whether you are always in the same place or you change locations frequently, make it a point to know key features of your environment. Know where the exits are, including stairwells. Know what rooms can be secured and locked. Know how to lock down your area or unit if possible. Pay attention to where phones are. Find out if the facility has panic buttons and where they're located. Know your facility's procedures for reporting an incident so you know who to call and what to say before you ever have to pick up the phone. Be aware of people around you. Keep in mind that an active shooter won't fit any specific profile. He or she may look like any other visitor, patient, or coworker you might encounter on any given day.
We don't want to be too worrisome about it, but we do need to be prepared as a community.
We've
been trained on what to do in code situations. So the more that we're trained on this and the more that we practice and have drills, the more hopefully your mind will just go into motion.
Rehearse in your head what you're going to do if this situation were to occur.
Where you can hide, where you can exit, what can you use to fight? Those are not common thoughts, and they need to be. The best weapon you have is knowledge. And something as simple as gearing your mind to run away from the gunshots can save your life. And having the state of mind to take as many people with you when you go saves other lives.
Make run, hide, fight your mindset every day and train yourself to make it your strategy for survival.
So that is the protocol that we use. Here in the Northeast, statistically, we are less likely to experience a mass shooter. We are a soft target, just like a mall or a school. Hospitals, however, tend to be more broken up. So yes, we have a cafeteria, but other than that, there's a lot of rooms, and so it's not a high casualty target like other areas. We are, however, more likely to experience somebody who's coming to the hospital to kill a particular person. So a scenario like a disgruntled patient coming back, or a disgruntled employee coming back, or domestic violence spilling into the workplace. So if you're on a service line or a floor, and somebody has that stalker X with a restraining order, I mean, they might not want to be talking about their personal business, but knowing who's supposed to be on the floor and who isn't is a good idea. When we had the lockdowns, it did help with just having a lot of people on the ground. But now we have visitors, and they get screened and that sort of thing, so that part is helpful. At Knott Street, I think we're doing it in other places too. On the doors that you can lock from the inside, there'll be a 3-inch blue circle on the outside of the door. That indicates that you can go in there, lock the door, and that's a safe space. Now, having a big window like this would be problematic. That's why they had these. They did have somebody called in a threat here. So in order to lock the door, you can pull this down and the shooter can't see in. However, you have to make sure that you're going and doing that with all the windows. Otherwise, the only doors with the felt down means there's people in there. But so yeah, and if you can run and get out of the building, just run home. Doesn't matter, just go. If you are in a building, they will, the cops will be called and wait for the all clear. Don't be like, well, I've been here for half an hour. This is boring. We're going to go. If they do call code silver active shooter, they will tell you where it is, so you know which exits to go for. Because if they just call active shooter, you don't know. So it's like active shooter A4 elevator bay. That means you need to go run the other direction from A4. So if there was cold overhead active shooter, and we could hear gunshots and we didn't feel like we could bust some screens out, I guess, and get out. where would you hide in this room? Say those doors, that windows didn't open, where would you hide if this was the room that we were stuck in? This corner, behind the podium. Yeah.
We try to barricade the door with the podium.
You could. I was actually just wondering that same thing while I was sitting there, but I think
Like,
there's wires that go to the
like, I
floor.
think crazy things like that. My daughter's still have an active shooter. So. I'll try not to-
Everything was okay, but it's scary.
Yeah. What would you fight with?
I have Tom shears with me, so I would try that.
Yeah, anything. We're throwing chairs. We're, yeah, throwing chairs, barricading tables. We do anything we could. So, and yeah, a lot of people have a hard time just leaving the patients, but we would need to do that. And out here in Schenectady, the SWAT team, we have cops that are also paramedics. So they would be responding, and they would be the ones to, even though you're all nurses and healthcare providers, they would be the ones to triage, the injured until it was all clear that the shooter was dispatched. It pretty much covers it. Yeah. All right, so we're on page 78. Page 79 is a quiz question. So like, what are the goals for physical intervention? It's another one of all the above jobbers. Help the client regain control, provide safety, teach the client better ways to cope, maintain the client's self-esteem, and try to build a relationship with the client. Page 81. So now we're getting into the code gray, the actual code. There's been de-escalation that we've tried. And if we're going to go hands-on, so what's that look like? Like we said before, the nurse is the one who's in charge of the code. Now, that can take many, many different shapes. A lot of the time, it's the nurse that the patient is upset with because the patient wants pain meds and they can't have it. Or the nurse is reinforcing that they can't go home and they're going to have to stay another night and meet with the treatment team in the morning. So the nurse is often the one the patient is having a hard time with. That doesn't mean he or she relinquishes that role, because there's a lot of things that go into this. I'll finish this page and then we'll kind of do a mock code. So the nurse is running the code. If that's not possible, or you can have the nurse manager, assistant nurse manager, or nursing supervisor on the off shift also assist in running the code. So they're going to be overseeing, making sure that everything is running according to plan, according to policy, and how we handle things. Staff members who are responding to the code need to go to the nurse or whatever and find out what's the desired plan. Is this guy who's on alcohol withdrawal, we're going to get him back to his bed and we're going to medicate. Okay, so we know what we're doing. So most people will go to like the nurse's station to where the nurse is, find out what he or she wants to have happen. Some people will go right to where the situation is to keep a lid on it until we have a plan and we know what we're going to do. Another thing I didn't say here, the other people who can run the code are people who are a code captain. So what they would have in this badge buddy. So nurses, this is most important to you. Somebody who has that code gray captain badge buddy there's about 24 of us. Ryan, yeah, Ryan, he was code gray general. I'm just totally derailed with that. So code gray captains can also run, and actually we instituted that because usually in the ED and psych, they're pretty solid because they do it often. On the medical floor is not so much. So a code gray captain can come alongside that nurse on the medical floor and help them run that code so that they feel confident and they know what to do. the auxiliary staff or you, the full responders who are showing up, we need to be quiet, we need to be professional, we need to make a plan. If, in case it's gonna go hands-on. The nurse who's running the code, if the patient has some issues, we need to know what they are, but I'm getting ahead of myself, so we'll get that. So let's, I'm gonna need 3 volunteers. Because we're gonna need a patient, a nurse, and a tech. And you're not gonna have to act. It's not like you're gonna have to perform the role play. We're gonna do what we call surplus reality. So we're all gonna do it together, but I need people to hold the spots so we can see it and do it at the same time. So I just need 3 people. 1, 2. You're a nurse, right? Gotcha. Nurse, you go stand over there. You can be our tech. You can be our patient. Yay. All right. So we'll use their real name. So we have Alexis, Mackenzie, and James. All right. So let's build our scenario. So we have Alexis, who is our patient. So what's her deal? She's bipolar. Man, she's bipolar and manic. This could get fun. So she was disrobing in one of the not bus terminals, those little bus huddle things. What do you call those?
Fishbowls.
Fishbowl?
Yeah.
Fishbowls waiting for the bus. So she's there, she's yelling at people, she's yelling at cars going by. And so cops picked her up and she's coming to the hospital. She's familiar to us. We know her. And I don't need to be here. I'm tired of this effing place. You keep like me. Sounds you keep trying to put me on those effing meds. I don't like them. They don't make me feel good. I don't need them. I want to leave. You can't hold me here against my will. You're violating my human rights. And I want a fucking cigarette. So that's what you got. All right.
That's the normal. That's every day.
That's every day, right? That's pretty close.
It was like, yeah.
How many bookers were there in the pod yesterday? 5?
5.
Yeah.
I was on a Sunday, myself and 1 tech and 1 security. We had 3 in the pod that day.
Yeah.
And it was that I need my Nicorette gum. I need it literally.
Because this is pretty close.
Yeah.
Pretty
So
close.
she needs her Nicorette.
Yeah. I want an effing cigarette. I want to leave. You can't hold me here against my will. This is the cops, yeah, and she's pressured, but she's with it. She can have a conversation. So Mackenzie is the tech. So Alexis is Alexandra.
What'd you say, Lexi?
Lexi. So Lexi's having a hard time. That's what she's saying. That's what she's demanding. That's where things are at. So if you were Mackenzie standing right here, how would you try to engage and de-escalate Lexi? What would you say? What would you do?
You could like acknowledge, you could say, it looks like you're really upset right now. What can I do to help?
Open the fucking doors.
Give me. Oh, can I curse in here?
I've been cursing all day.
I almost just watched myself. I was gonna say, give me a fucking cigarette.
All right, but she says, how can you help me? So, okay, so you give me a cigarette or open the doors. I don't need to be here. I don't want to be here. So that was good. Keep going. Prime the pump. You're priming the pump.
So wait, I just have a question. So the cigarette and the doors, they're not optional. So we gotta go to.
Cigarettes definitely
So
not
then
optional.
Right.
you could say, well, cup of coffee?
Oh, yeah, let's give an angry person a hot cup of coffee.
Yeah. That'll make me more manic.
Turkey sandwich, a warm blanket.
Yeah. Turkey sandwich. Iced decaffeinated.
I'll take all of it.
I don't, all right. So since we don't know if she's taking any drugs, she probably will be NPO for at least a little bit till she's cleared by medical. So
What's NPO?
nothing by now.
Thanks.
Thanks. Actually, I should have said that this morning. When I'm tossing around terms like DSM and stuff like that, or NPO or IM, because I'm making the mistake of using all the medical jargon. So if I'm doing that, just like slap me upside, don't literally slap me upside the head, but just what's that mean? Thank you. I'm glad you asked the question.
You can pull the patient aside, like not in like the waiting room, or I don't know where this is happening, but if it's like, you should probably remove them from where all the other people are. I mean, like if it's a waiting room, and then just say, you know, we can't, or I don't know, I really.
But that's why we're here.
I've never really.
I would say something like,
But
it sounds like you're
that's
really.
why we're here. That's perfect. I'm glad you're trying. I'm the phone. That's perfect.
I would say something like, it sounds like you're really frustrated, which, you know, if I was without my cigarettes for a certain amount of period of time, I would get really upset myself. Just try to like relate to them in some.
Okay,
aspect.
let's hear, listen, apologize, resolve. The listen part, we're all good. She won't stop talking. We know what's going on with her. She's manic, she's pressured. I don't want to be here. So we know what's going on here. What might the apologies thing sound like?
I'm sorry you're upset. Start like that, I mean.
Sure. It can be a bunch of different ways. Yes, I'm sorry you're upset. Keep going.
That you feel we're keeping you here. Or something.
Okay. Yeah, I'm so sorry you feel like we're keeping what we are keeping you here. I'm so sorry. No, keep going. I almost, come on.
What were you gonna say?
No, I was gonna say it. I don't.
I'm sorry, we're keeping you here. It's, you know, it's my job to keep you safe. I'm doing my best to do that. Can you work with me and we'll try to decide like, what's the best way we can do that to get you in and out of here.
Let's work together.
Yeah.
Let's be teammates
Make
here.
it sound like you're on a team.
Okay, definitely what you can do. Keep going, listen, apologize, resolve. Here, I want to hear more about it. Remember the whole thing about apologizing and validate, not collude, validate. I want to hear that.
Say what.
Feelings are
Repeat back
valid.
what they
Feelings
want.
are valid.
Yeah.
Thank you.
Yeah, just to say like, yeah, if you feel like you're here against your will, you want cigarettes, kind of just.
What I hear
you're
you
hearing
saying.
them. So it's like, you may know that you're
Feedback.
listening.
I'm your friend.
Just kidding. We could have a cigarette later.
Yeah.
Meet me at my car.
So in this, initially, you want to try to make that connection, like the whole team thing that you were talking about. So you want to somehow create an alliance if you can. I am so sorry that you had to go through that. You know, you said that you were brought in by the police. That can never be something that anybody wants.
And then I would try to find something like common ground that I can, that's what I found in general, like you can relate to someone, so they feel like you're. on the-
I wouldn't start there though.
No, I know what I'm saying, but eventually, like, that's what I.
Right, so you would build towards that.
Yeah.
I'm so sorry. Go ahead.
Sorry, so if she was disrobing at the bus stop, you could ask her if she'd be more comfortable if we gave her some clothes, like gave her. Like,
Well, let's say she's got her clothes back on, so she.
So my first.
You still have her half naked standing in the hallway. No, they were able to kind of put that back on. No, she just, let's say.
If I was disrobing though, would I be naked in a cop car?
No, they would have, we're saying that they would have, I'm not saying that you completely disrobe, but are we hung up on that? So she was just. So she was.
Your scenario.
But it's real.
It's very real.
People who are bipolar are very often hypersexual.
Yeah.
So her clothes are back on. She's been brought in by the police. She can't leave until she's been cleared by a psychiatrist. So she's saying, I'm here voluntarily. Nobody said that I have to stay here. I want to leave. So I'm so sorry that you're in this situation. You know, I can't imagine what it's like. You must be really, really frustrated. I can't imagine. So you want to camp out in that whole validation thing so that, you know, she's
Gain trust.
right. Like you said, you're saying things to validate or so that she hears that we're here. So that's what Mackenzie's going to be doing the whole time. Just, wow, I can't imagine what that's like. That must be really difficult, you know, feel like you're here against your will and, that's just, and remember, we know her. So now we can also say, and Lexi, I hear you. You don't want to be here. At the same time, you kind of know how this whole thing works. So, and this goes to what some of you guys are saying. So the sooner that we can get you into some scrubs and assigned to a room, the sooner we can get the doctors in here to get this whole process moving. So, but you can't push that too soon because they're like, you're just making me. Now, and so, some of you, I can't remember who said it. When you get that whole thing about, like, I just want a cigarette. Use it. That's like a huge open door. Because now Lexi's like, oh wow, that's gotta be really difficult. By the way, how much do you smoke? Pack a day. Geez, no wonder you want a cigarette.
Yeah.
That stuff, I mean, it's so hard to, you've got to be licking. No wonder you want to leave and have a cigarette. Now, we who aren't nurses, we can't offer anything because we don't, we can't talk about meds or doing meds like that. Now, so she's doing her best to engage and bring her down. The nurse is going to show up in a relatively short amount of time. A really solid thing to do, if you're this person, is when the nurse shows up and say, James, Lexi here is really upset. She feels like she's being held against her will. She doesn't want to be here. She says she doesn't want any medications or anything. And she's just really jonesing for a cigarette. If she can take all of this and condense it and feed it to the nurse, her experience is at least this one gets it. Even if she's not feeling good about being here, this one's paying attention to me. So there's this subtle alliance now that's starting to build.
So she'd say it in front of me, not like.
Absolutely. It certainly within your hearing, because now it's like, holy, all right, I just said all that stuff and she just was able to say it as well. So that's good. That gives him all the information he needs to know because he's just arriving on the scene. So now he can validate, you know what, you're right. It's really hard to be here. I'm really sorry that these are the circumstances for you. If you want, I can certainly, call the doctor and it's too late in the day to give you a patch, but I can certainly try to get you some nicotine gum. If that can help at least a little bit. So now at least she's going to feel like, okay, they're trying to work with me. I don't want to be here, but at least I hate the stupid gum, but it tastes like crap, but I'll take that. And now maybe since we knew, the cops called ahead of time, he might even have already talked to the doctor and he might have like some PRNs available. But so he might be able to say, hey, you know what? Lexi, I know that you don't want to be here but that you've been here before. And the doctor has ordered 10 of Zyprexa. You've had it before and it has worked. Can I get you some of that Zyprexa or some Seroquel or whatever? So now she might agree to that. She might not. Let's say for training's sake, no, I don't want any of your effing meds. I don't want to stay here. I'm here against my will. I'm not staying. I just want you to, all I want you to do is open the fucking doors. That's it. That's the only thing I want. So now she starts to escalate and she starts pushing on the door where she's getting more and more agitated, starting to posture a little bit. James might be like, okay, this isn't going well. We need to call a code. So he calls the code because maybe now she's starting to threaten. She's starting to threaten Mackenzie. So let's say we are the group that respond to the code. When we get there, one, we need to be professional. One of the problems that I've seen that's been brewing a little bit lately is that people get there, they find out what's going on, and while they're waiting for the order for the meds from the doctor or whatever, they're joking around. It's like a little, hey, and we have a couple of security officers, and you probably know who we refer to, who get there and they kind of joke around a little bit, because it's just them being charismatic and friendly. This is not time to catch up with with people and hang. If we show up and we're waiting for the meds to be ordered, and we're like, or I don't know, yeah. So if you and I are laughing about something, what does she think?
They were laughing at her.
She thinks we're laughing at her. Or we show up and we're like, who is it? It's Lexi. Oh, geez, it's not Lexi again. I mean, you might be able to talk a bird out of a tree. We just destroyed everything that you guys have been building because we're out here talking about her. She can hear. So we have to be professional. Please, if somebody's joking around, just, give them this, because it is happening, and I've seen it bother the patients and erode this process. So be professional. Now, we also need to go to James and find out what's the deal, what do you want to have happen? Well, we want her to go to room 20. I'm going to offer PO. If she refuses it, we may do IMs because she's already getting aggressive and she's only been here 5 minutes. So, okay, so now we know the plan is to get her to change into scrubs and to go to room 20. So we're gonna be trying to work that situation. And so this time though, she's dug in her heels and she is not going. I'm not taking, you're not getting my clothes. I'm not doing any of that shit. I'm just not. I'm sick of this. So now she started, like I said, getting aggressive. So the code has been called. She's getting more aggressive. She kind of went after Mackenzie. So Mackenzie had to kind of step out because she's now focused on Mackenzie. And it's not an ego thing. If this is you and the patient's focused on you, and that's what's igniting the situation, it's best for you to just remove yourself. It's not that you did anything wrong. That your presence is just making it worse. And like I said, a lot of time it's the nurse, because the nurse is the one saying you have to have meds, or you can't have meds, or yes, you're staying. So now, even if it's him, so he might have to remove himself and have another nurse will step in, but he's the one talking to the doctor. He's the one calling the shots. Often it's actually like in the care team by the emergency room and a psych, the nurses really do well tag team. They just go back and forth and they just kind of run the code together. It can look like the tech is the one running the code because they're actually the person standing there doing all the talking, because it might be that she has the best report. And actually the person who's doing the negotiation in any situation like this is a person who has the best report. It's not an ego thing. A lot of the time, security, they know them from before. Security has dealt with them before, or they might be up on the floor and security has had them downstairs at Care Team 5 or whatever. This could be a code on the floor, on the psych floor, and she's angry at all the psych staff. You're all awful. You're keeping me here against my will. Johnny shows up and they were okay downstairs in Care Team 5. So now she'll just completely focus on Johnny. These motherfuckers, blah, 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 blah. But now that's a huge opportunity for him. He's like, Lexi, dude, what's going on?
What's up?
Yeah, what are you doing downstairs? This is all new. And then he's gonna turn to the nurse. So what do you want? To go to room 20 or to go to whatever. All right, so Lexi, okay, whoa, come on, come with me. And then use motion. And she's let's see. So we're negotiating at some point. So say she continues to get aggressive and the doctor says, okay, do IMs. So now the last choice that she has is, Lexi, you're getting increasingly agitated and upset. We're worried, like your phrasing was wonderful. We are all about safety. This is a safe place. I know it was rough on there on the outside. You're in a safe place, but at this time, because of your behavior and your actions and your unpredictability, the doctor has ordered shots. So you can either take these shots willingly and you can chill in your room, or these people are going to go hands-on, and we don't want to do that.
But also still offer the PO meds again, because that gives them an escape from the whole situation. And that'll resolve the whole
It can, although if she ordered PO, if they ordered POs, offered POs, they didn't take them, and the doctor says, no, we're going to do IMs, where it's kind of hard to turn back from that. Although and you can make that call, because sometimes when you talk about the shots, you're right. They're like, oh, no, I'll take them. So then that's kind of a judgment call on the nurse's part. All right, I'll do the PO. But if she's really agitated or she's just playing because she doesn't want the shots, but she's gonna keep going. Yeah, but that is a good point.
How come an inpatient, they could, if they're refusing, they would just go to court and then you would go there? Would you go? You would do all of this before? Because I feel like a bunch of people in the inpatient refuse and like aren't on meds.
Well, right, they're mentally ill, they refuse to take their medication, so eventually we have to take them to court to medicate them over objection.
Yeah.
Yeah.
But now I'm getting medicated.
Oh, yes, because you're straight in off the street, you're not medicated, you're dangerous, you're impulsive, and you could be violent, so yes, we will medicate you right now, even though you don't want it, the doctor has ordered it in order to calm you down.
I think that's like pertaining to like the everyday, like every morning or something.
Yeah, when they're in the-
refusing that, like for the
Yeah,
orders.
so if they're refusing standing meds, that's when you go to court.
Okay.
So so James has called the code, and so now Lexi's there. We've already checked. So the responders are all going to kind of get into a semicircle here, and we're all standing here. Now, we're also, I mean, we're not going to be this close. Yeah, we'll just back up a little.
I feel like this is more threatening.
Well, that's kind of the point, because we called the code, she's uncooperative, so
We're at that point.
So
I didn't know. I was so
we use
scared.
what we call the bladed position. So actually, you guys are, this is perfect. Now he's, hang on, don't move. So you don't put your hands back in the pocket. So this is how James stands when he's just standing comfortably, right? That if we're just standing there like that, how is he at a disadvantage? Right, his hands are in his pockets, so it's harder to get. So, and this is how she stands comfortably. Why would we not stand like this in a code? Why is this one not good?
Suspicious.
Yes, what do you have behind there? So we will all stand in a bladed position. We don't square off because that makes us a bigger target and more intimidating. So we're not trying to like Ryan, we're gonna stand at a three quarters.
I kind of want to do this shin flip.
Your hands are in front of you like this. They can see your hands. Your feet are shoulder width apart. Your knees are slightly bent. And
am I coming at you?
Not yet. No. And we're not looking right in her eyes, okay? Because that's intimidating. And if James is really trying to say, listen, can we please just go to your room? We'll do the shots and it'll be all over. If we're looking right at her, she is less likely to acquiesce because I'm looking right at you. Okay, you can do it. I'm looking at her midsection. I can see everything, but my eyes aren't locked on her. I can, if she lunges, I can go, but so it's almost like in the animal world, you drop your eyes as it's like submission. We are totally in control, but we're letting her have that slight upper hand for her. I won't be. You know what I'm trying to say.
It's like children, when you stare them in the eye, it's like as the parent and you're staring them in the eye, it's kind of like, go ahead, like you can have like, it's almost like a duel. So
Yeah.
it's like you're kind of averting your eyes, but you got the eye on the
Right.
situation.
So these two are, they're the ones that are looking at each other.
Yeah.
So okay, so I'm making eye contact.
You're making eye
with
contact
somebody.
with him, but we're not staring at you. One other thing that can happen right here is Mackenzie, because of that earlier effort, and we're right at that moment where it's almost hands-on, Mackenzie can say, Lexi, you can see and feel what's going on here. Nobody wants this. You know what? Let's just go to your room and have this be over. And then she can start to move and again, use motion. And if she follows, so now Mackenzie has given her an out in this situation. She's given her an out. So now she can just walk. And if she follows Mackenzie to room 20, we've scored.
But what if I lunge at Mackenzie?
Mackenzie's going to stay a safe distance away, and then we're going to come at you.
Nice. I kind of want to try.
So All right, so we brought this right to that instant where hands-on. We're gonna pick this up. All right, you guys shall sit down. Thank you. Thanks. We're gonna pick this scenario up when we do the hands-on to go from that safe distance away to engaging her. So I'll meet all of you later. Any questions or statements about that whole process of, engaging, de-escalating, questions? Page 81 just actually refers to a lot of stuff we just talked about. You want to have that one leader, so James would be the one running the code. You do not want a whole bunch of people talking all at the same time. That leg length away for protection. Protective posture is that bladed position. Hands-on is the last resort. Interfering in a code. This is another quiz question. It's another all the above. You do not want to have people interfere in your code. It adds an additional people or possibility for injury. It adds people to the fight, increases the opportunity for further escalation, and suggests that there's no teamwork. Interference in the code can come from anywhere. It can be other patients, like in Care Team 5. You'll be dealing with one person, another patient is going to try to take up for this one. It can be other staff members, doctors. I've had to pull ER doctors off of patients because they got spit on and they go after the patient.
Someone coming out of the bathroom and then they're like right up in the action.
Yeah, or the whole voyeuristic. They're all like, "What's going on? I'm hearing voices." So just like we had a doctor on our adolescent unit. He no longer works here. He didn't renew his contract. And that's when child psychiatrists are like rare as hen's teeth, and we I'll tell us quick. So do any of you remember Tryon? It was out like in Johnstown. It was a juvenile felon lockup. So it was mainly from downstate down in the city. So these are people who have rape, armed robbery, assault, murder. It was a locked facility for juvenile offenders. We had this girl, and she was big. She was in my height. She had abused, horrifically in every way you can imagine. Had developed this, and she was just angry at the world, angry at everything. And her gig was to tear off the bottom of her shirt and tie it really tight around her neck to the point where it would take her life left unattended. They didn't tell us that. We learned that on our own. So she does this. She's on the adolescent unit. So they call the code. We have to go in. We make a plan. A bunch of guys go in, and you hear crash, bang, thuds, all kinds of stuff going on in the room, and then they all come running back out. And we used to have a security officer play college football. Yeah, he's like really tall. And he's like, "Woody, oh my God, I never got hit so hard in the field, and I just got hit there." So we make another plan. More people, and they go in, and we get her on the bed, and the nurse goes in there, and they cut the thing off of her neck. And this young woman is just fighting. I was on the legs, and she was tossing me around like I was a rag doll. It took all of us to get this thing. And doesn't the doctor order an IM, and he ordered 5 of Zyprexa? No. Which, for those of you who are familiar with meds, is nothing. So he orders 5 of Zyprexa, and he comes in. All of us are like getting tossed around. He's got his little cup of coffee. This is bad. This is bad. You should not behave. Talking to the patient, you should not behave this way. So he leaves. We get that 5 of Zyprexa. So he comes back in, and he's like, so the nurse, Lindsay, she's a new nurse, but really, really good with the kids. So she's got this cold washcloth. She's talking with her. She's still wrestling, but she's trying to calm her down. She's doing a good job. Doctor comes in. This is better. That- Yeah, right. There's not a brain cell in the room that thinks letting this kid go is a good idea. But now, the doctor, is now getting in a power struggle with the nurse. So the kid's feeding off of this. So now she's like, yeah, let me the fuck up, the doctor said. So now the kid's getting more amped up because of what the doctor said in everyone's presence. And now he's getting angry with the nurse because in his culture, he is a doctor talking to a nurse, therefore she should obey. He is a man talking to a woman, therefore she should obey. And he's older and she's a younger individual. She should obey. So, I mean, as the seconds tick by, he's getting more and more angry, yelling at the nurse to let this kid up, because now he's created a power struggle in front of everybody. So poor Lynn.
Yeah.
Code gray stat on nothing. Yeah. So fortunately I was there and I was like, doctor, thank you. Well, I had to because it was getting worse and worse. And the kid was playing it. Oh, she was playing it big time. She was getting all amped up again. Doctor, you know what? She just had her IM. So I think we'll just hold her for a little while till it kicks in. And so I had to stroke his ego, give him an out so he could leave, maintaining his inflated ego. And so I guess the point of it is, if you see that kind of situation going on, don't be afraid. Somebody like say a cop, somebody who's in the hierarchy of things, you think, oh, I can't talk back to them. Say something. Don't let them do something inappropriate that is going to cause harm to the patient or cause harm to us. All right. And if there's a mess, we'll take care of it afterward. I've had doctors write me up, call me all kinds of names, because I told them she's 14 and you can't restrain her at 4 points because she won't talk to you. I mean, it's just the most asinine. All right, codes now I'm just hitting chunks that are not always connected. Also with codes, have you guys, have you seen Rick and Cargo, the K9 team? Well, you have, yeah. So we have Rick Rhodes. He's one of the supervisors in security, and he has Cargo, which is our K9. And they patrol the hospital, and they occasionally will go to codes. A K9 team, a dog, is a far more of a deterrent than a gun. A lot of people are used to seeing guns, but when that dog shows up. So what Rick wants is if he shows up to a code, it's usually like, in the ED waiting room or the hallway or whatever. He does patrol the ED, patrols all the public spaces, doesn't go on the medical floors. If there's a code with Cargo, don't leave, stay there, but step back. Rick and the nurse will decide what to do with the situation. And Rick just wants a zero margin of error. I mean, actually Cargo is very, very well trained, highly trained. And actually he trains with the New York State Police and their K9 teams, and Cargo outperforms the state police, which is pretty cool. So low risk, high safety, wait for instructions, and go from there. I watched the video of this code. We had a guy, it is not illegal to bring a knife into a hospital. A gun, yes, a knife, no. And he had a knife strapped to his belt, pretty good size. And he was yelling and screaming, something about the hospital, and we weren't doing anything right. And he's yelling and screaming, threatening. So he's on the first floor. There's the ICU, that stretch of windows, and the gift shop, and then the front entrance. So he's like by the ICU and the windows. Call the code gray. And Rick, who's in the C building, is coming down the hall. And you can watch the video. There was no audio, which watching it was good enough. So Rick's coming in the hallway, and the guy's like, I ain't afraid of that dog. I ain't afraid of that dog. He's getting faster. Faster. And Rick, that's what you saw, that's what we were saying. So he goes all the way past the gift shop. I ain't afraid of that dog. And he starts. And we had called the cops.
Out the front door.
The cops, we had called the cops, and they were sitting at the front door with the back door of the squad car open. I ain't afraid of that dog, and he jumps into the back of the squad car. So, very, very effective. I love telling that story.
It doesn't show at all.
Yeah.
I had a question, when code grade is called, code grade C3, whatever, who's all that's actually saying it, like, is it like kind of over the PA speaker? Or whatnot, who is it, like, I'm just curious. Who is that? Yeah, like, it's not always.
It's a little person we have chained in a room. Okay, good question. It comes up later, but I'll say it now. So if you're the one who has to call the code. Wow. Okay, so if you're the one who has to call the code on the landlines in the hospital, you dial 911.
Okay.
Not on this phone. And don't dial 911. That will get you the police. If you dial 911 on the hospital phones, it goes to a dedicated line up in the operator's office, and they will pick that up. And what you need to know, I forget what their initial saying is, but then you just say code gray Alpha 6 hallway, or code gray Edward 2 202, or so. Say where code gray, say where it is, and say it slowly, and say it twice. Because if you're, remember, your adrenaline is flowing, and if you say code gray, Charlie 3 hallway, and hang up, if they didn't catch it, they don't know who to call back. So say it twice, say it slow. Good question.
Thank you.
Page 83. So if you're doing a hold and they're struggling, these are some things to watch for. Cardiopulmonary distress, flaring nostrils, grunting, rapid breathing. If you notice some of those things, you gotta, tell the nurse, hey, we got a problem here, whatever. Neurological, so say you take somebody down and they hit their head, and then all of a sudden they're starting to vomit, they wet themselves or whatever, seizures. We gotta make sure that, oh my God, we get the medical staff involved. Musculoskeletal, you gotta watch, in the midst of these things about how you're holding things, how you're holding arms and that kind of thing. And lastly, psychological. Yes, that people will be upset. Trauma survivors could be having a hard time. You will hear, you're hurting me, I can't breathe. Do check that out, because if somebody truly can't breathe, the last thing they're going to say is, I can't breathe. So check it out. Since the George Floyd thing, we could be standing this far apart. They call the code, oh, I can't breathe. It's like, God, I'm 10 feet away from you, stop. So, but do check it out. We had this security officer years ago. I don't know how I got the job. He must have been somebody's nephew. Skinny little dude. And there was this patient was saying, my arm. And I looked over and he's squeezing it. He was like the most upset, worked up person in the code. And he was squeezing the arm. They were like digging into the flesh. So, and he had a thing about the legs. The legs had to be like perfectly straight. That's the only way the legs can be. Not like this. Oh God, no. Because then he'd be like pressing on the knee. It's like, geez, you idiot. So, but because if that patient is saying something, check it out, because it could be that a staff member is doing something incorrectly. Page 84, positional asphyxia. The short of it is, when we restrain somebody, we restrain them on their back. If we go down sideways, however we go down, we roll them over on their back so that the airway is open. Even if they're on their back, if they have, a big gut, that can press up against the diaphragm and they can still have a hard time breathing. So do pay attention to the, how they're positioned. And also cervical injuries. We can't hold the head. It's human nature. Someone's like trying to bite or spit and they want to like hold the head or hold the head, so we can't do that. It's too easy to hurt the neck. And if they're thrashing and you're holding the head, oh God. So, and a lot of people do it, you know, when people are trying to lash out or bite or spit, people want to, you know, do something with the head, but they can't. Special needs population, like we said, people with intellectual disabilities or autism, if they struggle to understand things cognitively on a good day, when they're worked up, it's going to be even harder for them to follow directions because, you know, they don't understand. So we have to pay attention to that. Other populations, and again, like if we do say we have a code on a medical floor, we need to know what's going on with them. You know, neurologically, you know, have they had a stroke? Are they there? They just had a hip replaced, and so we have to be really, really careful. Fragile cardiac patients. So the nurses should let us know as full responders what's going on with the patient so that we can be mindful of that. That's now a lot of this has like organizational policies. They're all on the internet. So if you're somebody who really wants to know what the policy is, you can certainly look those up. I'm not going to go over those with you. Oh, this is page 89 is what we just talked about. So I was down 911 to call the code. Page 90, code gray talking points. We've really covered all of this. Yep. Yep, we already covered all that. Code gray in the police. On the medical floors, sometimes we do have forensic patients, either from the jail or they have a charge on them. And so cops, there's usually 2 cops sitting with them and they're handcuffed to the bed. If we have police officers bringing someone in to the emergency room or to Care Team 5, we need to work as a team. We all serve the community. We had a couple of night nurses in the emergency room who almost single-handedly destroyed our relationship with SPD. They had the mind, I don't know if they had a chip on the shoulder with regard to officers or what, but they would bring a patient in cuffs, and the nurses were like, this is our patient now, take those cuffs off. You know, they shouldn't be in cuffs. This is a hospital. And they would just give the officers a hard time. And the cops would often be like, this guy's just playing possum. He's just standing here. He looks like, but as soon as you take those cuffs off, all hell's gonna break loose. No, they have to come off. They don't pay. So it got to the point where the officers would bring them in. And if they pulled that, they say, we'll take them off. But when they start to assault you, we are not gonna help you. So if they go with what, and they might stay calm while they're with us, or in Care Team 5, if they're in cuffs and it's an iffy situation, you can bring them from the entrance of Care Team 5 into the restraint room and have the cuffs taken off there, so that if they are doing that, we can just, you know, go right straight into restraints. Yeah. 92. So if someone's trying to run away, on medical floors, patients can sign out and AMA, against medical advice. If they're there on an involuntary status, like they can't leave legally, like say someone overdosed and now they're on a medical floor, they've stabilized medically, but psychiatry hasn't cleared them because it was a attempted suicide, and they're trying to leave. If they're trying to force their way off the unit, we do call the code, and we have to make sure that they stay. Happens in the ICU a lot too. They recovered from their overdose and now they want to leave if they can. If they happen to, involuntary patient happens to get, you know, running through the hospital, we would go and apprehend them. If they get out the doors, we have to pull up, because if they're running, they've gotten out of the hospital and we're chasing them and they get hit by a bus and we're pursuing them, they'll come back on us. So you have to pull up. We'll just call the cops, do a pickup order. Sometimes we'll have the security officer follow at a distance with the radio, talking to the police to know where they're going. And just like a wounded animal, people who are running away from the hospital, they will run out. They typically run down Knott Street. They'll run downhill and they'll turn on Wendell. So they'll go downhill, and the first opportunity they get to get off of Knott Street, they will. So if you're the one who has to go, say somebody's out there, and they put you in the car or whatever, that's like the first place. Or they'll go down to Ben Franklin and go that way. So just, so you know. What were you gonna say?
I just had a question, so if I wanted to respond to a code on C3, how many people is like too much to where it'd be overwhelming to, to try to help, said waiting nurse station C, it's I feel like is there a number where there's too many people that would be there that we should
It's strictly case by case.
Okay.
If you have too many, the nurse can send some away, or that having too many in line of sight of the patient can be a problem. So you have, like I said, stay out of the line of sight, stay in the hallway. Or if the code is going on for a while and you have a lot of people and you have 4 security officers, okay, so we have plenty of unit staff. Let's dismiss 2 of the officers because they have all kinds of stuff that they have to do. So 2 of the officers can go and more policy stuff, inpatient policies, outpatient policies. Jump to page 99. Oh, we are sitting pretty. Okay, let's do like we did before. Can someone read page 99 for us?
Assumption, restraints keep the people we serve safe. Reality, 50 to 150 deaths occur each year nationally due to seclusion and restraint. At least 14 people died and at least 1 has become permanently comatose while being subjected to seclusion, restraint from July 99, that's trying to say, right?
Yeah.
July 99 to March of 2002 in one state alone. Rick, age 36, of Stockton, died of cardiorespiratory failure and extreme agitation in the county psych health facility. He had been wrestled to the floor by 8 staff and bound in leather restraints. Crystal, age 16, died at a psych hospital on February 5th, 1999, after being restrained for 30 minutes, face down on the floor with her legs and arms held. Crystal suffered respiratory and cardiac arrest. Tanner, age 9, had his leg broken on the first day at an Iowa program with staff physically restrained him. After surgery, he returned to the program with a walker. His leg was later broken a second time. 18 months after admission, Tanner died while being restrained in a routine physical hold. He died of suffocation. He was only 11 years old.
So yeah, so these are people dying from improper restraints. And actually it happened in Albany Med, what, 2 years ago now? In their emergency room. And this one here, because those examples are kind of dated. This is from not this July, but last July. Girl 16 dies during restraint in an already troubled hospital. I won't read the whole thing, but it's the lead is the charge nurse found Alexis Yvette Ritchie alone in a small room, the SSM DePaul Health Center, motionless and sprawled face down in a beanbag. So what had happened was she had a behavior. They restrained her face down in a beanbag. She struggled more. They held her tighter. She eventually stopped struggling. So they let her be, left her laying there face down in the beanbag, got up and walked away. And she lay there dead for 12 minutes before they realized it. So.
Obviously, protocol's not being followed. I mean, you have
Oh,
to do
exactly.
initial life.
Exactly.
You have to do
That's
15-minute checks.
that's what I'm saying.
That's
It's
just face down in the beanbag.
people doing things that they're not supposed to do. We'll skip that one. Can someone read 101 for us?
Assumption, restraints are only used when absolutely necessary and for safety reasons. Reality, Andrew, 11 years old and 96 pounds, was crushed to death when 2 MHAs at Elmcrest Psych Hospital sat on his back. His offense, refusing to move to another breakfast table. Edith, age 15, suffocated while being held face down after resisting an aid at the Desert Hill Center for Youth and Families. Her offense, refusing to hand over an unauthorized personal item. The item was a family photograph.
So there's 2 kids dead because of power struggles. So I guess I really don't need to say it anymore. That's just Page 102, assumption, I have no personal or legal responsibility for an outcome of a restraint. Reality, staff can be personally charged with and arrested for assault or other progressive offenses if found that improper techniques were used during an intervention. I'm not going to read the rest. These are all excerpts from local papers back in 2007 when the 13-year-old boy, Jonathan Carey, Jonathan Carey was killed on an outing by 2 OD HEC staff. They use skip. Some of you might have been familiar with that. That's where they take it's usually from children. So they take the kids' arms, they cross them like this, and then they grab the arms from behind and they kind of do a basket hold. They were on an outing in a 15-passenger van with the bench seats. And rather than do the hold properly, they laid him over on the bench seat with his back against the bench seat, and the staff member sat in front of him, and then it just pushed back. So the kid was pinched between the seat like this. And he fought more, he pressed harder, but Jonathan eventually stopped, and he did die in the van with the other kids that were there with him too. And just to make matters all worse, once the staff realized that they had killed the kid, they drove around for another 2 hours because they knew they were in trouble.
So for all the other children on the van?
All the other children on the van with the dead kid. So obviously they, went to jail and, manslaughter and child abuse registry list. Now, I don't want to scare you because things do go wonky and we have to improvise until we can get things under control. And we will have your back if something goes. We had he's now moved on. He's doing other things now. He doesn't work at Ellis anymore. We had this guy, Shawan, tall, really muscular, worked out, so big broad shoulders, narrow waist, muscles on top of muscles. Very soft-spoken, really good with the patients. In fact, I wanted him to be an instructor, but he was just kind of shy. He didn't want to do it. Man, teach this a little bit. Because he could do it very well. He just wasn't comfortable teaching. So he was on a one-to-one with a guy who was bipolar, we'll call him Bill, who was also really big, but big and soft, big, just big guy. His fixed delusion was that he had discovered these aquatic astrological signs in the waters of the heavens, and he was going to publish this and make millions of dollars. He's on one-to-one because he's aggressive, he's huge, and unpredictable. It was a Saturday morning at 7:30. Where Danielle is sitting, that's where Shawan was. So the psych bedrooms, there's the door, A bed, B bed, wall, bathroom door. Bill comes out of the bathroom door, engages Shawan right in the eye, and has the transient delusion that you are reading my mind and you're going to steal all my millions of dollars. So Bill runs across the room and hammers Shawan in the face. Literally, breaks his, cuts his foot and knocks him right out of the chair, which is really something because Shawan. So now Shawan, he's the male tech on, there's a female tech, 2 nurses. It's 7:30 on a Saturday. All the patients, if they're up, are just like wandering around, like, where's the coffee? And so Shawan's like, what the heck do I do? We don't restrain solo. This came out of nowhere. I got to make a decision. Do I just let him go up in the unit, but is he going to start assaulting more people, or what? So he said, I made the decision to wrap him up, start screaming for help, and take him down. And that's what he did. And when he went down, Bill got the wind knocked out of him, but then went right straight into respiratory arrest. So it was code gray, then it was code orange, but now it's rapid response, and then code blue within 4 minutes. So, of course, every regulatory body in the state is just salivating to get us in trouble. We almost killed the guy. And so they interviewed him, me, everybody. And they interviewed Shawan, and they were just like, Shawan, do you do solo restraints here? No, we don't. well, then why did you do it? So he went through the whole thing about why he made the choice he made. And we had full confidence in Juwan. He's a really good staff member. He did what he needed to do as far as keeping safety. So we had his back, paid time off during the investigation, attorneys, working for him, the whole 9 yards. And he ended up being completely exonerated. And the only corrective action that we had to do was he took this class again. Because he did everything right. He did everything he could in that moment, in that situation, to handle it as safely as possible. So don't worry, if you're doing what you're supposed to be doing, Ellis will have your back, even if things get messy. Page 105. A manual restraint is when we're actually doing a physical hold. I'll show you that later. Mechanical restraint is when we put somebody in 4-point restraints. I'm going to show you that in about 10 seconds. Chemical restraint. I gotta explain this one. So the phrase chemical restraint is literally when somebody is like in the ICU and we intubate them, they're in an artificial coma, intubated. Okay, that's the phrase chemical restraint. So nurses, if you have one of our travel PAs or a doc or something, so you have a code gray and you get an IM order from them. It's either an IM for agitation. That's what that would be, an IM for agitation. But you'll have some of these doctors that don't know will say they order the IM for chemical restraint. Do not let that stand. The term chemical restraint automatically triggers a high level audit. And when they put it in wrong like that, it's gonna go, somebody's lying. Somebody didn't do what they were supposed to do. Because chemical restraint is a big deal. So that's only in the ICU would that even be considered. It wouldn't happen anywhere else. Seclusion is involuntary confinement. A lot of people think seclusion is locking somebody in a room. If you confine somebody involuntary, they can't leave, that's ultimately considered. Now, so if, like, say, Lexi, you get to work on the adolescent unit, say we have in October, and some kid, Johnny, does something. The way you would document it is Johnny took a voluntary time away in his room. Because that's it, Johnny, go to your room for half an hour. You can't do that. So you're sending the kid to the room. That means that he's under the belief that he's involuntarily confined in his room. He took a voluntary time away in his room. Med-surg restraints are those white with the ties. You know what I'm talking about? Behavior restraint, that's like a behavioral plan. That's what they do. Okay. So going on a field trip, ladies.
Like the magic school bus?
The magic school bus. Wheels go round and round. So yes, we're gonna go down to the lab. I guess we have to wear a mask to get here to there. But yeah, so we're gonna go over the doing restraints.
I don't know where you are either.
You want my student loans? Go for it.
Oh, thank you. Thank you. Yes, ma'am. Okay.
Your style, I know.
Used to do it all the time, 3 up into the table. Where the
Yeah, I didn't see them.
Okay. On page 108. We have there's a lot of, information that's in here, but the main things you need to know from this page are that. So nurses, if you make the decision to put somebody in 4-point restraints, you can make that decision. You don't need to call a doctor to get the order first in order to do it. You make that decision, patient's going into 4 points. Then you call the doctor, say we had to restrain them, they're at 4 points. We need the order. So in addition to that, during the day or that doctor needs to come and see that patient within 30 minutes. A face-to-face has to be done within 30 minutes for the doctor to assess and make sure that patient is okay. Do call that doctor for that face-to-face as soon as you can. If you wait till minute 28 of that 30-minute half hour, the doctor's going to be really pissed at you. So just make sure as soon as you get that whole thing done, call the doctor to come and do the face-to-face. Adults over the age of 18 can be in restraints up to 4 hours. If you get to the 2-hour mark, which is rare, but if you get to the 2-hour mark, you need to call the doctor and let them know that the patient is still in restraints. You don't need a new order or anything, but it's just a call to let them know that they're still in. Under 17, it's back to 1 hour. It used to be 2 hours. It's under 17, it's 1 hour in restraints, and then we have to let them know. And a lot of the rest of the stuff talks about debriefing, we already talked about that. Page 109 is another quiz question. So you have those two right-hand columns, behavioral restraint frequency and med-surg restraint frequency. The question I think is, how often do you have to check somebody when they're in behavioral health restraints? It's every 15 minutes. So med-surg doesn't have as high standards. It's 30 minutes, sometimes 2 hours, but with psych patients, it's every 15 minutes. More reminders, 4-point restraints. So page 110, we just talked about all of this over in the other room. The next page, 111, is the letting go process. We already went through that in the other room. Lesson plan 10 talks about the debriefing. I actually tucked the debriefing in here. Remember that whole thing about the 2 different sheets and is everybody okay? Okay, that's what this whole lesson plan is. It just fits better here than talking about it at the end. I'm all the way up to 124. So I know some people have written in the answers, but we'll review them anyway. What does TEAM stand for? More, yes. SOS. Self, others, and surroundings. Q-tip. Yes. Get yes is that thing there. What is number 5?
90% of our
clients have a history of trauma.
You said it's
Bingo.
higher today, no? Did you say that? The statistics are higher today.
To
Oh,
my
no, I
understanding,
thought you said that, sorry.
no, to my understanding, it's still about the same. It's still very high like that. What's number 6?
20%.
20% stronger.
20% stronger.
Yes. Leave your attitude at the door and put on your game face. Okay. Now, page 124A. Let's put it all together using case studies. When I took this class back in 2008, there were 2 instructors. And they thought they were God's gift to teaching. This class is supposed to end at 4:30. It would run till like 5:30 or after. And they would, oh my God. And one of them was obsessed with her quote booty. And she would refer to her butt like 2, 3, 4 times during each class. And I'm like, you are so freaking inappropriate. And some of the active kind of things that they would do were just creepy. Can I babysit your son? Can I babysit your son? It was just bizarre. And then, so it would get to now, and so we're already at like the 4:15 mark. They'd break us up into small groups and have little case studies, discuss the case studies, then come back and present them to the class. Oh, if you hadn't experienced homicidal ideation before you took that class, I just leave it in here so you know what bullet you dodged. I mean, it's actually in the new material. It's not there.
But did these used to be hers though, like her, or these are all yours? Well, because someone put booty juice.
I know,
on
one
the
of
pages.
Somebody wrote that in there?
Yes.
I told you. I didn't know.
On our page, I showed it to her,
Yes, we
they
were
go,
laughing.
it's
That's
called the
why we
booty
were
juice.
laughing. Yeah.
And we
Oh,
started
yeah.
laughing, it was like written in here.
Yeah, I know. They were
Like,
so
yeah.
inappropriate.
Yeah, that's what I was like, did this used to be like used with them, because.
That's why we just.
Oh, yeah, she had one of the old binders. Yes.
Yeah. 'Cause one of them says like, yeah, that booty or.
Yes, she used to refer. It was.
Yeah, right here, AKA booty juice. With hearts.
People have been reading that for 14 years. You're probably wondering what the hell.
Part of the lesson plan.
That's right. Break out the booty juice. All right, we're done with the binder. Now, we're gonna have to get creative here. Because we can't go use a large class because our students. So I think we're gonna have to work together here. I think we'll have enough room. We can leave these tables as is. We need to take these 4 tables and I think like spin them so that they're parallel against the wall. And then we'll have a big aisle here and here. So if you guys could work together, spin the tables. Actually, that back table, just shove that against the wall. And let's spin these 3. That's good. That's good. All right. Now let's just take these chairs and just shove them. Okay, so what I'm going to need for all of us to do is we have to break into dyads, a group, we need to. I want you to find somebody who's about the same size and with whom you're comfortable with physical touch. Okay. And actually trying to stay in the same gender is usually good because of what we're going to be doing. So, all right, so find a partner and then let's spread all out, use this entire space here.
I'll be with you.
Okay.
Okay, spread out. Use the whole space. Some people come over here, fill in the middle. Because when we're doing this and we're doing releases, like doing wrist releases, I don't want anybody like doing this, punching a table. So make sure you use the whole space and be mindful because it is kind of tight, so don't be smacking somebody else in the butt. So, your booty.
We're the same height.
Okay, so situational awareness, environmental awareness. If this is the patient who's getting escalated, I want to be between him and my exit. I want to try not to get myself caught with that's the only way out and the patient's right here, I'm stuck. So make sure that you have an exit as best you can. The whole PMCS model from OMH is all about keeping the patient safe. So a lot of these are focused in that way. We did follow this model because it is very patient oriented and keeps us at a high standard when it comes to being reviewed by other regulatory bodies. So I will show you a couple and then I'll have you practice them with your partner. All right. So grab my wrist. So if somebody grabs your wrist with one hand like this, that between the thumb, or I'll watch and then you guys practice. So between the thumb and the finger, that's the weakest part of the grasp. So they call that the gate. So you want to pull down between the thumb and the fingers. So I'm going to pull down hard and I'm going to back away. I want to back away with my hands up, put your fingers together. You don't want them like this. Last class, as I was saying, don't do this. The guy swung at me and it caught my fingers. I was like, thanks. So you want to be like this, all right? Because you can block whatever's coming at you. You always want to keep your eye on that person as you're backing away. You don't want to turn. I've got a bad Steve story on that one. Kid almost knocked me out. So you want to go like this, all right? The other one is if you want to reverse control. Like say this is somebody who's schizophrenic who's grabbing me because they're disoriented and scared, but I'm not sure what they're going to do. I can reverse control. So I'll start with my palm parallel to the floor, drop the thumb, lead with the pinky, grab that wrist, spin them and move them. Right? So.
I'd like to do that.
Thumb down, lead with the pinky. And this only works if it's right arm to right arm. Because if it's like this, that doesn't really get me anywhere. So right arm to right arm, and I can move. All right, so practice those two, please.
I gotta work with it. All right, so that's your oh wait, no, it's thumb down. But now how, like when I want to get so that's your right, here's my right, so I'll grab it like that. You're trying to push them. So wait, my gosh.
And then the other one, I don't really get. When you like wrap your forearm. Yeah. I don't think I'd be able to like think that quickly.
Yeah,
that's what I'm trying to say. I do this, my right.
So she just actually.
Oh, I think about you now.
I'm afraid I would snap or joint.
Okay, next one.
I got you on the first.
Next one.
Oh, no. I should be the patient.
Okay, so I want to go like that.
No.
And then kind of.
Yep.
Okay. So, if somebody grabs you with two hands.
Yeah.
You have two options. If somebody grabs you like this, remember, you want to go where the grasp is weakest. So right now, all of his hands, all four fingers are on top. So I'm gonna make a fist, reach underneath, grab my fist and pull down and hard using my entire upper body and back away. Or usually if somebody grabs you with two hands, it's like that. Now I have just thumbs on the top and all the fingers on the bottom. I'm gonna make a fist, reach over the top, grab my fist and yank up through the thumbs. Please, when you do that, you pull up, pull to one side or the other. Not it's embarrassing for the person, but it's fun to watch. All right, practice those two. Practice those two. Hands down, hands up.
Are you done with that? Why don't So now the two ones.
Oh, sorry.
Sorry, I just got You guys good? All right. Okay.
Yeah.
If someone grabs you by both wrists like this, you want to use your entire upper body. You don't want to go down. Again, it's the strength of the grasp. You want to go through the gate, past that thumb. So I'm using my entire upper body hard through those thumbs and back away. Go ahead, Rex.
So funny story about it.
Well, you know, you
I'm still full of everything.
No.
Okay, hair pulls.
Oh, you don't pull it back.
Now, if, when you do this today, in real life, you would lace your fingers and you're gonna push down really hard because you want to hold your hair to your head so you can't rip it off. But it also, when you push down hard, it hurts. Feel it? Feel it? Yeah. It hurts the knuckles a lot if you push down really hard. Then I'm going to shrug my shoulders to protect my neck, elbows in, and drop. It hurts the knuckles and it hurts the wrist. If they let go, great. Otherwise, I'm protecting myself just like a boxer would, right? Until help comes. Same for behind. Push down hard, elbows in, shrug my shoulders, drop. I still want to go back because it's safer back here. It's safer back there than stand, you know, because if I just stand right here, you can punch me like I can't see it coming. All right, practice those two.
Go in the direction that they are. You don't go against them.
Like I got you, like I'm trying to. I know, it's all kind of fun. So yeah, I got protect your face. Bring it down. Yeah. It's always like, anything always cover your face.
Okay.
Yeah.
All right, a ponytail rest. So I need a ponytail for someone.
Oh, do you need the holder or?
No, I need a ponytail with a person attached to it. Here. All right, now, if I get hold of that ponytail, I have a lot of leverage to her. Her job is to put both hands, base of the ponytail, both hands, grab it good and hard, same thing, elbows in, drop, try to get behind it. That doesn't mean I'm gonna let go. I probably won't. So she's now, pretend that's a ponytail. I mean, you have to pretend I have hair. So he's grabbed me and I'm gonna shrug my shoulders, protect my neck. I don't want my neck to be the pivot point like this. I want to keep my spine straight, tense up my body. So if he's yanking on me, I want to follow it. I want to just, do everything I can to protect my neck. And I'm with all of these, if anybody puts hands on you, you start screaming. Okay, now.
Start screaming.
So if I'm doing this, she's gonna, protect herself, grab that ponytail, do this. The first people on the scene need to literally come from each side and throw us both into a bear hug. So somebody just. I'm saying you're calling somebody, come on, over here, somebody.
Like together or would
Yeah,
one go to the
together.
front,
I'll show you
one
why.
go to the back?
But there, okay, that's
Sorry.
good. Okay, that's good. That's good. Okay, I know. Okay, release, please. You see what happens out here? I can really hurt her. But when you throw me in a bear hug like this, I don't have any leverage. She's much safer when we're all in a clump because I can't do anything to her. Now you release the ponytail, then you take me down. Thanks.
I just have like a really stupid question. So like if, let's say I have, if I have this, you grab that.
Yeah.
You're behind me, why wouldn't I try to hit
If-
it?
Yeah.
Like that, I would think would release you quicker.
It might. Again, with this model, we start with these first. And actually,
Okay.
this class has been like 3 steps ahead the whole time. It's been wonderful.
I'm sorry.
No, it's wonderful. So I'll say this part now, usually I say it later. With any of these, if you start to fear for your life, like you can't get away and help isn't coming soon enough,
Yeah, 'cause
you
I
fight back.
have low center of gravity. You're.
So, yeah, so if you fear for your life, you fight. So we're not asking you to give your life because somebody who's, antisocial or, whatever, or even if they're psychotic, you need to protect yourself. Start with these, and then you can move up if you need to.
Question off of that though, but then we get into the he say, she say part.
No, that's
There's-
on camera.
There's cameras
Okay.
everywhere. And the hospital is going to, the patient or the person will say whatever they want. The hospital's on.
They already say whatever they want.
They say, what I was gonna say, that's
Yeah, all sorts of crazy.
Yeah.
Okay.
So we all know that. And so do regulatory bodies. So, they have all kinds of stuff. I mean, they call the Justice Center all the time on bogus stuff. And they just, okay.
Yeah.
So that's ponytails. Bites. So if someone is, I'm not gonna bite you. I would say if someone is biting you, on the arm or whatever, one, you want to push into it. Just like with, in training canine, if you push in, if you pull, it's gonna trigger a bite. If you push in, and that's human nature, just you want to push into it.
And bite back.
Push
I did that
into
to
it.
my son.
Now, if they're biting you and they're trying to pull a chunk out, a bite's bad enough, a bite with chunk out is worse. Hold it to you. So you're pushing in, holding it to you. And in order to try to get them to release, you can plug the nose, like so she's biting me here, plug the nose or disorient. Put the hand right over their eyes. That works best with people who have like intellectual disabilities and autism. you take away their senses like that and they freak out, they're more likely to release. Okay. It used to be that you couldn't plug the nose, but OMH finally relented and said, you know, it's like for crying out loud, we're getting bitten. We just stand here till they let go. So we can include the airway. Chokes. So a choke from the front. Go ahead. So if somebody has you from the front like this, they've taught this through the years, they've taught this. If he's really strong, you're not going to break that stress. So you're going to use your entire upper body, your body mass, your bone structure. You have to put both arms straight up, not like this, straight up, and then spin hard. And get away. Pull from behind. Straight up, spin hard. And get away. All right, practice those two.
So what are you doing now? Choking. Yeah, I got this tight. They want you to put your hands straight up and then spin. Like that, so with that, like you're a ballerina.
Yes, because the hands go out like that.
Yeah.
You are precise.
So what if you're like that from
I'll
the
show,
back?
I'll show you that. Let's come. Let's come. Okay.
We'll be like.
Oh, yeah, by the time somebody, think about it, someone this tall for them to attack me, they're like this, I'm not.
That's why they have
faces here.
All right, so
Technique, it's not.
I'm like a little
size, yeah.
being choked up against the wall. So if you're being choked up against the wall like this, this is a real dangerous situation. You've got 15 to 20 seconds. If she's gotten like this and she pulls up the airway, I've got 15 or 20 seconds before I pass out. So this is where I say, if you fear for your life, fight back, because you don't have long. The move to get out of this, so say I'm against the wall. One arm over, one arm under, clasp them in the middle. It's not over here. The fists are in the middle. And you're from forearm to forearm, it's like one solid lever, fulcrum, teeter totter, whatever you need to think. It's going to spin on this axis. Arm that's underneath comes up hard. Arm on top comes down hard. I break that grasp and I follow that. So when I'm over, when I'm under, clasp, break it, spin. I'm not doing this, like people will do this and they'll try to spin this way. Doesn't work. You want to follow that elbow. It's messy, but it works. Now it's going to be kind of hard, but I want you to get against the wall if you can, because if you don't have a wall behind you, you just tend to back up and it's entirely effective. So go ahead and try to find a spot if you can.
Sorry, no, you guys sound.
Be the first thing done. So, oh, you go.
Well, you can't do the table.
No, wait.
Good.
Yeah. Wait, go like this, like go like that with your fingers, and then it's like this one goes up and this one goes down. Yeah.
You guys good?
Okay.
When I'm over, yeah. In the middle. There you go. Okay, next one. If somebody gets you in a naked armbar, again, another serious situation. The main thing you want to start with is you want to protect your airway. So to protect your airway, you have two options. Grab that forearm, pull down as hard as you can and tuck your chin. You're screaming for help. Another option is to pull down as hard as you can. And if you watch any MMA, you'll see that if they get into this situation, they'll take this hand here that's by the elbow, shove it up inside and put your palm on your cheek. So now my forearm is aligned with my neck. And so I still have blood flow and air to my head. So practice those two.
Do you mind?
And then it's like, oh, I see it.
Hard down with this. Slide this one out. So here she tightens up. Got it. Some protection. All right, now, like I said, if you're in that situation, and you fear for your life, you know, you're kicking, you're doing whatever, going for the nads, whatever. All right, so come around behind me. I'll show you this. This is what they say about how to get out of it. Not yet. All right, so if I want to try to get out of this, if he's not too strong, or he can get out of it. I want to tuck my chin, grab that elbow. So, see I have my thumb on the inside, grab the elbow like this. Let's back over here. So grab the elbow. I'm gonna take this hand. I'm gonna grab the thumb on his hand. And now be careful doing this with your partner today. You're going to be using pressure points. You're going to yank hard on that wrist, pulling it way out. So I'm going to pull down hard here, up here. Now I'm not trying to pull his arm over my head. I'm actually just trying to get a little bit of space so that I can pull my head out the bottom and go out the back. I'm going to pull down hard here, up here. I'm going to take this leg. It looks like a wrestling move. I take this leg and scoot out the back. I'll show it to you again. Grab the elbow, grab the thumb, pull down hard here, up here, drop my center of gravity, and scoot out the back. I'm not doing this because that just makes it worse. Okay, practice that one.
And then you have to grab
How about this?
Yeah.
See how I have to. See how you.
Oh, I forgot.
So I did this, yeah. That, see how I have to lean it? Yeah, but do you see how there's no way for me to not? You could be little, it doesn't matter.
Oh, yeah. Okay. Blocking a kick and a punch. So if someone is looking to punch you, you want to have both hands up. Don't just use one hand. Both hands up, and you want to shuck it off using their momentum against them and push it off that way. So they're ready. Even if I get ahead of it, I don't want to do this because why?
Don't miss an arm. Yeah, the other hand.
The
Head's
left arm's
unprotected.
coming. So the right arm's going to
The
go
left
that
arm's
way.
coming.
The left arm is going to go that way. Practice that. Gently. Other way.
Yeah.
So
So wait, we're basically just taking each other.
So now do the right hand. So like that. Okay, blocking a kick. If somebody's coming at you to kick you, obviously you want to try to deflect it. The last thing you want is to have that front leg down and locked, because it's pretty much common knowledge now. You want to take somebody down, you can take you hit that knee. So you want that front knee up. I mean, if you do get kicked, there's cushion there, it's soft tissue, it's a bruise, but not knee surgery.
Yeah.
So that's what you want to do. That's what. Okay, we're in the home stretch, guys. You're doing really well. It's only 3:15. The last piece we have to do is escort to a takedown and what a hold looks like. Everyone, actually, interns, you don't have to do this part if you don't want. You can. Itching for it. Okay, remember that scenario we did before with the mock code? So Lexi,
I'm just an intern, so.
oh, you're a half naked patient right now.
But I took my jacket
You were. We had Mackenzie was the tech. We lost on yours. Okay. So, well, that's right. So we've called the code. We have our responders standing here. She's here. Going over here, you're standing here. We're all standing in the bladed position. Now, we have actually, nurse, I want you to stand like over there. I need somebody else to be a tech or responder. Thank you. Very politely. Okay. So James has gone through the whole thing. Lexi, you can't leave. Unfortunately, you're gonna have to stay. You're being assaulted. You refuse the PO meds. We're gonna have to do shots. You can either take them willingly, or these people are gonna go hands-on, and we're gonna have to, you know, give you the shots. We might end up in restraints. So please, please take the shots. No effing way. I ain't staying. I ain't putting that shit in my body. So now James has made the decision. Okay, hands-on. Leading to this code, remember you might earlier said I talked about making a plan. Before we get to this position, we will have gotten ourselves, you know, together, and we say, okay, I'll take right shoulder, you take left shoulder, and you guys follow in close behind. So that's why I'm positioned here, because if I'm doing the right shoulder, I need to be here. If I'm doing the right shoulder and standing over there, I've screwed it all up. So we have our assignments. So you're going to be going there. I'm going to be going here. He's going to say, okay, hands on.
Hands on.
We don't.
That was convincing.
Yeah, I know, right? We don't go immediately because she's going to know. I mean, it's very hard to build in an element of surprise when we're all standing in the wide open. So we have to look for a break somehow to get from the safe distance to be able to get into here. All right, that's our goal, is to be able to get in here tight, hip to hip. Now, we'll wait. I guarantee you, when the hands-on doesn't happen immediately, she will eventually look at James, because he's the one who said hands-on. And when her attention, goes to James, and that look goes over there, I'm going to come in here like a shot. And as soon as I get in here, she's going to be like a half a step behind me to get into this position. So that position that you're looking for is you have your outer hand just above the wrist. You underhook the arm like this. This is down across our midsection. Our palm is out so that if we fall, that's what's going to catch us. Okay. So
What if I had my hands like, oh, you just.
we would still grab you.
I made it so easy doing that. I was wondering, you know.
So here, come this way a little bit. So what we're gonna be, I'm gonna show you two things, and this is what you're all gonna be doing. Is not everyone can be a patient, but everyone has to be a staff person. So the first thing you're gonna do is we're gonna do the escort. So we're just gonna go ahead and get in position, grab the wrist, hook, and now next thing we're gonna do is we're gonna hip into her as we're walking, and we're gonna go that way, and we're gonna go quick.
Which way?
Part of that
plan.
Alright, so when I say go,
Gonna
we're
confuse
gonna
Harry.
walk over towards the garbage can going really quick.
Oh, no.
Ready? Oh, don't go dead weight. Ready?
Me?
No,
I
don't.
wasn't gonna.
No, I've had people would do this, they go dead weight, you're not expecting
Why?
it, and it so screws up your back.
Well, now I want to. No, I'm joking.
So, ready, go. So what's that like?
Kind of fun, but as a patient, not fun. But as me, it was.
So the reason we're going quickly is she's gonna be on her heels like this. We're tapping into the amygdala. We want her brain firing. I'm falling, I'm falling, I'm falling. So all she's focused on is the fact that she's tipped and she doesn't want to fall. We're using that to our advantage. That's why we have to go quickly. If we go slow, she'll like, oh, I get this. Now, the second half of what you need to demonstrate is taking someone to it, going to a takedown. So. Now, I have to do this very carefully because I just had like significant knee surgery like 7 weeks ago.
Oh.
So I have to go really slow.
Walking so well. I guess not.
Um,
Oh, no.
So what we're gonna do is, we're gonna say go, and we're gonna go 3 steps for it. Go, 1, 2, 3, and we're gonna go down to that knee. And we're gonna, I just want you to, when we go down, to just like sit down.
Okay. Like sit or lay? Sit?
Well, you're gonna sit and then, yes, we're gonna.
So happy I came today.
So, ready, go. 1, 2, 3, down. So we're gonna go to the floor. When we get to the floor like this, we wanna sit on our hips. Underneath your shoulder blades, we're gonna sit like this. This is so that she can't kick us. Until someone comes and gets the legs. That looks like.
And this would be on a bed or?
No, this would be right on the
floor.
On the floor or no, or on the restraint bed that we were headed to. So you can do the legs like this. Do it like this. A lot of people will do, will be kneeling and do this. This is a lot more exhausting. So people are gonna have to like switch out because it's tiring. If you're gonna use your weight, which is more advisable, you put your forearm underneath their knees and just lay on their shins. So it's like doing like deadlifts or leg lifts or something. So it's really hard to get up. And, so.
I'll see you in the office Wednesday.
Hey, whoa, not done. So once the legs are secure, we will then never let go of, this wrist. We're gonna spin around, get perpendicular, pinch the elbow between your knees, you bend this arm like this. This hand goes on the meat of the upper pec. Here. And you want your arm, we're gonna lean in, your arm straight, and use your body weight. Don't try to press her into the floor. Use your body weight, lean in and look away. Go ahead, try again.
Look away.
You take away. Don't move again. So when you have the arms like this, there's no strength. So there's one last story.
And my legs would already be strapped
Well,
down, I
someone-
can't like,
Well, no, someone's either gonna be laying on your legs or
okay,
they're gonna be putting you in front positions.
okay, but you do legs first, so I can't kick you.
Doesn't. Now, remember that exit sign that was on that page of weapons?
Yeah.
A guy ripped that off the ceiling. Yeah, on the psych unit. They took him down, but when they took him down, his pants and his underwear came down to here. The guy on the leg is Jerry, one of our former security officers. So I'm standing right where you're standing. So Jerry's on the leg, and the guy's jumping right here. So there's a wall right here. So Jerry's like doing this. And I'm having the same reaction. I can't do it because it's a code. But I'm just like dying and I'm staring right at him. The guy was really racist. So, and so there's a person of color on this arm right up against the wall. So they swapped out and the nurse manager jumped in, who was wearing a scoop blouse and was well endowed, cleavage and jump. I tell you, it's burned in my brain. Seared. Yeah, the poor guy. And he knows that I tell this story every time. All right, we're in a home stretch. Wow, we're doing really well. So so you're all done because you just did the staff person. I need 2 staff and try to be around the same size. And if we keep the same gender, great, but if not, no big deal. So I need 2 staff and a patient.
Yeah.
So who's who? Are you true staff? Okay.
Sure. Yeah, and we're in the same department.
Yeah.
So here we are, we're doing this.
All right. So the first thing I want you to do, slow motion. If you're a patient, do not go dead weight. So just go ahead and get in position. So grab the outer arm. Tuck across your waist. Good. Good. She's got her palm out. This palm goes out. Good. Now, so when I say go, I want you to escort her to me going good and quick. Ready, go. Good. And also, if you think of it, hip against where she go. Okay, go back. Okay, same thing, but go 1, 2, 3 down and then stop when you hit the floor.
All right. So now do we just wait for like the nurse to say, and go? And then.
Well, yeah, but we're just practicing. So go ahead, get in position. And now it's going to be go 1, 2, 3 down. So ready, go. 1, 2, 3 down. Very nice.
That was very
Oh,
smooth.
wow,
Oh my God,
geez.
very smooth.
So the leg is secure. Jeez, but, oh wait, you want to come up and get perpendicular, pinch that elbow between your knees. So you want to come up and pinch that elbow between there you go. Arms nice and
1,
straight.
2.
Go ahead, try to get up.
No.
All right, good. Nice job, you two.
Thanks, guys.
All right, 2 new staff and a patient.
Like literally the 2 smallest in the
I know.
department.
I'll get it. Oh, watch this one. She's. All right, go ahead, get in position. Grab her wrist. Underhook, very nice. Hip in tight. When I say go, bring her to me. Ready, go. You guys couldn't see it, but people like. Okay, next one. So it's go 1, 2, 3 down. Ready, go. 1, 2, 3 down. Sit on sit on her hips so she can't get back there. First part. Okay. Now the legs are secure, so bring it around. It's the elbow between the knees. Yeah, hold that wrist. There we go. Arms nice. Very good. You're good. Excellent. All right. Who's next? Need a patient.
No, that's not gonna work.
Need a patient? Okay. So you're the patient. Who's we need a staff person?
We're gonna carry it.
Yeah, sure. I don't care.
Okay, get position.
Oh my God.
Ready, go. Good.
I'm definitely working for this happy hour.
Where are you going?
No, I was like,
That was a good follow-up.
Ready, 1, 2, 3, go. Go. 1, 2, 3 down. That's it. I'm trying to hack the neighbors. All right, so now she's. All right, spin around. Fix the elbow. Yeah, there you go. All right, nice and straight. Good. You're done.
Floor's concrete, my knees are old, I'm not going down hard.
No, not really. I suppose if they were fighting, but, okay, go ahead, get in position. Grab that wrist. Wrist
yeah.
there, underhook there, wrist here, good, good. They call it seat belt, so you are right across the front. And then this arm, this is out with your palm, in case you fall, that's what hits the floor.
Right.
Right. All right, so, ready, go.
Wait a minute.
I feel like you were restraining.
What am I supposed to do?
All right, no more Mr. Nice Guy this time. You're going down.
Oh, I'm scared.
Okay, puppies.
Traumatized.
All right, go 1, 2, 3 down. Ready, go. 1, 2, 3 down. Very good, very good. Sit on his hips. Don't let go. Okay, the legs are secure, so spin the elbow. Don't let go. Spin around. Pinch his elbow between your knees.
Never let go.
No, if you bring the other floor, pinch the elbow between your knees. You want to be up. There you go. Perfect. Thank you.
Hopefully we never.
Actually, that she just reminded me of, I think I said it earlier, but I'm not sure. We don't use our knees on anything. You don't kneel on thighs, you don't kneel on ankles, you don't kneel on arms, you don't kneel on anything. We use our hands. Okay, keep going. 2 new staff and a patient.
You guys know?
We're just gonna stay up here.
It's like, I'm done this already. Miss Sandra? Yeah.
Whoa. Nope. There you go. There you go. All right, you ready? Go. Told you I'm good. All right. Second half. Ready, go. 1, 2, 3 down. Very nice. Sit on his legs. All right, the legs are secure. So now you're gonna come up. Just bring the elbows up. Good, good. Pinch the elbows in the knees, arm nice and straight.
Easier.
Patient. You want to be the patient?
No.
Oh, we're gonna restrain Mike. Hey, Mike. Hey.
You want me to
Okay, what am I
restrain, so
doing?
put-
This?
You're in position. Now you want to be hip, tight. And ready, go. Good, good. Yeah.
He's like, yeah.
We're gonna talk about it in class next week.
Now he's ready for happy hour.
Everybody's welcome.
So ready, go. 1, 2, 3 down. Very nice. Sit on his hips. Okay, knees are secure, so come on around. Fix the elbow between your knees. Good, arms nice and straight, perfect.
That's it.
Who else need to be a staff person? 1, 2, okay, so we need another patient. Someone could be a patient again. Well,
All right.
so has everyone else been a staff person already?
Oh, wait, I gotta be a staff person, sorry.
Oh, I didn't do it.
You did? Okay, good. So you two will be in the next one. So go ahead, get in position. Ready, go. Bring it to me. Good. Yep. Ready, go. 1, 2, 3 down. Nice.
Oh my God.
Sit on his hips. Well, all right. So bring him around. No, really, no. Legs are secure.
He's flexible.
Arms nice and straight, use your butt. Good, good, good.
They would just stay on the hips until somebody.
they're
Until the legs are secure.
For sure.
But it's usually that we planned it so that it's like, the people get the shoulders and the people come in right behind the legs.
That's okay. I'm surprised I am too.
Yep. Really tight crush section. There you go. Ready, go. There you go. There it is. Ready, go. 1, 2, 3, down.
I don't wanna roll this right down. Yeah, I don't know how to do that very nicely.
That's okay. So she's on the floor. So you would sit on the hips until the legs, so we'll say the legs are secure. First, so spin around. Pinch that elbow.
Right.
This is gonna be here. That's gonna be there. Arms nice and straight. Lean over the top. Use your and look away.
They will spit in your face.
So everyone's been a staff person, right? Sweet. Okay, so that part is done. So now we need to carefully put this room back together. So slide these tables back the way they were.
I mean, watch your butt.
So just make sure they all line up with the one across the way.
What's your back?
There was an extra.
What's your back here?
Wow, this for a class this large, this is record time. You guys have been great. So the last two things, there's the quiz, so I will pass out the quiz in just a moment. While you're doing it, like I said, you can do it in groups of 3, 5, whatever, discuss it. And there's the evaluation. The only instructor that's here is me, Steve Wood. So you would rate, circle me and then rate me, there's questions. I go with that. There's also open-ended questions at the bottom. So yeah, this. Because I do catalog all the response and we do adjust what we're the teaching, like this, like the whole psych stuff. Like routinely, people are like, oh, that was really helpful because a lot of people still know that, and it just kind of gives them the framework. So if there's things you like, let us know. If you wanted something more of something, let us know. And then once you're done with these two things, you're free to leave. So. Actually. Yeah, do this, that, or this.
Does anyone have an extra pen? I just, I mean, you very unprepared. Well, if you don't mind, I also can Thank you all.
Did I leave?
So did he use it? I saw the moon and I was like, thank you.
Yeah, I was home last year.
You were close.
Oh, this is an evaluation,
Yeah.
right?
I think he just right over here.
Oh,
yeah.
Yeah.
That's why you're taking it, yes.
Any of you? Yeah. That's what I think. In balance. I think
You know what, why don't you guys talk out loud?
sorry, I'm like. Yeah, so crisis is not stress isn't.
Yeah, usually words are, as always said, they talk a lot. I would say that,
You actually are still there. Team members. Yeah. No. Right.
it's always not like. It's like, right.
I think we don't want to run solo.
Oh, we give.
Well, actually.
Sorry, I like read it and then it's like. No, I was.
Yes.
Yeah.
Yeah.
Oh, maybe. I'd say one reader.
No, it's saying.
You're not mentioning the ones where it's like, you don't want to block their way.
You don't want to.
And you don't want to use maximum.
You don't want to use maximum. So what leader and then getting myself. Yeah. True.
We retake it again. I mean, it's
I haven't
definitely like a
had,
fire.
I haven't had anybody tell this.
Yeah.
Yeah, but, I mean, this can technically and get all the other parental.
Don't pull away. Pull away from the, okay, don't pull away, right?
No, you don't want to pull away. Because then you can check out.
So it's A.
Yeah, that's true.
D, every 15.
I would say I'll go above.
B to teach.
15 minutes. Here you go. Major focus. Thank you. So they say.
All right, thanks, Liz. Yep. It's yours, you take that home. Yep. Yeah.
Yeah, I'm not writing
Okay. So try, you can try to.
Thank
you.
you.
I'm
done. Yes, exactly. Like a nervous.
Yeah, thank
you. Thank you.
You're welcome.
I texted, so I took the time.
Have a nice day, guys.
You too.
See you Monday.
See you Monday. Have a good weekend.
Thanks, you too. Like what you said, I've been on a lot of buses like this.
Yeah.
You are the best.
Well, thank you.
Thank you very much.
You're welcome. Glad you came. I have. Here's lots of firefighters.
Hello?
I mean, a lot of my background is shown development from trauma.
Again? Why?
So obviously, you know, you would make an application for somebody. Yes.
Where do you guys live?
Yeah, that's 45, 50 minutes. maybe.
This is very serious.
Well, one, if you can get him. I mean, if he wants to come in, you can just work on the there's almost nothing.
There's not much out there besides cows.
Trees and cows and
Yeah.
grass.
You gotta call me the name for.
Talking about where I live.
Thank you so much.
That's great. Thanks. Thank you.
The honor
You're
was
well done.
really,
Thank you.
yeah.
Thank you. So many trainings by uninspired people that end up being such like forgettable trainings.
Yeah.
And that was not the case.
Well, good.
Thank you.
I know there's not much out there.
Yeah.
My bank says it's gonna happen. Yes and no.
So we'll talk to him about it. And then we can.
I'm a joke bus driver. Yeah, it's gonna be so nice though. Damn.
Oh, yeah.
When was your last day? Any birthday here Friday? Or you guys just-
I'll be talking.
Okay, I'm gonna make sure I see you.
Oh, you will.
I meant I'm making updates, I don't know.
Yeah.
Do one later? No, she went for Val.
Well, yeah.
Val went
It's-
for Velvet.
And even if
I'm
it's,
also probably,
even if it's
uh,
trying to come up with a way to
Homemade, how do you do homemade? Basically just.
incorporate it, how to handle it when you're in the moment.
Yeah. I didn't realize that. That's centralized again. No, it's, I mean, I bet.
Most of them.
It's just burnt it.
Bye, thank you.
Take care.
Well, there you go.
Yeah, I just saved myself like 70 cents.
Well, now you know how to do it.
So that's, so it comes by honestly and do it. All right, and actually, you know, off the beat with the guy helps.
That's what I think it would be better.
And when he knows that I've been at the FBI training for the business stress,
I think you very well too.
that, you know, that kind of stuff, so.
What's the best way to find out more about psychodynamic?
It's, there's a network. It's actually called group psychotherapy. Psychodrama, sociodrama, and group psychotherapy. There's a network for that, so if you just see Google, that kind of stuff. And there's different layers of training. I'm a certified practitioner. And then the highest levels is what they call a TEP or trainer educator practitioner. So I can train to a certain degree, like anything that we would use in the hospital, action methods, stuff like that. I can train that kind of stuff.
What does the modality come out of?
What
What does the modality come out of?
Actually, it was developed by J.M. Moreno. And he was an extensive writer and just kind of developed it on his own. He was back around the time of Fritz Perls. Fritz Perls was, he did a lot of stuff like the empty chair and stuff like that. So, and actually Fritz Perls got it from J.M. Moreno. There was a real conflict between the two of them because Moreno was like a megalomaniac, just thought he was so much stuff. So yeah, like there's a training facility down in Hudson, which it has the original psychodrama theater, which it's in the round. It has a balcony. It's really kind of cool. It's really intense. I mean, initially psychodrama got a bad name because you get by somebody's cognitive defenses really easily.
Yeah.
So once you know the skills, you're inside and doing that primary process stuff. And if you don't know what you're doing while you're in there, you can cause more harm than good.
So it has like a psychoanalytic component.
Yeah. There's a piece of that.
Okay, yeah, I'm interested, I'm gonna look it up.
Yeah,
Cool.
yeah, go ahead.
Thank you for today, it's great.
You're welcome. You're welcome. Good. Glad it was useful. Take care.
I think he would respond well to you. There's a very particular person. I don't think he would respond well to a female. I think he needs a male, more of a.
Most cops don't. Even female cops.
Yeah, there's I think just sounded like, oh my God, like he's not even a year in. I mean, he's a year into like 8 months in from being on the road, but not since like he went to Schenectady Zone 5. He's already having issues and.
So he's in Schenectady?
Well, no, so he did 6 months of his training in Schenectady.
Oh, okay.
And now he is Montgomery County, he's the deputy sheriff. for
Yeah,
Montgomery
okay,
County.
okay.
So, even for the small rural area, the other day, he got a call for a lost horse in the road. But there's once in a while, those bad calls come in, it really hits them bad.
Yeah. Yeah, actually, I've got a female cop, she's no longer, she left policing. She was in the Saratoga County Sheriff's Department. Left there to become a social worker. So, yeah, she's so.
But so I will maybe see if he's interested. He said he would try at least. And he said, all I can ask you to do is try. Because he doesn't want to talk to certain people, because he's afraid of burden.
So there's ways around that, you know. I mean, that means he has a kind heart.
He does.
So.
Mhm. Whew. What can I do to help you? To unpack up all the
Oh no, that's
essays?
yeah.
You don't think I need a card? Like I can take one of those for you.
Well, actually, I've got a carrier and
Oh,
I'm just right outside the door.
Oh, okay.
So,
Perfect. Well, yeah, so thank you for today. I'm glad I was able to get it with you. So. Sharon, anything else?
I do that.
All right, you have a good weekend.
So you're leaving? Sad face. Under my nose.
Sad face, no.
That's unfortunate.
Yeah. And it didn't have to be, but. I don't pay attention. Shit happens. So.
Well,
I mean, actually, why wasn't the way some things were handled was done really poorly. And,
isn't that the illness way?
I was like, you know, addressing it and,
Nothing's fixed, being fixed.
well, yeah, and just leadership is changing, HR really changed. And I mean, there's just a lot of pieces, as in any situation.
Yeah, yeah. Well, you gotta do what's
But
best for you.
and actually, I wasn't even really, despite how things were going, and there was a plan, and it was kind of working out, but at the same time, essentially, I don't know, maybe like word got out or what, but anyways, I got recruited. I wasn't looking, but I got, you know, recruited to go to another facility, doing the same exact thing. And it's making a significantly more money.
Gotta do what you gotta do.
And the counter offer was
A joke.
in a word.
Yeah.
So, and just that's between us.
Yeah.
So,
That's okay, I don't know anybody anyway, besides people here.
so
Well, good luck where you're going.
you know what? I don't know how to turn off.
Well,
They've got this Zoom thing.
Oh, I think you just put that, don't you just put that on?
Is there an end recording thing or is it? Stop video.
All right.
That should be.
Because they were recording this.
Yeah, I don't. I heard that rumor. That's why I emailed you yesterday. I'm like, did anyone tell Steve that we're doing this? Because we're moving his room now and now I can't. Now I
Yeah,
already-
well,
I
I
already
did,
had this email saying that he was in 8. I said, now we're
Yeah.
having an email telling him that he's in.
I got a call
He's
yesterday.
in 14. I'm like, because I guess there's some sort of thing with that